Pleasant morning, dear all. We'll be starting in a short while. Good morning, dear all. Warm welcome to one and all present. We'll be starting in 2 minutes. Welcome back to day 2 of Horizon Unlimited, the virtual international conference hosted by Anu Dental College and Hospital, Muatupura, in association with Online Dentistry. A word of prayer and gratitude to God Almighty for granting us health and safety during these tough times of pandemic. Anu Dental College and Hospital, Muatupura is the 22nd among the private dental colleges in India as per the survey conducted by the Week magazine, and is also recognized as the College of the Year 2019 by the Higher Education Review magazine. We take pride to announce our recent achievement of being accredited a NAC B++ grade. This is the highest grade for a standalone dental institution. Our students are recipients of various funded projects under the coveted ICMR, the Kerala State Council Science and Technology, and the Tata Trust Scholarship. Horizon Unlimited, the virtual international conference, is hosted by Anu Dental College and Hospital, Muatupura, in association with Online Dentistry. Online Dentistry is a dental education firm that is celebrating its 13th year of establishment in 2021. With over 20,000 followers cross-platform and having successfully completed 500 plus webinars during the pandemic, it is a one-stop solution for all dental education requirements. Before we begin day 2 of Horizon Unlimited, let me thank you all for the overwhelming participation for yesterday's session. We had around 450 participants in the Zoom platform and over 850 views in the YouTube channel. For day 1, we had 2 eminent speakers, 2 great teachers, Dr. George Paul and Dr. Jiju George Baby. Once again, on behalf of Anu and Online Dentistry, let me thank you all for the participation. Without much ado, let us begin today's sessions. Today we have 4 eminent speakers for the forenoon sessions. Dr. Jose Paul will be speaking on the considerations in single tooth replacement by dental implants. Dr. Vivek Hegde is delivering a lecture on the tips and tricks in endodontics. Dr. Mohan Bhuvaneshwaran will be speaking on smile makeover with ceramic laminates. And Dr. Aparna Pandya will be dealing with the topic recalibrate and reboot. Today's opening session is in great consonance with the implant dentistry. We have with us Professor Dr. Jose Paul to deliver the topic considerations in single tooth replacement by dental implants. Audience, please note, kindly use the chat box for any queries and during the session. Before we commence the session, let me take this opportunity to introduce our esteemed speaker, Professor Dr. Jose Paul. Professor Dr. Jose Paul is currently the Students Dean and Head of the Department, Periodontics and Implantology, Anu Dental College and Hospital, Muatupura. He graduated from Vinayaga Missions, Shankaracharya Dental College, Salem in 1996 and completed his MDS from Government Dental College, Trivandrum in 2001. Dr. Jose Paul is the recipient of the Young Scientist Award from the Government of Kerala for his work on platelet-rich plasma in periodontal regeneration in 2003. He is a member of ICOI, the International Congress on Oral Implantologists, and has to his credits many indexed publications in various peer-reviewed journals, and is actively involved with several professional organizations like the Indian Dental Association, the Indian Society of Periodontology, the Society of Periodontists and Implantologists in Kerala, and Cochin Periodontist Society. Apart from being the invited faculty for multiple CD programs and national conferences, he is also the chief mentor of the advanced implantology course conducted by Anu Dental College. It is my pleasure to welcome Professor Dr. Jose Paul for the presentation. Over to you, Dr. Jose Paul.
Good morning, all. Thank you, Dr. Veena, for that wonderful introduction. Now we have a lot of people who have spent your time actually on a Sunday morning to learn something about dentistry. Today, without much delay, I'm going to speak something about implants. Now, what I want to ask anyone who is viewing this presentation is, if a patient comes to you like this situation, what will be your response? Now, he or she has lost one teeth, and what type of replacement are you going to plan for him? The question here I would like to ask everyone is, are you going to suggest an implant for this patient? If not, what is the reason why you are not suggesting that? Now, we have more than 50 years of documented implant research, and the data shows that more than 95% of implants are success. Still, a lot of people are reluctant to give implant as an option for these patients. What could be the possible reason? One is lack of training. Yes, the yesteryear dentists probably wouldn't have been trained, but now there are a lot of opportunities, a lot of courses that are available. Now, the idea of this presentation today is to sensitize you or introduce you to implants so that later on you acquire more knowledge and start practicing dentistry, implantology. At the same time, you might be referring some patients to an implantologist, or some of your clinics may have an implantologist visit. So this presentation will really help you to plan a treatment for an implant, and at the same time, you will gain knowledge as to what an implantologist is doing on a patient. So what I've done here is, we are going to discuss about these implants or treatment planning under 9 headings. Now, this is not at all a theoretical lecture. This is a typical clinical practical lecture with a lot of clinical photographs and conditions. So the first thing that we are going to discuss today is about medical considerations. Okay, if the patient is not terminally ill, he is a candidate for implants. But there are certain conditions which warrant special attention. And as Dr. George Paul was saying, India is the diabetic capital. You may find a lot of diabetic patients, but not all diabetic patients are contraindicated for implants. Now, if the patient has the diabetic status or glycemic level is controlled, then definitely you can go ahead with implants. And there are other conditions which affect the bone. Which are they? One is osteoporosis, parathyroid, hyperparathyroidism, or irradiation. So here there is some sort of osteoclastic activity which may have an influence on implant placement. But mind you, these are not absolute contraindications for implant placement. If you take special attention, you can do implants in these patients also. Now, the second aspect, that is a edentulous space consideration, is one of the most important considerations. Now, if you don't have sufficient space to place an implant, and more importantly, if you don't have sufficient space to place a prosthesis over the implant, there is no point in going or suggesting implants for these patients. So the basic idea that I want to give you is, what are the space requirements, minimum space requirements that are needed to place an implant and a prosthesis. So we are going to discuss this under different headings like width, height, length, angulation, and crown height space. So length is nothing but length is the distance between two adjacent teeth, while the width is the width of the ridge, and height is how long an implant that you can suggest in that particular condition. So first we'll discuss about the length. Now suppose if you place an implant, you're placing an implant, the minimum distance between this implant and your natural tooth should be 1.5 millimeter. So you need 1.5 millimeter in this side, and you need 1.5 millimeter on this side. The minimum diameter of an implant that most of the companies now give is 3 millimeter. So you have 3 millimeter diameter implant and 3 millimeter space that is needed on either side. So you need at least a distance, a length of 6 millimeter to place an implant. If you don't have that 6 millimeter, then don't think about implants. Okay. But if the span is more, suppose the span is more than 12 millimeter, you can always suggest, or it's always better to give multiple implants. But the thing that when you give multiple implants, the distance between two implants should be 3 millimeter. Now, what is the need for this 1.5 and 3 millimeter? Now, this is for the papilla to form. This is for you to give a properly contoured restoration. And when you give a properly contoured restoration, the patient can maintain it well. And if the patient can maintain it, that restoration will last his lifelong. So that is about the length. The second aspect that we are going to consider is the width of the ridge. Now, suppose if you have a wide ridge like this, now it's quite easy to place. But the problem is, whenever the patient is ready for implants, you often find that there is a deficient bone. And when you find conditions like this, it's going to be very difficult to place implants. But you can modify your treatment in many ways by means of advanced implant surgical techniques, where you can place implants in these conditions also, that we'll discuss in subsequent slides. So the minimum width, the minimum bone that should be there on the buccal or the lingual aspect after placing an implant is there should be a minimum of at least 1 millimeter. Then that means that ridge is sufficient. Okay. The next is height. Now you have different areas in the mouth where there are anatomical limitations. Now, in relation to the posterior aspect, as everyone over here, there is a maxillary sinus. And when a tooth is lost, what happens is the sinus pneumatized like that, and the height or the residual ridge height is reduced to place an implant. In relation to the anterior maxilla, you find the floor of the nose. In relation to the posterior aspect of the mandible, you find the inferior alveolar nerve canal. Now, the safe distance between the base of the implant and the nerve bundle, neurovascular bundle, should be 2 millimeter. Now, most of the implant companies now give a length of 6 millimeter implant. So considering 6 millimeter and 2 millimeter as the safe distance, you should need at least a height of 8 millimeter to place an implant in the posterior mandible. But again, there are surgical techniques by which you can avoid this inferior alveolar nerve bundle, bypass that, or by means of advanced surgical techniques, you can lateralize that. But in the posterior maxilla, even if the sinus is pneumatized, if you have reduced bone height, you still have surgical techniques by which you can actually lift off this cnidaria membrane and place an implant. That we'll discuss in the subsequent slides. Now, another thing is you should always place the implant parallel to the long axis of the missing tooth and perpendicular to the plane of occlusion. Otherwise, what is going to happen is you may need advanced prosthetic procedures to bring that tooth into occlusion. Second thing is there is going to be a lot of stress on the implant, and there may be crestal bone loss. Then you have now placed an implant. But when you look into that patient's mouth, there should be sufficient space to place the prosthesis also. And the distance that is needed for placing the prosthesis is known as a crown height space. And it is nothing but in the posterior teeth, it is the distance from the crest of the bone to the occlusal plane like this here. While in the anterior teeth, it is from the crest of the bone to the incisal edges. Now, what is the minimum dimension that is needed? The minimum dimension that is needed is 8 to 12 millimeter is the ideal dimension that is needed. Now, that is for the biologic width. Then you should have that abutment. Then for your space for the crown, everything, you need at least 8 millimeter to 12 millimeter is considered ideal. And anything above 15 millimeter is considered excessive. Now, when we look here, all these implants are placed at the same level. But look at the crown, height of the crown here, and look at the height of the crown here. Now, suppose the same amount of force is being applied on this crown and this crown. Now, because there is an excessive cantilever here, there is a lot of stresses that is going to appear on this implant at this margin here. And also, there may be a lot of stress on the screw here, and it may cause screw loosening or it may cause a screw fracture. So that is the importance of this crown height space. So these are the dimensions that are required to place an implant. All this while I was talking about the quantity of bone. Now here I'm going to talk about the quality of bone. Now when it comes to implants, it is not only the quantity of the bone, but the quality of the bone is also very important in determining the success of implants. Now consider two trees. Now this is a cross section of a rubber tree that is commonly found in Kerala. And this is a cross section of a teakwood tree that is again commonly found in this part of the country. Now imagine you are screwing a screw into this a plank of each of these wood. Now it will be very easy to place this screw into this rub wood, and it will be very difficult, or relatively it is going to be very difficult to place a screw in relation to this teak wood. So same applies. So, and you place a screw, it's very stable in relation to this teak wood. The same applies to implants too. Sorry. Now, Mish in 1988 has classified the density of bone from D1 to D4. Now, what is D1? D1 is more of cortical and less trabecular bone. And this is the type of bone you find in relation to the anterior mandible. Now, D2 is you have less of cortical bone and you have trabecular bone, but thick trabecular bone here. This is the type of bone you find in lower mandible, the anterior maxilla, as well as in the posterior mandible. Now you have this D3 type of bone where you have a porous cortical bone, and you can look at the trabecula here. The trabecular spaces are increased. And this is usually seen in the maxillary anterior, the maxillary posteriors, and the mandibular posteriors. And this is the bone which is least dense, very thin cortical bone. Look at very thin cortical bone and very large trabeculae. The bone with poor quality, which is mostly seen in relation to the posterior maxilla. And this is one of the reasons why many implants fail in relation to the posterior maxilla, mostly because the quality of bone here is not that good. Now, what is the treatment plan modification that you can do to improve the quality of bone? Now, instead of drilling the bone, if you can spread the bone to the surrounding, you can condense the bone, you can improve the quality of bone. Now here, if you look at this diagram, you just make one drill, and then with the use of instruments known as osteotomes, what you do is just condense the bone. You increase the size of the osteoma, diameter of the osteotome, and then you compress the bone to the surrounding area. Now you have latest addition to your armamentarium, a drill that is which causes condensation of the bone rather than drilling the bone, which is known as a denser burr. So these denser drills are really helpful if the bone quality is very less. Excuse me. The next aspect I want to speak to you is about diagnostic imaging. Now, when you look at imaging in relation to implantology, now in all aspects of your implant treatment plan, you need images. You need imaging for your pre-surgical implant planning. While doing implants, again, you take images, and then after placing an implant during the prosthetic phase, or after if you are given a prosthesis to look at crestal bone loss over years, again, you need post-prosthetic imaging. Now, you have umpteen number of modalities for implant, but the three things that are real importance for us is periapical and panoramic, which everyone knows. And with the advent of CBCT, implantology has become really, really easy. And I'll show you how implantology has become really easy with CBCT. Now, what is CBCT? In CBCT, you get images in all three dimensions. Now, imagine you have an apple like this here. This apple can be cut like this. This is a cross-sectional slice you can see. In 1 millimeter, you can cut slices like this. You can also cut slices in this direction also, in this direction also. So when you cut such a slice in relation to this area, you get a picture like this. So you get a picture where you have the teeth, then you have the surrounding bone. So any pathology related here, you can identify. And you can just take slice 1 millimeter apart, and you can look at different areas and look at extent of pathology also. Same way, you can cut an apple like this. This is not as an axial slice. So in relation to a mandible like this, when you cut, you get an image like this. Or if you just shave off like this a layer of this, you get the panoramic slice. So you get images in all three dimensions. So that is a basic advantage of CBCT over other conventional radiographs. Now, how do we plan a treatment using CBCT? That is what I'm going to show you now. Now, this is a case that came to us. His premolar, 5 was missing. His 4 was extracted long time back for orthodontic treatment. Now he had the 5 was missing and he came to us. So we advised a CBCT for him. And look at that. This image was reconstructed from the panoramic radiograph. And you can see that in this area, you can measure the distance between the length of the bone. That is, what is the distance between this tooth and this tooth? So it was around at the semiendoenamel junction level, it was around 10 millimeter. So there was sufficient space to place an implant there. Now, next aspect is you have to look at, if you take a section like this, now here, this is what you get. So this area, this tooth is this tooth. And these 2 molars are actually these 2 molars. So this, in between these 2 tooth, you are going to place an implant exactly almost in the middle area. That is, you are maybe placing an implant in relation to this area. So that is this area, that is 2.5. So in relation to 2.5, if you make a cross-sectional size, now this is the image that you get. And this image is the most important image for an implantologist. Now, this is the sinus, and this is the sinus that you see. And this is the width, and this is the length. So in the crustal region, that is the crustal region corresponds to this region. In relation to this crustal region, you have a width of 4.8 millimeter. You go a little bit apically, 2 millimeter down. The bone width here, in this case, was 7.4. Little more down, you have more width of approximately 8 millimeter. And when you consider the length from the crust to just below the floor of the sinus, you find a length of 12.5 millimeter. So suppose you are going to place an implant 2 millimeters subcrustally, you can confidently place an implant of 4 to 4.2 millimeter here, so that you will have minimum of 1.5 millimeter on either the buccal and the lingual aspect. And when you consider you have gone 2 millimeters subcrustally, so remaining there is about 10.5 millimeter bone. So you can determine, or you can take an implant of length 10 millimeter. So from this CBCT, you have decided the size of your implant. You have decided that you're going to place a 4.2 into 10 millimeter implant. And actually using softwares, you can virtually place that implant. Now, different implant companies are there of different size implant, and that is available with this softwares. So which you are going to do a normal implant. Okay, you take it from the Nobel library and then virtually place it, and you see how the implant is aligned. You can construct a 3D image also. So that is how implantology CBCT has made us very, so useful in the implant practice. Now the same patient we are going to do during implants. This is the image that is taken. Now after the pilot drilling, what we did was we placed the paralleling pin. Now this paralleling pin helps in identifying the parallelism. The second thing, it helps in identifying how far we have drilled. And in the paralleling pin, you have blocks like this. This is of 1 millimeter. So if you count the blocks, you can actually know how deep you have gone also. Now this, you have gone almost 13 millimeter down. And that length was 12.5 millimeter and more. That was measured in the CBCT. So your drilling is correct, the angulation is correct. You are away from the sinus, and you can go ahead and do the osteotomy and place the implant. Then again, imaging is very essential, even during a prosthetic phase. In your prosthetic phase, you will be taking impressions. So while taking impressions, you will be attaching impression posts. Now suppose the impression post is attached like this. There is a gap between the implant and the post. You take an impression and send it to the lab, and you place the prosthesis. When the prosthesis comes back, it is never going to fit. So before itself, you have to make sure that your impression post has fitted nicely with the implant, just blended with the implant. So then you take an impression, and then your final prosthesis is going to fit properly. So in almost all stages of implantology, imaging is very, very essential. Then the next thing that has made an implantology really, really easy for anyone who is a dentist who can place implant, that much implantology is made easy by something called as guided surgery. Here also in guided surgery, what we do is we make use of the information available from the CBCT, and you can actually reconstruct the structures in the mouth. Okay, once you reconstruct and make a model out of it, and from the model, you can make a stent like this. Now, what you can do is you get a stent like this. In the stent, there will be a sleeve. Now, in the sleeve, the angulation would have been predetermined. Okay, and they will give you a prescription as to the drilling sequence and how deep you have to drill. So what you have to do is just place it over the tooth and then go about your drilling. Now, mind you, you need specialized drills, okay? Guided drills are there so that you can fix the length of the drill also. So blindly you can go. You always don't need to open this flap also. You can go flapless also. So that much improvement as our technology has improved in so many ways so that implant placement now has become child's play. Next, a patient comes to you with a badly mutilated teeth. That tooth has got poor prognosis. You are going to extract the tooth. When are you going to do an implant in the patient? Earlier, always we used to wait for long periods of time. But you know, the patient has come for the teeth. He has not come for an implant. So you have to, if you are giving implant or not as an option, you have to plan an implant in such a way that you do an implant at the least possible time. So whenever possible, try to immediately do an implant whenever you are extracting the tooth. Now, when you look at the classification of when you can do implants, you can do immediate, as I told you now, or you can delay it. When do you delay it? Now, you are extracting a tooth. This tooth will be having some sort of pathology there. So at the time of extraction, if you are sure that you have removed all the pathology, or if you are not sure there is some pathology remaining, better not. Okay. And one disadvantage with immediate placement is you are extracting the tooth. You have an open socket area where you are not going to get soft tissue coverage. So when you do immediate implant placement, the head of the implant may not be always covered by means of soft tissue unless and until you raise a flap and release the flap and close it. Okay. So these disadvantages can be avoided if you do it in an early stage, that is within about 2 months. The soft tissue would have covered, the whatever infection, residual infection, that would have been also taken care of. Or third is the delayed one, where the normal way, you extract, wait for long periods of 4 to 6 months, and then place an implant. Now, there are a lot of advantages with immediate implant placement. One of the thing is, you know, the length of time, the number of appointments is being reduced. And one important thing is, whenever you're extracting the tooth and allowing it to heal, there is a lot of hard and soft tissue loss that is going to take place with that extraction and healing. So if you are going to place an implant immediately, you can to an extent reduce or minimize that soft tissue loss there. And mind you, if you are doing implant placement, direct immediate implant placement, there is 2 things that you should be absolutely sure. One is an atraumatic extraction along with removal of any whatever residual infection that is there. That is of prime importance. And second thing is there should be sufficient residual bone onto which you place an implant and you get primary stability. So if these 2 conditions are satisfied, immediately you can go ahead for implant placement, or otherwise you have to delay your implant placement. Now, this is a case which we did. You can see that this tooth was fractured. This is a root canal treated tooth. So we did an atraumatic extraction. For that, you can use instrument called as periotomes. These periotomes actually are very thin. They go into the periodontal ligament space and they sever the periodontal ligament. Never use elevators. Always try to use luxators. The buccal bone is very thin. It's less than 1 millimeter. The average thickness of the buccal bone is just 0.7 millimeters. So do an extraction very carefully in such a way that to preserve the buccal bone. So an atraumatic extraction should be done. And then you can go ahead with your implant placement. And this is the radiograph after placing the implant. Now, what I want you to look is here. This is the gingival level of this tooth. And when you compare it with the adjacent tooth, it's almost at 1 millimeter level. And this is after immediate placement. And you can see that there is about 1.5 millimeter has gone up. But if you had in place an implant, immediately, probably it would have gone up 1 or 2 millimeter, which have been totally anesthetic. So that is something which you can avoid or control by doing an immediate implant placement, especially in the anterior zone. Next is loading concepts. Now, when do you load an implant? Previously, all the implants used to be submerged. You had to place it for about 4 to 6 months, 4 months in the mandible, 6 months in the maxilla, and then go to load it. Now, later on, we found that even implants which are exposed to the oral cavity osseointegrate. Later on, when the implants were immediately loaded, we found that the implant stability was more. At the same time, it was good. I mean, less marginal bone loss was also seen in implants that were early loaded. So you can classify the loading as different types. One is immediate or direct loading, where during the surgery or within 24 hours, you load the implant. You give a process. You say immediate loading, but actually you give a processes, but it will be out of occlusion, centric as well as eccentric. Okay, but you call it as immediate loading only. Then the second concept is early or functional loading, that is within days or weeks after placement, or the delayed loading, which usually takes place about 3 to 6 months. Now, what is the criteria for immediate loading? When you are placing an implant, and if the implant has good stability, how do you check the stability? Now, when you torque the implant, if you get a torque of more than 30 Newton per centimeter, and a reverse torque is you try to remove the implant and check for the torque values. And when you try to remove it and you find that the torque value is more than 25 Newton per centimeter, along with that, if you have an Osler's device which measures the implant stability, it's called as it measures in ISQ or implant stability quotient values. And if you have a value of more than 60, you can immediately load that implant. Now, what is the idea of immediate loading? Aesthetics and to an extent function is being established immediately. You can evaluate the occlusion in the provisionals. And most importantly, one thing is, especially in the anterior zone, if you are giving a prosthesis immediately, the soft tissue is going to heal according to the prosthesis that you are given. So your final restoration will have a very good emergence profile. The aesthetics is very much improved if you give a prosthesis immediately. Now, this is a case which we did. This tooth was fractured, which was deemed for extraction. And we took a CBCT and found that there was a lot of bone apical to that. So we decided to place an immediate implant. Okay, and we got very good torque value. So we thought that we would load that implant. And this is a abutment was placed and a composite was built up, was done. And look, and this, this tissue is going to heal accordance with the process that we are given. This is the immediate post-op of that case. Now the patient came with this situation and is going out with the head tooth. That is the beauty of immediate loading. Then the second last thing that I want you to know is about the surgical consideration. Now, I'm not going to discuss about the normal drilling protocols of things like that. But what I'm going to discuss here is there may be situations which are not ideal. So in that, if you can try to modify your drilling and if you modify your surgical techniques, you would be able to place implants simultaneously along with some amount of bone grafting, rather than grafting and waiting for a long period of time and then doing implant. Now, there are two conditions which I want to discuss today. One is when you have a narrow ridge like this. Just look at here, this is the contour of the adjacent teeth. This has become so narrow. And the second condition in relation to the posterior maxilla, where the residual bone height, the sinus has pneumatized and the residual bone height is very less. Now, this is the first case that I want to discuss. You can see that here the ridge is narrow, but as you go apically, you can see there is a dip. So definitely the ridge is going to be very narrow here. So yeah, either you can open up and do a bone grafting and increase the thickness, wait for a long period of time, for 4 months, and then do an implant. Or what you can do in other way is you can do a ridge expansion. And this is something that we explained when we explained about bone density. So you just drill using one drill, and then you just expand the bone using your osteotomes by increasing size of osteotomes. How do we do that? Now, this is after the flap has been reflected. Now you find that the ridge is very thin. So what do? You start drilling. Only the 2 millimeter diameter drill, you drill first. And then you can place your paralleling pin and gives a lot of information. Now you take an X-ray, you know that you are away from the floor of the nose. It is whatever angulation that is needed, that is there. It's away from the adjacent teeth. You have gone the depth that is needed. Now, what you do is instead of drilling, you use these osteotomes. These osteotomes will go and actually spread the bone. It will condense the bone rather than drilling the bone. So you use a series of osteotomes. When you compare the size of this osteotome to this osteotome, you can say that is more. So slowly, you expand the ridge. And then you go ahead and place implant. Here we use a 3 millimeter narrow platform implant. And when the implant is fully immersed, you can see that there is a fracture line here. But that implant was stable. You had good primary stability. So there's nothing to be worried about. Only thing is this area need to be grafted well. So what we did was we grafted this area, and then we placed a membrane. The membrane we placed was a PRF membrane here. And then over that, we did a suture, and this is how it healed well. And this was the final outcome. So we could take from this situation to this situation in one go. Otherwise, what we need to do was we needed to initially graft this, wait for some period of time, and then do an implant. But here we did the expansion and the grafting in one go. The implant was placed. So the overall treatment time was greatly reduced. The second consideration is where in relation to the posterior maxillary sinus. Now, in relation to the posterior maxillary sinus, when the residual bone height is like less, suppose you have a ridge height of 5 to 6 millimeter. Now, you can consider a technique which is known as indirect sinus lift. What you do is with your drills, you drill to the floor of the sinus. Now, going through this bone will be very easy. It will go like passing through a cheese. But when you reach the sinus floor, the sinus floor is really good cortical bone. So you will feel the consistency. So you make a notch into that. And then with an osteotome, what you do is you tap the osteotome and create a green stick fracture here. And then what you can do is you can put some bone graft into that osteotome site and slowly push this bone graft. So the bone graft will actually passively lift off this membrane rather than using this instrument to lift off the membrane where probably the membrane tear can occur. But one thing is this is a blind procedure. Okay, this is a blind procedure. And you lift off like this and then you place an implant. I'll show you a case which we did. You can see that these two teeth were missing, and there was good amount of residual bone height here. Because these two teeth were missing for a long period of time, the opposing tooth had supraerupted. So we plan to do an intentional root canal and a crown for this tooth for getting proper occlusion. And we went ahead with the treatment. Okay, this is the sinus being lifted. You can see the osteotome implant, and this is you are malleting it so that you are creating a green stick fracture on the floor of the sinus. And you can see that with the paralleling pins, you can see that you have entered the sinus, and this is after the implant placement. And this is the pre and the post. So we took from this situation to this situation. You can see that implant is within sinus, and we are following it over a period of time. It's more than 4 to 5 years since we have done this case. And this is the lower ridge where we have been on a crown. The last case I want to show is about direct sinus augmentation. This is again a case, so generalized periodontitis case, missing tooth. Here, that again the tooth was had poor prognosis. It was mobile, grade 3 mobile. So again, after here, the length of the bone, the height of the bone was very less. So in relation to this area, we took a CBCT and found it was approximately only 3 millimeter. So this is not a very good candidate for indirect sinus lift. So we thought that we'll extract this tooth and then create a window in the lateral aspect and do a direct sinus lift. And this is what we do in direct sinus lift. Now, this is a normal sinus, and this is an expanded sinus where you find that the residual bone height is very less. So what you do is at what height you want to lift off. At this height, you create a window. The upper aspect of the window should be at the level where how much you want to lift off this membrane. So you create a window like this and you lift the membrane, and this full area is being filled with bone graft. Fill this area with bone graft like this. Wait for time to heal. Wait for about 4 to 6 months where that graft is completely converted into bone. Then you go ahead and place implants. And this was our case. This tooth was deemed for extraction. So we extracted this tooth. This is the extraction site. We reflected the flap. And this is the outline of the window that we were planning to create, outline of the window. So here we use this piezo surgery unit. Now this is very useful in cutting the bone. At the same time, it won't injure. There are tips which are specific for sinus lifting. So what you do is you lift, you cut all the bone. This bone part was attached to the membrane. So beneath that, we started lifting off. Once we have achieved sufficient lift, we insert bone graft laterally into this area, and then we close it. Now we could take this patient from this situation. You can see the ridge height was so much to this situation. You can see the outline of the Schneiderian membrane here. If there was any tear in relation to this graft, the whole graft would have been somewhere in the sinus splattered like this. So now we have to wait for this healing period, and then we will place an implant. The last aspect that I want to talk to you is about prosthetic considerations. Okay. Now, previously the concept was bone-derived implantology. That is, wherever you found bone, you place an implant. And then when the patient came to us later on, we had to do a lot of advanced prosthetic procedures for giving a proper prosthesis. Now, when you look at the basic prosthetic consideration, you can have a straight or an angled abutment, and the restoration may be either a screw retain or a cemented retain. Now, this is if you place an implant in proper angulation, you can always use a straight abutment. A straight abutment, the screw hole will be in line with the implant like this here on top. But if you are placing an implant like this in angulation, the screw hole, if you place a screw, it is not going to implant. So your abutment will be like this, parallel to the long axis and perpendicular to the plane of occlusion, but your screw hole will be in line with the implant that you have placed. So this is called as an angled abutment. And there are two types of prosthesis. You have a cemented prosthesis and a screw retain process. In cemented process, what you do is you attach an abutment that is milled. Now, when you with the help of the screw, you are attaching this to your implant. Okay. After that, it will look like a prepared tooth only. Take an impression and get a cast, it will be like a prepared tooth only. Into that, normally how you cement a crown, you cement it. Now, in screw retain restorations, what happens is these two parts are being cemented and attached within the lab, and you will have an opening like this, a screw hole here. So this whole unit, you attach the implant and then screw it. That is a screw retain restorations. But there are advantages and disadvantages for both screw retain and cement retain restorations. Now, this was the same case which we discussed when we discussed about CBCT. So this is this is with the abutment in place, and then we did a cement retain restoration here, and we took it from this situation to this situation where the patient was really happy. Now, the take-home message that I want to give you is, this is not a science that you should be afraid of. This is a science that is quite easy. Only thing is you need a little bit of training and get experience. Now, if you are not practicing it, definitely do join a course. And one thing about implantology is you always see the end in the beginning. You try to imagine what type of prosthesis you're going to make. And from there, you plan backwards. And you do each step with meticulous planning and with careful execution. You can give a prosthesis, an implant retain prosthesis that lasts a lifetime for a patient. The only disclaimer is the patient should maintain it well. Well, this is the wonderful team with whom I work. And most of the cases in this presentation was held by all of them, most of them. And I really thank Team Anur Perio for that wonderful help. And this is the wonderful institution where I've been working for the last 20 years. And I'm standing here saying that I'm a proud Anurin. I thank each one of you patiently listening to this lecture. And If there are any questions, queries, we'll take it up. Thank you.
Thank you, Joseph, sir, for your excellent presentation. Now the session is open for discussion. We have some questions in the chat box. So the first question is from Dr. Unnati Trivedi. After extraction, when will the implant be placed?
Look, that's what I said. After extraction, you can place an implant depending upon the situation. Now, if you are able to extract the tooth atraumatically and make sure that you can remove all the pathology, and if there are sufficient bone whereby you can get a proper implant stability, you directly go for immediate implant placement. If that is not the case, you wait. You can wait, you can do an early implant placement where you wait for 2 months. The idea is all this infection associated with that tooth will be reduced. At the same time, you will get soft tissue will heal over that extraction site. So when you place an implant, the implant head will be covered by means of soft tissue.
So there is one more question from Dr. Devayani Allen. Can you please explain about surgical guide and their fabrication and use?
Now, this surgical guide is basically fabricated in the lab. In the lab, what they do is they do, it's based on information that you get from the CBCT. So from this CBCT, they make a stereolithographic model. And based on this model, they plan a guide. So in the guide, the main thing associated with the guide is that you have sleeves attached to the guide. The sleeve is positioned in such a way that the drill is going to go in the proper direction, angulation. The only thing you have to do is you should use the guided system and then drill to the proper depth. After that, it makes implant placement becomes very, very easy.
So one more question. What are the reasons of failure of implants?
There are umpteen number of reasons when you look at failure of implants, right from the planning aspect, right from your surgical aspect, and from the loading aspects. Okay, if you are not, one thing, maybe one of the reasons probably may be because of some of the underlying systemic conditions which have not been controlled. That is one thing. Second thing is probably your surgery. There are a lot of things that can happen during a surgery. One is contamination that can happen. Second, you reach a situation where primary stability is not reached. That is another thing. Your drilling can cause heat production, which can later cause any residual infection which you are not able to control. That can cause an implant failure. Again, after the implant failure, probably if you consider a broken screw, that is also considered as a failure for an implant. So if you're not loading properly, if all these dimensions and spaces, you have to take into control and you have to plan each step. At any of these steps, you may go wrong. An implant can fail because of that.
So there is one question from Gibran Rashid. How do we place the implants which are angulated into the zygomatic process?
I think that is something that is beyond the present. I mean, this lecture, the extraoral placement, zygoma or pterygoid implant placement, you actually need advanced training in it, and you need specialized instruments and kit for giving a zygomatic implant. Now, regarding angulation, you always have this abutments, multi-unit abutment by which you can bring it to occlusion.
Sir, there is a question from Dr. Mayank Malik. Once the implants are placed, what are the post-surgical medications given to the patient?
Like the post-surgical medications, usually like you extract the tooth and whatever medication you give, the same type of medications and advice you can give to the patient. You can give a course of antibiotic along with, again, look, your implant surgery may involve, then there may be a lot of hard and soft tissue manipulation. So based on that, you can actually give the strength of your whatever potent antibiotic you want to choose. Based on that, you can choose. Okay. Along with that, you can give an anti-inflammatory in the normal case, give a pantoprazole or whatever, and then give a good mouthwash. That is more than enough.
So there is a question from Dr. Ritesh Shetty. What are the precautions to be taken while placing an implant if the patient is diabetic along with generalized periodontitis?
One thing is, you have a two-way relationship between diabetes and periodontitis. That is something. Okay. Diabetes is not a contraindication. Okay. A controlled diabetic patient, you can definitely place an implant. And if it is a periodontitis patient, definitely there is a chance that whenever there is periodontitis, there is an increased chance of developing peri-implantitis. So always you have to treat the periodontitis first and controlling the blood sugar before you venture into placing implants in such patients.
So we have a lot more.
Sir,
Okay.
One YouTube question is there, sir. Can I take you, sir?
Yeah.
Sir, Dr. Kushal is asking, which is better, cemented or screws retained crown?
You can't say which is better. One thing is, there are advantages and disadvantages with each of this. But whatever said and done, both are actually one-way screw retained, because the abutment has to be screwed in case of a cement retained. But the problem with cement retained is there may be a flash of cement going in to the peri-implant tissues that can cause infection and inflammation. So that is a major disadvantage. But another thing is, the advantage with the screw retained is the retrievability. So that whenever you want to remove an implant, it's very easy to remove that implant. But the only thing is, you can't give a screw retained in all the cases. Suppose the screw hole is coming buccally or an area where aesthetics is of concern, probably you will have to give a cement retained restoration in such cases. So each of them has got its advantages and disadvantages.
Thank you, sir. Thank you so much.
We have a lot more questions in the chat box, but due to time constraints, we have to move forward. Dear participants, all your queries will be attended in the WhatsApp group. Thank you, Dr. Jospol, sir. It was really a very informative session.
Thank you, Dr. Nidhi.
Now we are moving on to the next session, Tips and Tricks in Endodontics. Introducing the speaker. It is my pleasure to introduce the next speaker of the day, Dr. Vivek Hegde, the man who has taken Indian endodontics to an international level. At present, Dr. Vivek Hegde is working as the Vice Principal, Professor and Head, Department of Conservative Dentistry and Endodontics at M.A. Rangoonwala College of Dental Sciences, Pune. He has completed his BDS and MTS from the prestigious Manipal College of Dental Sciences. He also has a master's degree in dental lasers from the University of Vienna. He is the president of Indian Endodontic Society, president of SOLA, that is a Society for Oral Laser Application, and director of the Indian Board of Endodontics. A micro-endodontist par excellence, he has represented India in various prestigious platforms like American Endodontic Congress, IFEA Seoul, and APEC, New Delhi. An acclaimed academician with more than 25 years of teaching experience, he has more than 100 publications to his credit. He has contributed to more than 10 books. He was the invited speaker at various national and international conferences. He is a member of the editorial board of various scientific journals. He is the CEO of White Arch Dental Center, Pune, and One Dental, an online teaching platform. With great pleasure, I welcome Dr. Vivek Hegde. Over to you, sir.
Thank you so much for the invite. I'd asked the organizers to give me the screen share. Yeah, I got it. Thank you. All right. Thank you so much First of all, I know you had a good lineup of speakers. Thank you for the invite. One of the primary reasons I'm here for this Horizon Unlimited is because of my dear friend, Dr. Johnson. Johnson Dilima and I studied together in Manipal. When he asked me, I couldn't refuse it. So thank you, Johnson. And I know you're all doing a good job. So when I asked the organizers, what topic would you want? Because I wanted to talk to the target audience. And they told me that 65% or above will be young doctors, dentists, practitioners. So I decided then, even after me passing the masters, I did a lot of mistakes maybe, which I didn't know the answers for. So I said, let me share some of them in the 55 minutes that I have. So this topic was aptly decided for that, called Tips and Tricks in Endodontics. So what we'll do is we'll try and give some explanation on each of those topics that I've chosen. You may wonder why have I picked up these tooth numbering systems. Today is the day of global tourism. And I've seen a lot of mistakes happening in some clinics just because we are mixing up the systems. We followed the Britishers. So for us, FDI is a more important system. But also if you see, there are two other systems called Zygmundi-Palmer or the grid system, which the computer doesn't recognize. Still some colleges teach that, right? But we will follow something like say 1-1, the first quadrant, first tooth, or 2-1, the second quadrant, first tooth, something like that. That's the FDI or the 2-digit system. But what confuses this system with another system is called the universal system, like the ADA system, the American Dental Association. You may wonder why I'm going into the theory. The only reason I'm going is I have seen mistakes happening in some clinic. Just to give you an example, we have Pune is an IT hub. Okay, I belong to Pune. I'm settled here now. So when patients come from US, because Pune is IT hub, a lot of people working in the US. One patient came from the US. There are two examples I can give. I'll give you an example of tooth number 11 or 11 written there and 15 or 15 written. If you mix up the systems on some of these teeth, you're going to terribly go wrong. So here the senior doctor, very ethical dentist, okay, for some fault that they lost the touch of the books or whatever you could call it, he's just retired now. I was in the college, I never get late to the clinic, but this was one day where my postgraduates held me back. And I called, sir, I'll be back in 10 minutes. So he started telling the patient is from abroad, I don't want to waste time. So you know what, I'll inject the patient. So fair enough, he injected the patient. Having seen that, the 1-1, the maxillary right central lens had nothing, he put an injection on 1-1. But this was an American report. So it is tooth number 11. For American systems, for all of us to revise, it starts from the maxillary right third molar, 1 to 8, 9 to 16, down 17, back to 32 here. So that's how it goes, right? So when I came in and saw, I found nothing wrong in 1-1. And doctor agreed to me, but the report said, see, we have to do this root canal. So when I looked into the canine, there was an interproximal caries that was involving the pulp. The radiograph was missing in this report for whatever reasons. So I made a radiograph. I found that right. I took sir to the next room, convinced him, because he's a senior doctor, he could talk to the patient and convince the patient. So I told the patient, you know what, we'll leave this tooth at the moment. There's another tooth that's more important, and we'll do that. Cutting the story short, all I want to tell us is, you know what? Mistakes are pardonable, not neglect, even in the court of law. Suppose you had opened 1-1 and somebody sued you, had it. We don't want that problems, right? So please understand at least two systems. Zygmundi-Palmer is not working in the system, maybe because of computers, but you have an FDI and the ADA, the American system and the European system. So please know these numbers well. Again, for pediatric, it goes in a different ABCD or 5, 6, 7, 8 and all those quadrants. So that you can read, it's not difficult. All I'm telling is because it's global tourism, when we write a report for a patient who lives in US, an Indian person who's working there, you need to write in that system, otherwise they will go wrong maybe. So this was one example I gave. Suppose 1-5 I said. 1-5 would have been the maxillary second premolar. Tooth number 15 is what? A second maxillary molar on the left side. Everything, equation is wrong. This has happened in the colleges also. When you write maxillary right, you do the left. These treatments have happened. But I don't think in this generation will be survived or they'll spare us. So let's take cognizance of this and be wary of this also. That was my first point on tooth numbering systems. So this is what I was talking about, just to revise. FDI goes this way. It's not rocket science. It's fundamentals, what we learned in second year. And here's a universal system. Now, I go one step further now because I use microscopes. There's a camera attached all the time. I make pictures of all the teeth that I'm working on, even if I don't work. Or I tell my assistants to just take pictures of the full mouth and keep as records. Because if I tell a patient there's a pit and fissure caries or there's some oral prophylaxis to be done, some may not trust us, I don't like the question mark that comes in the patient mind. You come wholeheartedly, selflessly, and accept everything what we say, because true to yourself, you can't be that way. But there are patients who are the other way around. So then we keep records, show them what it is. They want to do or not is their call, but we don't want to fall in the wrong place. So that's the pictures. We are talking of diagnosis now. So I give you our tooth numbering system. We're going to the next system now. Like, okay, it's good. I've seen a lot of doctors having OPGs in this clinic. Even I have an OPG in my center. OPG is a very good picture to make for a wide angle view. It's a distorted image. That's why I've written here. It's got the least diagnostic value. When you make for cavity preparations or endodontics or any other procedure, please make intraoral periapical or a bite wing. Maybe an occlusal if you want, but that is coming out much less nowadays because maybe you have a scan, you have a CBCT now for all those reasons. Even in the IOPA, try to master parallel cone technique than a bisecting angle. There are a lot of advantages. I can't go into the detail, but I'm going to give you a quick example of this. You see this picture here. This was a young girl who came to me with some problem in this area, maxillary right quadrant. I saw only a deep filling there. I just took her inside. I told her, let me make some IOPAs. Because OPG is good to see a third molar, a generalized bone condition, and a general picture. But it's a very good selling tool. It's very impressive when a patient looks a full mouth there. But please make localized pictures. And you see this AMA I'm talking? We made localized pictures, and see this picture. When you see this picture and see the OPG next to that. Making these pictures, because you can't keep adding and telling a patient, you know what, I found another cavity, I found another cavity. You can't do that. So you need to talk about all the things. So another quick example. Here's another OPG. Patient came with a classical symptom of endo. Doc, you know what, on the right side when I bite, it gives me a lot of pain and it's towards my cheek. Indication is what? Cheek, eye, therox, maxillary area maybe, mostly. Biting, pain on biting indicates what? A crack or a fracture, which mostly never comes on a radiograph. Here, now we are going here. You see this? I made an IOPA. I saw a crack propagating down close to the pulp. Of course, this was not exposed. So I don't believe in endodontics. I'm very, very holistic. For me, endodontics is what you know. I don't call it root canal treatment. Everybody says he's a root canal specialist. I want to be called as a root canal therapist because I would start from holistic approach, from a deep caries management, like a pulp capping, direct or indirect. Even they will cost equal as much as the root canal sometimes because you need to put a bioceramic material now. You have a MTA, a biodentine, a total putty, or whatever it may be. The equally expensive material, but a very good regenerative material. I'll come to that time permits later, but all I'm trying to tell you is think of this capping procedures. If not, the next step got pulpotomy. A lot of Indians have written good papers on pulpotomies. Some of the best papers you must follow is Dr. Ajay Logani from All India Institute of Delhi. They have done pulpotomy and tried to save the root at the other end. They've helped root closure and so many things. JOE, IEJ, good papers. Sometimes we may do a partial pulpectomy, a deep pulpectomy, because one of the functions of the pulp is what? To form dentine. You hurry up and remove the pulp, that's the end of the story. The pulp is gone, the tooth is gone. Two reasons if you want to keep the tooth in place. Just remember this. First is remaining dentine thickness. How much dentin does a tooth have? Second is, can you manage a leakage? The tooth restoration junction. The restoration junction can be a resin composite, can be any other material, maybe a crown, maybe a onlay, inlay, whatever you want to call. All of this must have a good seal. You call it a micro seal, you call it a nano seal, any seal, but seal is the deal for me. That's it. Coming back to this radiograph, we saw a crack, we treated this, and go back to the same picture, you see nothing. Hence, let's believe in the localized pictures than the generalized pictures. Sinus, okay, I put it this way here. Whenever you get a patient with a sinus, most commonly it's buccal side. Having said that, you also have on the lingual side. Sometimes you also have sinuses as gingival or as cervical as possible. So what you need to understand is, whenever there's a sinus, don't use your brain. Let's trace it. I've seen doctors speculating, can it be this tooth, can it be that? No, you don't need to. All I'm trying to tell you is, we need to try and understand that whenever there's a sinus, let's trace it. Because sinus opens at the path of least resistance. Cutting sinus story short, all I want to tell you in this slide is what, sinus, when there's multiple, think of a lesion that has grown bigger, that is chronic. More importantly, the root mostly is fractured. When there are multiple sinuses, it is mostly an hopeless prognosis. And then maybe you have to think of another procedure called implant. Now here, this dentist has given some crowns that are joined. Somebody has done a re-root canal through that, and things, or a root canal, I'm not too sure. They've gone through the crown and treated the tooth again. And the GP point, unlike here, has opened up here. You see this? It's become diffused or dispersed. And when we put 2 GP points, they go and curled around that. It simply means it was fractured. So presence of more than 1 or more than 2 sinus tract is mostly indicative or a fracture. Now, you have another case here. This is a case of a calcification. Like, unlike the next tooth or this tooth, you see the pulp. Here you hardly see any pulp. But pulp not being there in the tooth is no indication for treatment or no treatment. I would say this way, most commonly we have patients coming to us saying that, doc, you know what, I have a discolored tooth. And the commonest reason is what? When I was small, I must have fallen down. And some agree, some don't remember. When they come to the social age of going to college or getting married or whatever it is, they come and say, I have a discolored tooth. Please make an IOPA. In an IOPA, if there's a periapical lesion, like the one here, there has to be a canal and you have to treat it. But if there's no lesion, you don't have to bother much. Just leave it. All what the patient needs is a good preparation on the labial side, put an Emax veneer, and you're done with it, you're sorted. Later in the future, if there's a need for root canal, you also can go from the back end, right? But why I'm saying this is, I have seen doctors referring cases to me after trying calcification. They dig everywhere, called gouging. Gouging is what? Unnecessary, excessive preparation of tooth structure, losing the orientation, making the neck of the tooth weak, which is called the pericervical dentin, which is the strongest. What is pericervical dentin? 3 millimeters above and below the cemento-enamel junction is called the pericervical dentin. That dentin should be strong and maximum. That's why if you see today in root canal preparations, the so-called flare technique, the double flare technique is all going. It's becoming minimally flare technique. We all call it as minimally invasive access cavity preparations. So think about that. Now here there's a lesion. Now there are doctors telling me, sometimes, what, I may not be able to go through it. Then you can do one more thing. Don't do the root canal. From the ortho approach, raise the flap, go to the other end, cut the 3 millimeters of the root, go to the root end, find the opening, because I said, if there's a lesion, there has to be a canal. Dig that, put some bioceramics, you're sorted. All I'm saying is the zone of infection of a root canal is at 3 or 6 millimeters. Singkuk Kim, one of the fathers of microsurgery I could call from UPenn, he said only one thing: if you resect the root for the last 3 millimeters, 60 or 65% of the lateral axaries, main canals, hideouts are all taken off. Then you go into the canal, work another 3 millimeters, try and put a bioceramic. That's another approach. So if you find it difficult from this end, if there's a canal, you need to find it. Radiograph, the principle is what? It doesn't bisect it at times. You miss that canal because canal is not a straight line. When calcification happens, calcification always happens from any direction, right? Buccal side, lingual side, mesial, distal. So it's a wavy pattern maybe. It doesn't look as straight. And all these teeth are palatally turned or lingually turned. That's the problem. So if there's a lesion, please go after it. And that's exactly what we did in these pictures. We did try and use, these are some good files called C+ files or C pilot or EndoPilot. Many companies sell you this. The tip design of the file is like a K file. The tip design is active. The first few millimeters is very, very resistant to buckling. So it doesn't bend as much. And they are stainless steel. You can't use a night eye with hand. So that's another way to go through it. So this is one picture where we went through the root canal because it was a lesion. So calcification is always and always crown to down, never at the apex. It may go as far as the apex if there is possibly a long-term injury. I would like to remember Steve Buchanan here. In one of his articles, I think in 2003, he wrote a good point here. You know what? He told calcification does not exist. There are only impatient clinicians who give up before going to length. I think that's a classical statement. If you spend time, of course, you need to have some expertise, some judgment, some good luck, many things. But more than that, anything more than that is what? Time. You need to give time. So that's about calcification. So here's another explanation now here. Now this patient, she's a doctor. She's a 32-year-old lady with a young child. She comes to my clinic. Actually, she goes to my friend who's an implantologist. Now, this is a hopeless tooth for sure. We know that. The remaining dentin is not good. The furcation area is too thinned out. The inner wall curvature is not looking good. So many factors. So even I was for extracting. But this doctor friend of mine told me, you know what, Vivek, if I extract, she will have to pay about 20,000 rupees because I have to graft a bone and then wait for a couple of months and extraction charges and whatnot, and then an implant. And she doesn't want it for the next few months. Can we try something else? So I said, okay, we can. The point is, he said, if you put a graft, you're putting an allograft, autograft, or a xenograft, or whatever it is. It might be synthetic bone, or animal bone, or human bone, or whatever bone it is, right? So it costs money. Forget the money part of it. So I argued with him and say, if I can generate bone there, what better bone than the patient's own bone? So I took up this case, asked him for a couple of months. Endodontics is so promising. Believe me, we did this root canal and I've just given it 4 months. See how the lesion is healed. Did a simple root canal. There's no rocket science here. For all the principles and fundamentals, gave 2 dressings of calcium hydroxide over a period of 2 weeks each and called the patient back, did a core built up. I still told the patient the tooth is not good because I can see more of white. I want to see more of gray. More of white with core built up, or GP is not good. She, you know what she tells me? Now I want to defer the implant for another few more years if I can, because my child is small. Can you give me a crown? So I said, I don't think I should be loading this tooth. It's not good, but still we did it. You know what? With a plastic anatomic crown, not with a ceramic crown, but cemented with a glass ionomer cement more permanently. All I'm saying is regenerative capacity of humans or any, it's phenomenal. You just need to believe in this. You give 4 to 6 months for anything good or bad. What do you mean good or bad? Good or bad is like lucency or opacity. That's what we look at, right? If the lesion increases, we'll say there's a periapical pathology. If it heals, we say reversal of the periodontium. For anything to happen, even books have told what? It takes 4 weeks to 12 weeks. That's 3 months. So I think the patient deserves that kind of time. Today, I can show you many cases, of course, not in this presentation, some other time, where I wait for it to heal. I put a very good coronal seal and I don't obturate the root canal. Some of my patients, like I told, are in IT or any other business who travel a lot. I see them when they come the next visit, like in a couple of months, nothing happens. In my school days, I was taught, okay, fill the root canal, put a temporary dressing, wait for 3 weeks, no symptoms, do the core built up, and then the crown. I would say the other way around. First visit, do everything, clean shape, except pack. Packing is obturation. We'll wait for the obturation till I see signs of improvement. I'm not saying healing. Healing may take years sometimes. I want to see the lesion reduce in size. If I know that's happening, I'm good with it. Then I'll obturate the case, the second visit or the third visit in a few months, and then we go with the rest. And I also tell my patient every 6 months, please see me. I need to make one picture to see which side I'm going. This helps you in 2 ways, for youngsters. We all want new patients every day. How many of us try and do patient retention? Our old patients are not thought about. So this was the mind that came to me. It came to my mind long back, like 2 years back. Like I have seen 1,000 patients in a year, suppose. Not even 20% are coming back. They will come the next year, the following year. So what I decided is, I want to see my patients, what I've done, for a free consultation, no charges taken. Because they will think I'm calling for money. No, that's not the reason. The reason is I want to see which side I'm going. Suppose it's failing, I can groom them accordingly. I can educate them accordingly. I don't want surprises. I had a patient telling me, Doc, the lesion was in this tooth. Now it expanded, went to another tooth, 2 teeth got involved and whatnot. I'm not God here. Mistakes happen to everybody. It's not a mistake also. It failed. But the point is, if you're with the patient, they like it. And if you don't take consultation charges for a second time, doesn't matter. You know what? They'll come in another problem. They need an oral prophylaxis. There may be another caries, something else that you're giving a free diagnosis to. Everybody appreciates. Who doesn't like to feel pampered or important? Tell me. I do. So that's the fact. So try and keep your patient, keep retention. New patients will come. Keep your old patients together. That's more important. That family is important. Right? So this was a case. My take for all the implantologists is, if there's an implant coming in, if you can do endodontics and regenerate bone, what better bone than the patient's own bone? Instead of putting a graft from the chin or somewhere else in the body, I think this is a thought to think for them also, And we're doing quite a lot of work like this. In fact, my wife, Dr. Rashmi, she's an implantologist. So in our own setup, we do these things. All right, another important picture here. These mistakes happen in the college quite a lot, okay? Now, is it 3-1 or 4-1? Which tooth to work? While working, because the grid right becomes left because you're sitting opposite to the patient. My only simple take is, be a carpenter here. Be like a tailor. Measure twice, cut once. Simple. You see a tailor, he will do 2 times, he'll pull the tape, he'll draw the line, he'll cut once. Do that, please. It'll pay you in the long run. Don't hurry up to start. Then you can hurry maybe, but don't start with a hurry. So what I do even now is what? When I get identical looking teeth, I confirm it. I take my marker pen, which is sterile, not from the table. I've got in my drawer a separate set of pens and pencils, which I used intraorally. I take it, I put a mark, then I go on to put my rubber dam. It is so easy to put a rubber dam on the next tooth, which looks identical. And only when you open the tooth, you'll realize, oh my God, when the X-ray is taken or the radiograph, you'll see it's in the next tooth. It's not excusable today. Let's be clear about a few things. These are all basics and fundamentals. This is not my theory. I've learned it from one of the best clinicians around the world. I've traveled a lot. I go and spend time with some clinicians sometimes. And these fundamentals made me feel so simple and humble that, grassroots are never to be forgotten and basics are never to be, missed. We only want to speak so hi-fi. I also do a lot of laser dentistry, microscope dentistry. You will find nothing of that in this presentation. All I'm saying is the target audience being 65% young doctors, let's speak for them. That's what it is. So please make it an indication. Any indication is okay. Now, these are few of the tips that we always give in our platform called One Dental. Like our Horizon Unlimited is there. We also have a platform called One Dental. There's a lot of tips we keep giving on Insta or Facebook. You can follow us there. And it's not only endo, it's of different specialty people coming in together. Now that you're opening a root canal, a lot of times, initially in my earlier years, there's a proximal decay. Now, this was an 8 that was sleeping, okay? And for some reason, it dug into the 7 distally. I would have opened the root canal from the top and never bothered on the proximal side because I'm giving a seal from top. But saliva is entering from inside. One of the reasons why we give a closed dressing is what? Trying to give a good sterile dressing. There's no sterility here because there's leakage happening continuously. So all I'd ask is the first visit, like it's a C-shaped canal, the first visit, what I want to do with every one of us, including me, is we inject the patient. Ideally, you're supposed to wait for 11 minutes for a good block. None of us wait. I don't wait either sometimes. So what I do is now I've started giving post-op instruction to my patients after my injection. Sometimes I remove the gloves, I sit and talk to them. I give some, I don't know how much to talk, but I'm not a good person who can converse with my patients so much. I still tell them all the do's and don'ts. Then after 5 minutes, I put the pair of gloves again. I will start removing the caries from the borders. It's not so sensitive. I will do something called as a pre-endodontic built-up first. Put a matrix band, build it up with a resin composite, or sometimes some people use flow, some people use glass ionomers. You may use an amalgam if you want. It's your wish. I don't do amalgams as much anymore, but that way. Then I would start entering into the tooth. By then, this 11 minutes is done. The patient is more comfortably numb. If you see here, there's some calcium hydroxide in the canal placed. This is the pre-endodontic built-up. The seal that I wanted is subgingival. We did some deep marginal elevation. It's called DME, where you tuck the Teflon or sometimes retraction cord, sometimes the rubber dam itself, use a laser or electrocautery. All I'm asking is, please get the finished lines of the restoration on a sound tooth structure. Nothing free floating and free hand, please. Then we open the access cavity from top, and in between you see there's some Teflon cap. I'm coming to that later. And then this is how we completed a root canal. This is multiple visit root canals. I don't intentionally believe in one visit all the time. There are very few indications where I go in for one visit. I prefer to see the tooth a second time. But I will cover up on the second time because the first visit might take. There's nothing wrong in doing one visit because people who do one visit also do the core built up the next time, or they may do the core built up first time, the crown the next time, right? Or the onlay, inlay, or endo crown, whatever superstructure. My take is this way. When I've opened the root canal, it's a new patient. I don't know, will they sit through the rubber dam? Will they get through me for the 45 minutes or 1 hour? So if they can get through that, I will tell them, you know what, this time you give me 1 hour, next time give me 2 hours, please. I will do the root canal filling, the built up, the post, the impression, the temps, everything. Third visit, they get the crown. 3 visits, we are sorted. Or sometimes if they're not good, I take 4 visits, doesn't matter. But I get a second chance to go and see what I want to do. It's not that always I need to put a calcium hydroxide there. If it's a short visit, I may not do. But all I'm saying is, if there's not enough time on your hand, like the 1.5 hours that you need every time, you can't do a single visit root canal. The only reason for single visit root canal is, can you get a dryness of the canal? So many times in vital teeth, when you put a paper point and try to pull the paper point out last time, that one last time you'll have bleeding. You had it. You cannot close it with that. Sometimes non-vital teeth are easier to fill up, This is one of the reasons. You may just slightly overshoot sometimes, which you don't want to, in spite of the apex locators. Most importantly, do you have the 30 minutes of cleaning time? You need to have 30 minutes of cleaning time, 20 to 30 minutes with activation maybe. You can reduce it. After the master shapes are done, not before. When you start irrigating before and the pulp is not out, the coronal 1/3 is not done, that's not irrigation. Only when the apical third is done, when the 30 gauge needle reaches the apical third, the 2 or 3 millimeters short of apex, that's when irrigation starts. And then you need to give 20 minutes of activated irrigation. So I don't have that kind of time. So I believe in multiple visit root canals, 2 visits. When I say multiple, it's 2 visits. Maybe a chronic one, I take 3 visits, or lack of time or competency. Sometimes in retreatments, you get ledges and all, you may not be able to go through it the first time. But like this slide says, make pre-endo filling a priority. It's a must. It's a must do, please. Now, when I said I kept some Teflon in between, this is what we do. I take a condenser. There are 4 canals here, and I've just pressed it in there so that it gets a nice lock inside. What's a Teflon? Teflon is nothing but a plumber's tape. A plumber's tape is what? It's any electrician will have it. You just need to autoclave it. Make small beads, put it in the Ziploc or whatever, and throw it in the autoclave box or the autoclave systems. That's all what I'm showing you. You get different colors. You get yellow, you get white, you get every color. Restorative dentists use it. Implantologists use it to put Teflon. Why don't we then? I have stopped using the conventional cotton or sponge. I'll show you some examples. Now here, this is what I used to use earlier. But then also, I used to stain the sponge, the cotton, I'm sorry, cotton. So we used to put some ink there and then lift the cotton out from as a dressing. This cotton tries and, it entangles to the aerator, makes the noise, leaves the fibers behind, whatnot. I didn't like it. So it's been about close to 8-9 years that I've stopped doing this now. I also used to use this for the early part of the thing, like called sponge or a sponge. So we did a pre-endo. Next visit, when I was removing it for retreatment, I'm using an ultrasonic under the microscope, of course. So we removed this black colored autoclaved sponge. We cut small pieces, again, make autoclaved pouches of this and take what we need. My assistant will take with her tweezer and drop it on my tray. That's the sponge we use. But today, if you ask, I use Teflons. It's a very simple thing, a very easy thing for you to do. This Teflon will give resistance against the superficial material. There's no cushioning, there's no softness. It will not collapse. And the bigger problem is, when you use a cotton, you may make a bead out of it. But sometimes the fibers from the cotton may end up coming out of the tooth, and you will put a cavity filling, whatever it may be, cavet or eugenol, non-eugenol, which I don't like anymore. The only dressing I give is restorative glass ionomer, if not resin composite. Minimum thickness is 4 millimeters because it's said that the best seal that you could get, interim dressing or post, is with a 4 millimeter thickness or more. And it has to be a good coronal seal. So I put over the Teflon glass ionomer, suppose, or composites. But if the fibers of cotton, which I said I made a bead, is coming out, these fine cotton fibers that are coming out will act like fine capillaries for saliva to get into the root canal system. That's the problem again. So think about this. This is nothing big. It's a very, very simple idea and simple trick. Okay. Now, this slide says something nice. Conventional radiograph. How many of us have it today? Most of us have gone into RVG, right? So this theory just doesn't exist now. What it said was, if you had a conventional film that you developed, you have an aerator, take the smallest burr, keep the aerator with the burr against the tooth so that you have the level seam. Let the burr that you choose not cross the furcation so that you won't perforate the floor. And this was a good tip for a beginner because the head of the handpiece is touching the tooth. So the aerator burr is not going far away inside. So this was a clinical tip given to us when we were students. This doesn't relate to the RVGs because you're blowing the picture now. The IOPA is more or less related to the tooth. However, if you want to get a clinical correlation, then please use this. This is the right thing to do with a conventional picture. What I would say is, let's go clinical. The burr that you want to use for an access cavity opening, keep it on the buccal side and let the burr not cross the cervical margin of the gingiva. That's it. That's good for a beginner. Senior practitioners use any burr, any length. If you have the control, you're good. That's not a problem. Because I know there are some beginners, some youngsters who are wanting to listen to this and do well, please take the steps. Smaller burr, let it take more time. What happens is, when you do an access cavity opening, the head of the handpiece is covering the tooth. You can't see what you're doing. And then you come out, okay, I'm here. Now a little modification. The point again is there's air and water spray. That's going to complicate the situation even more. So that's why some of the seniors and good clinicians do it better and the beginners sometimes struggle a little. It's a phase we all went through. You will also go through it. Don't worry on it. Okay. So this is a small tip that I could give on the burr selection. Here's a good clinical tip. Now this is the retreatment tip. The tip only said this much. Okay. Now, when you take a file, every time remember one thing, even if it's a curved canal, the file will take the outer curvature, not the inner curvature. If you want to master endodontics, you need to get the inner curvature in your control. Because you take the outer curvature, as the file becomes longer and broader and stouter, the curvature starts straightening up. And then you'll get a deviation, you'll get a ledge, you'll get a transportation, you'll get an elbow, you'll get all sorts of procedural accidents. You don't want that, right? So try this way. These are something you should try. So all I'm asking you is start with small instruments. There's something called as a glide path management. Try and get that glide path. Glide path is given by some of the best clinicians like Cliff Radl, John West, Pierre Machto, many people, Richard Munz, many people have given all these things. You can go and follow it up in the literature. All what they said is from the entry point to the exit point, how do you travel? How does the canal travel? You have to register the impression of the canal because you're working, or we are working, mostly on a 2D picture of a 3D object. The third dimension, that's the buccolingual or buccopalatal dimension, is not seen. So for that, you need your hands, the tactile, to feel it. Rotaries will not. So don't jump into rotaries. If anybody says so also, if hand cannot travel, rotary will not. Let's be clear about it. Okay. So this is a revision for some of you, maybe if you've heard me before. Some of the slides are, I purposely brought them back here because I wanted to be very simple on my presentation for this topic. So here's the picture. Now this case is what? Lower anteriors. There were 4 teeth to be treated. Somebody had given crowns, joint crowns, and there was no time. This little girl comes from Jaipur to Pune. She takes a flight and goes back. So she's not come out of the root canal actually. A lockdown happened and COVID happened and whatnot. This is a 2-3-year-old case. Anyway, I've lost the case. But the point I'm trying to tell you in this case is, you know what? See the GP points, see the paper points, see the radiograph. All says there are 2 canals in a lower incisor. The incidence is quite high. The incidence is as close as maybe 40%, 35%, 30%, not less. 40% is almost every second case. 50% is every second case. And also take it as a complement, or otherwise, if the right tooth has, the complementary left tooth also has or must have. You may not get it. And if you ask me, my most difficult tooth to treat, it's not a molar. It is these lower incisors and lower premolars which pose a lot of anatomical complexities which are tricky to manage because you have that much dentine. You can't take any burr and drill any which way you want. You have to be precise and perfect to go there. So these are some tricks to, Anyway, so please understand the anatomy, study it, listen from people that we have a lot of variations in our side of the country and the world. Okay. This slide goes on to say that apex locator is a must. There are something known as, in the X-ray when you make, you get to see what is known as radiographic apex. What you need to understand is known as the anatomic apex or the histologic apex. Histologic apex is not seen, it's felt. And what feels it? The file that goes and touches there at the PDL entry point at the cemento-dentinal junction, the minor diameter area, that's the area where the apex locator is felt. So it's a histological finding. It's not seen on the radiograph. It's always inside. So you need to, our endodontium stops there. Why am I showing you these 2 pictures? These are extracted tooth pictures. This is more of a variation, you could say. For all reasons, when the tooth was turned and the picture is taken, or otherwise, if I make a radiograph now, I will see, oh, perfect, 0.5 millimeter short. My file is just still there. But you see what's happened here? The file is already exiting 3 millimeters way before. Because there's no rule in the game. There's no rule, only on the hill, the file will exit and not on the valley. You have ups and downs, right? The root is not conical in one shape. You have a lot of different shapes, elongated, oblong, every shape of it. So you can have roots exiting laterally and incidence is high. You must see all these old studies on apex location. They have spoken so much about it. Cutler, Green, Leville, Lutt, and so many studies. I'm talking of 80s, not now, not recent studies. So they have worked on this. Like, Cutler study, I was reading somewhere 30,000 extracted teeth they had worked on. They're not mad people, right? If they worked on 30,000 extracted teeth, there's a reason behind it. They concluded saying 2/3 of the time, root canals open laterally. 2/3 of that open buccolingually, which never comes on the radiograph, which is like this. So please invest in a good apex locator. It's really, really needed. So this is all what it meant, the theory about apex locators. And here's another picture of a maxillary first molar. I've taken in different lighting conditions just for photography, just to show you how mesiobuccal root can be that much more difficult. See this mesiobuccal root. It's got multiple portals of exit. So there's so much here. In fact, I want to remember Jojo Kutur. Jojo is also a dear friend. He has published a paper in 2018, JOE, I think, so yeah. And he's spoken about MB2s. The incidence they gave, I think, was Venezuela was 48%, least, and highest was, I think, Belgium, 97, I think so. So 97 as good as 100, so every other case, right? And the least is 47, which is like every second case. So there'll be MB2 in every other case. So what I would say is, if you want to know more about MB2s, try and please log into One Dental. We have got about close to 4 hours of recording. Of course, there's some with a fee, some with free. So you see what you want, like how online dentistry is. We also have a platform called One Dental. You can use this code and get some discounts or see some lot of free online stuff there from different doctors. And we've been there for the last 5 years. We've got a close-knit community with a lot of dentists in there, okay? So you can go to onedental.co.in, become a member, add the membership, get the coupon code, take a picture of this if you want, and proceed to check out. All right, coming to this, MB2, it's very, very common and in Indian populations. If there's a slide which is there later, if there's time, I will cover that. One important point you need to understand here is what? 6 is missing, 7 is migrated. When it's tilted tooth, the angulation tilts. When you do a root canal, you're doing a root canal, which means it's internal. It's very easy to say, get a straight line, get a straight line. What we also need to understand, the long axis alignment. You know what I do? Sometimes I take my finger, I palpate the root. I take the aorta burr, keep my aorta parallel to the finger, get my orientation right, and see which angle it should go, and then take it out. So we see here, the floor is wider than the axis cavity. That's the kind of axis cavity we've done here. See the floor, it's more wider. And yet we've got all the canals which are multiple curved. Why I put the slide is not for the axis cavity. The slide means when you have 2 curves in one tooth called an S-shaped curve, do not take 2 curves with one file. Take one at a time. That's called stepping down, stepwise approach, layering way. A coronal 1/3, a middle 1/3, an apical 1/3. Coronal may be 8% taper, middle may be 6% taper, apical may be 4% taper. It's just an explanation. But you think this way. Don't go with one file, one taper. Doesn't work. For different canals, you have different files and different tapers. So you need to understand that. Also, when you have a curvature turning towards you, that's more difficult. A curve that goes away is easier. So that you need to understand. And one other point that I want to tell you here is, maybe I have another 5-10 minutes. So we'll see some more slides. So here, this is the word of caution, please. When you have joining canals like MB1 and MB2. In joining canals, let's understand very clearly, the canal that joins the main canal is more difficult. Please don't go into the full length and into the full length and broke the canals, not needed. Confirm it. There's various ways of doing a fluid technique. There's with paper points, with GP points, and many techniques. Confirm it first. Once it's confirmed, see which is the easier canal. Here there's MB1 and MB2. The MB1 is going one curve. The MB2 is joining and then turning. Don't take it. It will not turn. It will form a ledge or whatever. There are times when I have separated a file long back at the interjunction. The Y-shaped junction where it meets is stubborn and it breaks there, you lost it. We've tried to remove it, but we lost a lot of dentine. And at that point, sometimes the tooth has got a dumbbell-shaped cross-section, which means there's less dentine there. What comes on the radiograph is convexity and not concavity. The bulge comes. And where you work on the concavity is inner wall, which sometimes perforates and blood will gush in and you had it, the tooth is going there. You need to think of surgical approach. So let's not make all these mistakes. These are all mistakes that I have done earlier in life. I'm trying to share with you all, which when you have a difficult canal, it's always good sometimes to work the easy canal full length. Don't bother doing both canals. Then take the second canal till the point of joining, or little short, take a hand file and blend it, irrigate it well, medicate it well, pack it well. That's it. This slide also said one more point here. It said that any canal that's joining deeper down is more difficult. That's true. So when you classify your cases, I do classify this way: a simple case, a not so simple case, and not at all simple. The simple case will be just one visit, not so simple, maybe 2 visits, not at all simple, maybe 3 visits. So please give a range to the patient also when you treat. Tell the patient, yes, this might be 1,000 rupees, maybe 1,500, maybe 2,000. You may charge less, you may give a discount, it's all your wish. But the patient has to know that the variations. They always compare, otherwise the same tooth, somebody else is cheaper, or my other side was cheaper, whatever it is. No? It's not that. These are all canals which are going to trouble you otherwise. So plan yourself well, because we use a lot of disposables. I don't use it a second time, many things. But we put it in the costing and it works for us. I'm not a very, very busy practitioner, but I'm a very, very apt and a very limited practitioner, but we do well. That's what it is. So here, this is about MB2. Generally, we like to see a root canal that is well placed. There's an MB1 there, there's an MB2 here, and all that, right? In this case, it's different. You see this? It's one opening at the line angle. Because of the microscope, I got to get to both the canals. So these are some of the difficult cases at the line angle. It's called a shamrock preparation, where the wall is moved out and out. See how much of out I had to move there, that wall. And then we got these 2 canals. So that's where you found the MB1 and the MB2. But also, if you see the radiograph here, you'll get an indication that the MB2 root is getting thrown out and getting an acute bend. Anytime the root has got a different morphology, 2D or a 3D, you decide. It's not always you need a 3D or a CBCT for a endo. Very few times we do that. Just to get an extra canal, I don't do that. I have a doubt, I may do it, but mostly whenever I want to see the buccolingual side of a tooth, like in resorptions, I don't miss doing a CBCT. A ragged border, I want a CBCT because I don't want surprises later. I want to see is the bone available or anything else. Right. So this is one of the last clinical tip I'll give you here. This goes this way. So when you do a master cone selection, you see here, the canal is wet. You may wonder, I don't know why dentists have to dry the canal to put master cones. This gives me 2 advantages. You know what? It helps me in some ways. The textbooks have said there is something called visual test where you see up to where the GP point has gone, where you mark the GP point's extension, or you pinch it, or you bend it, whatever. Second is called the tactile test. Third is called the radiographic test. Now, there's one more test, that is this. You know what? This is exactly what I'm telling. Whenever the GP point goes finally, it goes with the sealer, right? So that's the same image or the impression I want to give the GP point. It goes with the irrigant now. And what's the irrigant? It's hypochlorite. One of the ways to disinfect GP points is by using a 5% hypochlorite for 1 minute. So earlier what we used to do, take a Dapin dish, put hypochlorite, put the GP points, then wash it and keep it and dry and obtuse it. If at all somebody does. Now I don't do anything of that. I put hypochlorite in the canal, I put my GP points, get my sensor, get the radiograph, make the pictures, take them away. By the time I remove the GP points, that 1 minute of disinfection that the GP points, automatically it gets. In addition to that, the sealer simulation happens, which is a must. So there are double whammy here. So think of this also. So master cone always will go in wet condition to simulate the root canal sealant. Okay, we'll just use this last slide and close it here, please. So this is another good picture. Now, this was an ortho case. It's resorbing, short root. We saved this tooth. It's more than 10 years and this tooth is still there. What I'm trying to tell you is, if your canal diameters are larger, they're oblong, they're not oval, the cross sections don't match, lateral opening, please think of a good bioceramic material. This is an MTA. You can get biodentine, it's equally good. There's total putty from FKG, it's equally good. So many companies. Please learn how to manipulate, use magnification to see it. It's very, very important. So the canal diameter where the size 80 number file is going through, 0.8 diameter, you can't put roll cone, inverted cone technique. They don't work at all. The cross-sectional diameter between sealer, GP and the dentine is too large to prove a success. So I think with that, I should thank the audience for having a good patient hearing, I think so. And I'd like to thank the organizers. So this is my classical signature last few years. I thermoplastically sign off with a good thank you. So I wish the Horizon Unlimited team best wishes and great success for all their endeavors they have planned. Thank you so much. Thank you, Johnson, once again for inviting me here.
Thank you, sir. That was Dr. Vivek Hegde rendering the tips and tricks on endodontics. Hope you all got enlightened with the real stratagem of everyday endodontics. Sir, can we move?
Yeah.
Sir, can we move on to the questions?
Yes, of course, of course.
So we have a question from Dr. Devyani Allen. And the question is, for pre-endodontic restorations, what materials can be used apart from calcium hydroxide? Also, do we need to extend it just beyond the canal or just in the coronal part?
Calcium, see, let's understand one thing. The zone of infection is always the last 3 to 6 millimeters. You don't need to have calcium hydroxide in the other places, in fact. You don't need calcium hydroxide in the middle third or the coronal 1/3. Just deposit calcium hydroxide, if at all it's needed, the last 3 to 6 millimeters and make it a point to activate. Because when you put calcium hydroxide or any medicament that you feel so, calcium hydroxide is proven the best actually of all the other medicaments. At least, I'm not asking for all the activations, at least try and do something known as manual dynamic activation. That's what I'm asking. At least try and do that. It's very, very important. What is manual dynamic activation? You're taking a GP point, which is one size larger than the master point, so that it doesn't go to the apex. It's short by a millimeter or two sometimes. That's the space when you put the GP point and just push it up and down slowly. You're trying to, move the calcium hydroxide everywhere. That's what is needed. Don't push the calcium hydroxide beyond, not needed. It troubles you sometimes. So when you do it, you don't inject the material like calcium hydroxide or even irrigant. You have to eject. So activation is a good way to carry it. That's what we do it. We don't inject. Yes, please.
Yes, sir. Next question is from Dr. Shahnaz Begum. She wants to know about the indications of administration of intrapulpal anesthesia and how is it done?
It's a very painful anesthesia if your LA is not working. But anyway, if you want to do it, you know what? It's a good idea to think about it. I do it sometimes in the sense that I try to give a good block, an added infiltration. My favorite injections now is, of course, articaine. I might combine sometimes. Earlier, we used to use sensorcaine, that's benzocaine, and the bupivacaine. I'm sorry, not benzocaine. Benzocaine is surface. Bupivacaine and ligno equal amounts for longer duration of actions. So I believe in cartridge today in many reasons because there's no methyl paraben. And methyl paraben being the preservative was a big problem earlier in the sense that that was the reason for allergy for a patient. It might have been any form, anaphylaxis or sometimes even death, they say. So I've avoided all that. Cartridges don't have. They've got ether and other preservatives, but they don't have methyl paraben. Anyway, coming to her question, I would like to retain a little bit of local anesthesia, a few drops to us in the cartridge and the carrier. And even if the patient is not complaining, but they're trying to help me, they twist the eyelids, wrinkle the foreheads, I know that they're feeling something. So when you open, try and get the pinpoint opening first and bend the needle should get locked in that opening. If the LA is working, the patient really won't complain. The LA is not working, the patient is going to shout once. I know for that. But talk to the patient, Be empathetic to them. Their empathy will help by, as you're talking and slowly inject the needle, lock it under pressure. Just a drop is enough. It's not the LA that works, it's the pressure and all that works there. But if the opening is big, there'll be a backflow. Then it's not going to work. Suppose you open all of it in spite of convincing the patient and trying, and you have the LA is not working, then you know what? It's not intrapulpal anymore, it's called intracanal. Each of this canal, the same thing what I said, you have to lock the needle into each of the canal. That's a pain. So if there's a reason to do it, do intrapulpal. I would say, you know what? Even more than intrapulpal, master the art of called intraligamentary. I also do something called intraosseous. There are two companies in the world which I follow called Stabident and X-Tip. That anesthesia is very good, where you numb the bone directly. There's a small drill they put in the bone, and it's like a cannula. Then you can take a 30 gauge needle, bend it, put it in there, and start depositing solution till the work is over. So I use intraosseous anesthesia. I use intraligamentary anesthesia, which are more potent, powerful, and effective than giving the intrapulpal. I do intrapulpal only when the LA is really working and I know patient is slightly twitching. Then I don't go for this. I use a little solution, and initially I would try and do that once. It doesn't hurt the patient much. Yeah.
Yes, sir. Thank you, sir. Then we have another question from Dr. Ayan Owen, and this is what he asked. There are times when the decay is clear-cut class 1 clinically, but there is a hideout class 2 occurring. So how to diagnose that hideout class 2, which often contaminates the closed dressing?
You have to make multi, you know what? First of all, I would say what? I told you parallel cone technique. When we make radiographs, I didn't speak about that point. We make 3 radiographs. I keep the sensor. I take the end-on, bang-on radiograph. I don't remove the sensor out. I tell the patient, hold on. I move the cone to the mesial. I move the cone to the distal. 3 times you shoot and shoot without moving the sensor. And you get 3 pictures on the computer. My staff will go and blow it up and keep 3 together. This is the day of the consultation, not otherwise. When you make an angulated X-ray, you cannot miss something. There are 3 pictures of the same tooth. You don't make 1 picture and work. Please make 3 pictures. It's called mesial angulation, end-on or bang-on radiograph, and distal angulation. It helps you diagnose extra canal sometimes, any other variations, so many things, you know. So it's important to do that. In this, you can't miss it. Plus, please use magnification. I'm not asking you to go and buy a microscope today. At least buy a pair of loupes. A good pair of loop with light will change the way you work. It will show you interproximal decay. But if there's a decay, don't leave it behind, please. See that you put a matrix band, any is okay, number 1, number 8, Toffelmeyer, sectional matrices, and then build up the tooth, please. It's very important. And the day 1, the pre-endo is done is the first day itself, not later. Yeah.
Then, so there is yet another question from Dr. Sharnas. It is like, what are the indications of open dressings in RCT?
Never. Open dressing should be out of the thing. Yes, having said that, if you have an active infection, which doesn't stop draining for the first 40 minutes, one day you can keep it open. The first day, you should go to the source, you enlarge the canal to a certain size of 25 at least, maybe 30, while at the apex. It's called trephination. We learn cortical trephination to the bone. Now I'm talking of apical trephination. Let it drain. You don't have to use hypochlorite, concentrated, nothing. Just use distilled water, warm water, just keep washing and manipulate if it is draining. Once it stops draining, you can close the tooth, but you need to call the patient every day for the first 3 days. The draining will still happen, but not so much to trouble you. It will not cause pressure, pain, gases don't build up, nothing. Drain it next day, drain it the 3rd day. By the 4th day, believe me, it's clean. Then I would say make new diameters, get more fresh dentine because this dentine is still infected. The trick is not of draining for me. The trick is of apical step preparation where the GP will go and stop. Because I showed a slide, if you have gotten 70 or 80, then no way GP will work. You need bioceramics, right? So that's the trick. Only if you think the infection is spread with the facial spaces, a lot of drainage happening, then I leave it open for 1 day with the antibiotics and all that if need be. Others, antibiotics also I do very little. It's avoided in my practice for long years. We only give painkillers, SOS, that's it. New cases, we have a lot of good control. We don't, have flare-ups. Repeat treatment, yes. Sometimes we do have patients coming back with trouble.
Yes, sir.
Yes,
So can we take one more last question?
you
This
can.
is, from Dr. Owais, and this is, can biodentine be used for apex closure?
Of course, there are two things, one is called apexification, one is called apexogenesis. Now, what are you going to do, fication or genesis? You can use a biodentine or MTA or anything at any level by protecting the pulp. That is a protective dressing for the pulp to keep there, so the pulp helps you form closure. Now, your question goes in this way that there's no pulp, it's an open apex. I want to do fication. Fication you can do anytime. Of course, you can do. Biodentine is a very good material to do fication. But again, like I said, you're talking root dentine. It's at a distance of 20 millimeters, 25 millimeters, or 22 millimeters from the top, the entry point. That's from the incisal edge. How will you manipulate till there? Do you have carriers? Do you have magnification? Do you have the control? The mixing, hand mixing is ideally not the right way. You need to have the capsulator because you said biodentine. I do, and it's a very good material. It's less opaque. That's because of no barium or otherwise, like MTA has and this doesn't and all those things. So it's less opaque. It doesn't show as much filled in the root end. So you might find some clinician telling that, no, he didn't fill the root end. It's not so. But biodentine is a very, very good material. Yes.
I think we have time constraints, so there are a lot more of questions coming up. And,
I know. I don't want to take your time because I know my friend Mohan is there ready. I don't want to abuse the hospitality. If
Yes.
Mohan is here, hi Mohan, how are you? Good.
Okay, sir. So dear participants.
Hi Vivek, I'm always listening to you. Happy listening.
Thanks.
Sunday pleasure.
So dear participants, we'll be attending all the queries in the WhatsApp group. So kindly cooperate. So shall we move on to the next session? Thank you so much, Vivek, sir, for
Thank
the session. Now, before moving on to the next session, let me give you present before you our institution with utmost pride and dignity. We have here a small video on Annur. Please do watch.
History has proven that those who dare to imagine the impossible are the ones who break all the human limitations.
यस्यां समुद्र उत सिन्धुरापो यस्यामन्नं पृष्ठयः सम्बभूव यस्यामिदं जिन्वति प्राणदेय सा नो भूमिः पूर्वमेव दधातु
Thank you all for watching. That was Anu Dental College and Hospital, Muatupura. And moving on, next is a much awaited session by an eminent speaker in Horizon Unlimited, the virtual international conference. He is the most sought after orator on cosmetic dentistry and endodontics, Dr. Mohan Bhuvaneshwaran. Professor Dr. Mohan Bhuvaneshwaran is an acclaimed cosmetic dentist with his MBS in conservative dentistry and endodontics. Apart from being the president of Academy of Cosmetic Dentistry, India, and the president of American Board of Cosmetic and Aesthetic Dentistry, Dr. Mohan is an accredited member of AACD. He won many awards, including the prestigious EVY Award by AACD. With over 20 years of clinical practice, he has his own training center to share his knowledge and expertise. It's my privilege to invite Professor Dr. Mohan Bhuvaneshwaran to enlighten us on the topic, Smile Makeover with Ceramic Laminates. Sir, do kindly take over.
Good afternoon. Thank you so much for those kind words. It's really a pleasure to be a part of this program. And hats off to Anu Dental College and the online dentistry for this beautiful online Congress, Horizon Unlimited. Should really thank you to pulling all the speakers and then giving the best to the audience. Really, really hats off to Anu Dental College. I know the online dentistry is supporting beautiful educational event. I would personally, from the bottom of my heart, thank both the organization for giving me this valuable opportunity on this Sunday. I think it's the marathon session. People already listened yesterday to a couple of speakers, and today it's going on till 6 o'clock. I saw the schedule. So I'll make my presentation as crisp as possible and as interesting as possible for the next 15 minutes. And then I'll take up questions. It's a lunch break, so it's okay. Those who want to stay can stay back. Others can leave, have your lunch, relaxly. I am happy to take any number of questions because I know what to do as a lunch break session, right? So I would also like to thank the audience taking the time out. I heard there are a lot of registration in 2000. That's what somebody told me. So really happy, and thank the participants for taking the time out on this Sunday for learning, because that is the only way we could improvise ourselves. As already introduced, today's topic is going to be Smile Makeover with Ceramic Laminates. The minute we talk about this, everybody, the eye, you open your eye and this is what comes in right in front of you. The laminates, I'm there with my laminates, and I put it onto my patient for creating a happy smile. Yes, that would be a beautiful dream. And that is what today she's been repeatedly telling, cosmetic dentistry. Today, it's a buzzword. Everybody talks about cosmetic dentistry. In fact, cosmetic dentistry is a huge branch of dentistry, which is a multi-speciality, multi-medical specialty. That's what I call generally, because we have a plastic surgeon, we have a dermatologist, we have a surgeon, orthodontist, we have a periodontist, everybody in the team. That is what is cosmetic dentistry. It's not a blind dentistry. It involves a lot of specialties, and it's very, very interesting. It's not that I always feel that somebody tells her, okay, put some laminates and call myself a cosmetic dentistry. No, we never do that. It's a deep science. That's what I want to convey today. It's not of a mechanical thing. So it's not just mechanics. It's something more than mechanics. So what is this cosmetic dentistry? The buzzword, I told it's a buzzword today. Yeah, it was a recent research in the United States of America wherein they found that the demand for cosmetic dentistry is not only in the nation, but even worldwide is the newest growth sector. Yeah, today, everybody wants to look beautiful. I'll give a small example. So it's called the selfie era, right? You take a picture, oh my God, am I looking beautiful? Now take another picture, take as many as that, and you zoom and see whether they're looking good, and then you post that picture on the social media. Thanks to social media, with the help of social media, the perspective of self-portrayal has grown beyond imagination. Despite the age, sex, caste, creed, profession, everybody wants to look beautiful. Probably 20 years back, when we all started this, it was limited to a certain group of people wherein, okay, he's a celebrity. What? Are you going to earn $1 million with your smile? No, just forget it and live with it. No, today it's not like that. Today it's not at all like that. Everybody wants to look beautiful today and appealing, because even literature has proved beyond doubt that if you look good, your performance level escalates. That is the reason today, adding to the social media, the cosmetic dentistry has grown too much, because the smile makes whatever makeover you've done, smile is an important component. Like there was another survey which was done and which was asked, come on, what do you want to change in your face if a chance is given? 80 or 75 to 80% voted around the dentofacial complex. That's where dentistry revolves. So that is where we play a role, and it is our prime duty to deliver that happy, healthy smiles to our patients. And also why people seek cosmetic dentistry, 89% is to improve the physical attractiveness and self-esteem. Today, I don't want to look shabby in front of thousands watching me. I want to look groomed, everybody, right? So it's not, even if you are sitting down at your house, you want to look neat. So that is the reason why we are talking about all this. And in dental evolution, probably it all started with traditional, and now today people talk about smile designing. Smile designing, I want to repeat that it's not new. It's been ages since smile design articles and principles have been published and in literature and in textbook. But today everybody talks about smile designing because of the popularity and the need for that. The question now that arises is that, are we able to cater this to our patients in the best possible way? That is what we are looking at today. So today's lecture is going to give you a clear options of materials and possibilities in smile makeovers with ceramics, right? So, and also we talk about digital dentistry, which I'll also be touching a little bit on digital dentistry. It's all about creating happy and beautiful smiles. So what are we going to do is that just create happy smiles or a healthy smile. It is a happy, healthy smile. That is what we are looking at. Primarily, I want to concentrate on the diagnosis and treatment planning. It's very important. It's not that, okay, why I'm stressing on this diagnosis and treatment plan, it's always been a habit to us, including me, that today I want to finish this code. I want to do a class 2. I want to do 2 extractions. I want to do a denture. I want to do inlay. It's always been what I wanted to do. What the patient wanted, who cares? Hey, I got a class 2 case. It's not that way we work actually. It is actually what the patient needs. That mentality to change comes only when we enter pure clinics. That's what today, comprehensive clinic. A patient is allotted to you. You do what is necessary for the patient and what is necessary and what is not necessary for us. Patient can find out today. It's very important. So it's not that you want to do a laminate, because today we call it responsible dentistry or responsible aesthetics. It's not that just because, oh my God, I want to change the smile of the patient, I'll do laminates. But it's not that what you want to do. Is that really indicated or not indicated? I'll tell you, look at this. This patient came to us and he was in a hurry. You know these patients, right? Oh, doc, it was a pre-booked appointment for me with me. Sometimes walk-in comes, but they always try to book an appointment with me, and then they will sit on the edge of the chair, indicating by body language that they're in a big hurry. Doctor, relax, what happened? Yeah, actually, that's also another point. I never make my patients sit down on the dental chair. It's always next to me and finding out what they really want. And then I ask, doctor, I need crowns to be done. Okay, tell me what you want. It's not that crowns is a treatment option. Doctor, look at this, look at this. No, no, I know you do a lot of things. I don't have time. I've come from Oman, right? And then I have 2 months time. I've come for my brother's wedding. So I am busy with the wedding. I'm also giving some time to you get this done. I told her, let me have a look. And I asked her, where do you want to do the 4 crowns? My God, doctor, don't act. Look at this. I told, no, I'm not going to do. Doctor, it's okay. I know it's expensive. I can pay how much. That's not the factor for me. That's not the factor for me. This patient is not getting that treatment and then going away and not disappearing off. I want this patient to be my patient forever. That is what we look, what the patient wants, not what I want or what she's looking at. Ortho, doctor, don't be a fool. People told me when I was 18, I didn't get it done. At 35, I will never get it done. Age is not a criteria. You have a good periodontium, a good ortho doctor. Please, I spoke to her for 1 hour. Then she asked, how long will it take? See, the discussion changes. So I'm not going to go into it because it's a huge story again. Then I know what my orthodontist can do in 10 months. This is where we are. What is being done to her? Nothing. No restorative work. Absolutely. The white foundation is there. The pink foundation is there. We have not touched. This is what we call the biomechanical risk. So that's a huge chapter again, diagnosis and treatment planning, which includes a biomechanical risk, the periodontal risk, the occlusal risk, and finally the aesthetic risk. So for me, the biomechanics is very important. What do I mean by biomechanics is, am I touching the tooth structure or am I not touching the tooth structure? That's why today people talk about minimally prep dentistry or no prep dentistry. That's what we are looking at, because bonded restorations we are looking at, and we don't want even a scratch on the enamel. I've been telling for the past few years, probably even 5 years, I've been telling that pre-COVID, we call it pre-COVID era, I tell someday somebody has to put the aerator handpiece into lock and key. Yeah, the day has come today when COVID comes. I was so happy. Oh my God, somebody's put the handpiece into Lock and key, yes. Guys, please don't unnecessarily take your handpiece, because we've been trained, if I don't take up that handpiece and put it in the patient mouth, I feel I'm not working. There is much more in dentistry today. There is much more. It's not the routine traditional dentistry. I don't even have to touch my handpiece to do some work. I just have to make some. Today, it's just diagnosis and treatment planning, wherein we discuss so much. I just have to put a digital scanner into the patient's mouth, take an image, go it, then finally I have the laminates in my hand and then fix it. That's all I do. So I actually put my hands in the patient's mouth only when I fix it for them. That's all. So please, I would be very happy at 1 p.m. if I could change your mindset rather than teaching something to you. So thinking out of the box. Next time when you see a case, I don't want you to jump, oh, Dr. Mohan taught me this, I'll do the preparation that way. No, I will not be very happy, but be very happy. Oh, Dr. Mohan told something. I need to think how to handle this case. It's not just doing it. I'd be very happy if I had initiated a thought process to you rather than doing this mechanical work with his hands. No, I don't want to do that. I can train all my staff here to do a good laminate preparation. At the end of 4th day, they will do a beautiful laminate preparation, but not knowing why they're doing. That is not what we are looking at. We are professionals. We need to know what we are doing, because I want to start with a beautiful saying that people don't remember what you did to them, but how you made them feel. So even failures, like Dr. Vivek was talking, failures do happen to everybody, but how we handle them and how we make the patient feel them as a human being is what is more important. This patient is going to be my patient forever. You know, at the end of the treatment, she told, doctor, even my husband has got something. I think we should get it done. So please, smile makeovers are common, but please make the decision what is the right treatment plan. Most of my cases go into for short-term orthodontics or long-term orthodontics. Without that, nothing. I have a special orthodontist for us, only for smile makeover cases. There's a special orthodontics only for surgical cases. One takes care of the regular cases. So orthodontists are quite busy in our office. There are, in fact, the maximum number is orthodontists, because periodontists we have 1, surgeons 2, endodontists 2, but orthodontists have a huge role today, because moving the tooth is the primary way in which you must be wondering why this guy is talking nonsense. He's supposed to talk about ceramic laminates, and why is he talking about ortho? Because that is the way the world is moving today. Now let's come on to the topic, ceramic laminate. Everybody wants to do a ceramic laminate. Yeah, even I would love to do it, but always I look at this, oh my God, am I going to do a lot of tooth reduction? No, come on, move the case to ortho, then we do little bit of reductions and then we do it. So what is a veneer? A veneer is a simple way. Anything could be a veneer. A veneer in a dictionary, if you open and see, that will be a material that covers the underneath surface. A table is getting laminated, a book is getting veneered, you laminate your ID card. That's all. A surface which covers what is underneath. In dentistry, a surface, a tooth colored material which covers the underlying deformity. So if you have a deformity in the shape, in the size, shape, or discoloration, you want to mask it and make it look better, especially in the anterior aesthetic zone. Ceramic laminate, a beautiful smile makeover with ceramic laminate. So what materials am I going to use? That's the next question. So is this case ready? Yeah, ready. And what am I going to do? I'm going to do a veneering or a full veneer crown, or what that decision. I'm going to show you a lot of cases so that it gets registered in your mind. So materials, composite and ceramic. This is always, hey, I want to do composite. It's not that you like or you don't like. Then a bias comes in treatment planning. So what the patient actually needs, that is what is the question. So on an average, if there are 10 patients coming to me, maybe 9 go for ceramics and 1 comes for composite. So the number of composite cases we do veneering is very minimal compared to the ceramic. So how do we make the judgment? It's not that a 10th patient who walks and goes for composite. That's not the way it works. It's a judgment what you make. So here is a small judgment what we make. The resin composite is a bonded one, and it's economical and cannot mask discoloration. Please remember, even if you stand upside down, composites cannot mask discoloration. Somebody could raise a hand and tell, Doc, I'll put an opaquer. Please remember, the more amount of opaquer you're using in your restorative work, the more unaesthetic your restoration is going to become. Okay, so please don't do that mistake of using opaquer and doing composite just because you want to do composite. Discoloration, absolutely. The minute I see discoloration, no, this case is not going for composite. This case directly I'm going to go in for porcelain. Maybe I do bleaching and then I take up the case for porcelain. And maybe if bleaching takes away all the discoloration, maybe I might think of composite restoration. What is the other thing? Other thing is when I reduce tooth structure. I'm going to show you cases so that it gets easy. So probably there is a slightly overlapping tooth structure. I want to reduce it and then do a veneering, a very minimal reduction. Then I would think only of ceramic. The minute I remove, I need to replace it with what material I'm removing with. Fine. If it's a diastema closure, I'm not removing anything. Additive. The minute your mind thinks of additive, it is composite. The minute you're thinking about subtraction, it comes ceramic. Why? I'll tell you simple. I'm not going to put at this lunch over the entire table of physical, mechanical properties, chemical properties of enamel and ceramics. It's easy. Very easy for any beginner to remember also. Ceramics are equating to enamel. Composite is equating to dentin. The properties are like that. So what am I removing in a veneer? An enamel. What am I supposed to replace it with? Enamel-like material. Ceramic. Simple logic. So always please remember that the minute you're trying to remove tooth structure, the facial tooth structure, it's enamel, you replace it with ceramic. That's all is the logic. So we'll see about the case selection or the types in which we classify the various ceramic laminates. Fine. So when there is discoloration like this, fine, maybe somebody can tell I will put opacers and then do no, it will not look good like what we do it. So this is a pure discoloration case wherein I need to mask. Composite is not going to work. We are going to work with ceramics only. Maybe I'll do bleaching and then do. This case is quite good. It's only the shaping problem, and then I need to close the diastemas. Maybe I have an option of composite and ceramic. Then I discuss with the patient, look, composite can be done, ceramics can be done, both minimally intervention, but composite's life is 6 years, ceramics life is double that. Composite may cost 8K per veneer, the cost of ceramic would be double of that. Patient decides, okay, doc, it's okay, 6 years I'll manage with composite. When I get all the money, I will get this done. That patient decides on that when there is an option like this. Otherwise, we make a decision like this. Here, in this case, obviously, orthodontics not going to play a huge role because if you look at the laterals and the central, they're all looking alike. So what is the patient problem? Doctor, something is, I'm not saying, look at that smile, it's all good. Patients who are not aware of dental proportions, they will tell the doc, something is wrong, doc, I'm not liking. So many patients, doc, what's your problem? Doc, I'm not happy with myself. What is that you're not liking with your smile? Sometimes it becomes very difficult. Some patients clear cut. Doctor, look at this, I want to change that. But some people tell, doc, I'm not happy. Okay, then it is our duty to find out what makes them not happy. The laterals. It's a proportion discrepancy. I need to chop the laterals, make them look like laterals, play with the proportions. Here I'm chopping. Ceramics is the only option. Now these two cases are clear-cut cases for composite. Look at that, hypoplastic areas. I just need to remove the hypoplastic areas. They are weakened enamel. I don't have to touch any other part and then do composite. Another case on to your right-hand side is discoloration. Maybe I'll do bleaching, and if bleaching removes all the discoloration, then I would take it up for composite. Otherwise, I would do for ceramic laminates. Fine. So today's discussion is only on ceramics and not on composites, but I wanted to give you a brief idea on material selection because in diagnosis and treatment planning, that is very, very important. What material I'm going to use, then we start working up the cases. So this is exactly what I was discussing. The types of ceramic laminates is type 1, type 2, and type 3, wherein type 1 is bleaching, type 2 is morphological modifications, type 3 is extensive restorations, wherein extensive morphological changes becomes type 3. These are the way in which we classify our ceramic laminate 3. Discoloration, major morphological, extensive restorative work. Now coming on to the choosing of ceramics, right? That is also important. So what are the types of ceramics that are available in the market? Everybody, the minute, I don't know, even a beginner today knows what zirconium oxide is, but that's not the healthy way. There are two types. This is just for classification of glass ceramics, a broader classification, which we have the glass ceramics and then the oxide ceramics. So glass is beauty. Please remember that glass is beauty. Whenever somebody serves in a ceramic plate, it's so nice instead of a metal plate. Oxides are metals, please. I don't want to discuss more about oxides today because my concentration is on glass ceramics. Glass ceramics gives us beautiful aesthetics. Don't ever think of doing a laminate with zirconia. That's not going to happen at all. Fine, they are all transitional metal. The whole category of oxides comes in transitional metals, which we're not going to discuss. So our restriction is going to be with glass. In glass, we have the felspathic glass, we have the lucite glass, we have the lithium disilicate, more popularly called as the Empress and the EMAC. We're going to revolve around that. So this is what is the best, if you ask me. The powder slurry system. The powder, we mix it, and then we mix it with a mixing liquid, and then take our brush and then start applying it on to the die. So this is a platinum foil technique. People think that, oh my God, it's history. People, it's in textbook. I see some pictures. Please, even today people do that, but only thing it's very expensive. In India, if you ask me, not many do platinum foil technique. Many do refractory die technique. So refractory die technique is that you have a die which is made up of refractory investment, which you start layering on top of it. So this is also a possibility. But the problem is that this takes a hell of a lot of time. I need to take my model. I need to start layering it. A lot of manual work getting involved. And also the strength of these ceramics. These are felspathic ceramics. The strength of these ceramics are not all that great. So the material selection, when you're talking about ceramic laminate, the material selection, this is not a great option for day-to-day dentistry. Okay, when I'm having a beautiful ceramist working with me and I have all the time on earth and my stars are all good and ready to spend, and strength requirements are minimal, then we talk about this. Otherwise, two main materials are Empress and Emax. So this is the laminates done with felspathic, and look at that cemented into the patient's mouth, right? They look awesome. They just look awesome. No words. This is the preoperative situation wherein diastemas were there. Absolutely no preparation was done in this case. Absolutely no preparation, then they were cemented. Look at the effects what a ceramist could achieve. So this is a top end. But today we are talking about more of machinable dentistry, all digital world. We try to mill. That is also a possibility, but we are talking about other class of ceramics. This is what is there. Somebody wants to take a screenshot, can take screenshot then, and then please feel free, except when the patient's faces come. I don't want that to go into any medium. So all these educative slides, please, if you want, take screenshots of them. It becomes very, because I've tried to, they're not given in any textbook. I've tried to simplify so that even a beginner could understand what I am talking about. So there are glass ceramics. So I narrowed down to glass. In glass, we have the felspathic, which is the powder slurry, which I showed you right now, which is very, very difficult to handle. Then we have the lucite glass, lithium disilicate glass. So the slide here clearly tells that the aesthetic levels are supreme with felspathic. Lucite, it's good, and lithium disilicate is good. It's not that I'm talking about 100, 50, and 25. I'm talking about 99, 99.5, 100. That's all. That is all is the difference. Maybe 100, 97, 95. That is all. Okay, they are all above 96% of aesthetics, but the strength is huge. Lithium disilicate, the Emax, 500 MPa, which is equivalent to the metal ceramic what we use. Beautiful. That's why knowingly or unknowingly, whatever you do, cases are done with Emax, because strength is also good, aesthetics is also good. So again, if you ask me, 10 cases, 8 cases go around Emax, one case with Empress lucite, and one case with felspathic. That's all. Felspathic probably even 0.1%. That's the way in which the majority is revolving around Emax. Why am I mentioning the name Emax is that we have enough literature support and my own personal research of 15 years of follow-up, which Emax works well. So today we would strongly suggest Emax, that is lithium disilicate, for all our aesthetic work. Fine. So when it comes to when it comes to discoloration also, what happens is that one minute. Yeah, when it comes to discoloration, we have the lithium disilicate which can mask, but others cannot mask. So please keep in mind that felspathic and Empress cannot mask discoloration, wherein Emax could do. So that is the press technology. What earlier you saw was the CAD/CAM technology. We get the pressed restoration. Then we start layering, micro layering, that's called minimal layering onto it, and then put the rest. There are the restorations right in front of you. Beauty, absolute beauty. It is not, see, ceramic laminate, it's not new. Everybody does. What is it? I don't call myself, I'm the only one who does it. Everybody does it around the globe. But how different you are. makes a difference. So please, it's not about that I do 1,000 cases. It's okay. I'm a master. One case should speak of your volumes. That is what I'm trying to teach you in this 1 hour. Look at the restoration. Oh my God. Yes. Be the dentist who could deliver that. Oh my God. That's what I'm looking at. I'm not looking at like Dr. Vivek was telling, it's not a mass practice. It's quality. I see only 2 or 3 patients in the morning session and 2 or 3 patients in the evening session. That's all. That's all I work. That's all I work on. But we deliver quality. Done is done. It's not that here, there, here, there. No. If I'm doing it, it's 100% to my satisfaction. Nobody can be perfect. We are all looking in the zone of excellence. We could stay in it and get these results. So please remember, as much we talk about machines, manual. This is my friend's post on Instagram. CAD CAM and manual plays a huge role. So technician's role is very, very important. So I love this wordings when I'm talking about material. As useful as machines are, the final 10% touch makes 100% difference. Fine. So please remember, make your choices wisely, that your choice and material selection is very, very important. So what I've told is that choose only glass ceramics. In glass ceramics, majority revolves around lithium disilicate, which is commercially the best material is Emax, right? We also have the lucid glass, which is Empress, and the rare possibility of feldspathic. I don't want to push feldspathic to all because I'm not seeing any of my audience here. I don't know at what level they are practicing, because using a feldspathic requires a huge amount of skill from the ceramist side and from the dentist side. I don't want blindly talk about feldspathic today. So please stick on to Emax. That's the best material suitable for every type of dentist whom we are looking today. Now the next part is coming on to tooth preparation, right? Tooth preparation is very, very important. People generally try to chop off the tooth structure. Today, I cannot ask a question to anybody. Could you give me guidelines for tooth preparation for ceramic laminates? Means, what are you looking at? Okay, incisal edge 1 mm, then labial you do 0.7 mm, and then you take an impression. It doesn't work that way. Today, concepts have changed because tooth preparation is biological, not mechanical. Somehow, even now, I want to throw away that aeroter handpiece. Yes, there are electric handpieces today. Life is a cycle, boys. What was old-fashioned yesterday is today new fashion, right? So life is a cycle. It keeps changing. We all started with slow speed, and today, I don't know if you're following a lot of people in Instagram, we talk about electric handpieces. Slow speed. That's all. Not talking about air rotor or anything. Air abrasion, micro motor. So today it's biologically oriented. It's not that you take the air rotor handpiece and chop it off. If enamel bleeds, will you do that? Gingiva bleeds, oh my God, it will start bleeding. Don't touch the gingiva. If enamel bleeding, will we do all that nonsense? No, we will not. We will respect enamel. Oh, okay, it will stop bleeding, but a little here, here and there. You do it. That's all. So biological, mechanical, little bit, because the restoration should stay in mouth. It's not that being conservative and then trying to spoil the aesthetics. No, not that way. Aesthetic also. So this is a cycle of tooth preparation wherein you do not follow strict rules and regulation, which will necessary for each case. Within the case, I may not do the same preparation all around, right? So minimal requirements coordinate with the laboratory. The case goes to the laboratory, we digitally plan everything. I'm going to show you all that, then tell, okay, come on, tell me, how is it? Okay, doc, do this, do this, do this. That's how it is today. And guides are there. Today, it's all guided dentistry. We don't do any blinds. My stents are ready, my guides are ready. I have my, already a smile design model. This guide, this is a printed model. They are ready with me. I just have to make my splints today. Everything is guided. If you're doing blind dentistry, it's a crime. It's a crime. I should know where I am going. Today I have to go to Mumbai. Yes, I need to go to Mumbai. Yeah, how am I going to go? Take an auto from here or take a metro from here, then land at airport, then walk. Every single step is important for me. It's not that blindly doing. Nobody talks about blind. So what am I going to discuss on tooth preparation is about the margins, where I place it, and how the margins have to be. So the margins can be plenty. Margin configurations can be many, in which we have the finish line configurations, wherein I have the chamfer, the heavy chamfer, the shoulder, the radial shoulder, the shoulder with bevel, and the knife edge. So all this is for multiple restorations. Today we talk about rounded shoulders, heavy chamfers, all that for all ceramic restoration, depending upon the amount of tooth reduction we do. And knife edge, yes, we still talk about knife edge in no prep dentistry. So this is a chamfer. This is a rounded shoulder, a heavy chamfer, what you call a rounded shoulder, because we don't want any stress concentration anywhere. The chamfer is basically used for metals, but if the laboratory technician tells that this material can withstand, you can still listen to him and do a chamfer or a heavy chamfer, and also a knife edge. What am I talking about? Knife edge. Look at this, 2 peg laterals. Can I do composite? Yes, obviously, you're most welcome. But there is also an option of ceramics. Not many ceramists could help you with that. Help you with what? Look at that. Thin, nothing, no preparation, just an impression. A laminate fabricated. Look at the knife edge. It's going to sit there. How is the margin not going to be visible? Invisible. That is a key. That is what is dentistry. That is what we are talking. That is what we are struggling. How to make it invisible. Invisible dentistry. Oh my God. Plenty is there to learn. Plenty is there to learn. Knowledge, skill, both are important. You cannot separate them. You just cannot separate them. You cannot tell that I'm a clinician. Forget it. Without knowledge, nothing comes onto the plate. The next is the biological width, in which where I place a margin. Unnecessary, the periodontal complex. I don't know, people following my Instagram, I put a post 2 days back also telling the importance of the resto-perio complex. If you're not respecting the resto-perio complex, done. So please, whatever said and done, don't try to put it subgingival. At the crest of the gingiva is what I recommend, because people looking at literatures and other stuff, see some people take it subgingival. I don't do it subgingival. I do it all at the crest. Because look at the gingiva and this mirror image, how crisp it is after laminates, right? This is what is the gingival health we are looking at. Supragingival is done only when I talk about posterior restoration, when margins are not going to be visible in the aesthetic zone. Our visible margin is an aesthetic failure, so we don't do it. Now look at the cases, failure cases I want to share with you. It's not that always success I want to share. I always want to talk about failures. Also look at this. I wanted to do a gingivectomy there because only then I could achieve the proportions. Then we did gingivectomy, we did the laminates, everything was good. 6 months later, I reviewed the patient. I see the gingival inflammation at the gingival apex, zenith. I violated the biological width. It's not good. Look at this. Immediate post-operative ceramic laminates done from canine to canine. Then I see the patient after 6 months, my heart breaks. If this is the way my gingiva is, forget the laminates in 5 years, all in the hands. It's not that I buy a car and I go to the showroom after 5 years and tell that, what the hell have you done to my car? Nothing is working. Yeah, obviously nothing works because not come for servicing every year. When a car, a machine needs to be serviced every year, why not dental restorations? Why people think dental restorations are lifetime restorations? This cannot be. The patient is not maintaining. I have not done anything to the gingiva. This is the way the patient takes care of such a huge treatment with so poor oral hygiene. Don't blame me. I show to the patient, look, this is the way you're going to do. Don't come back to me and stand. So this patient is on strict oral hygiene instructions reviewed every week after that and every 6 months, because it's our duty. It's our duty to deliver healthy and happy smiles. Again, I want to quote something because I've been talking about enamel today. How much ever bonding agents you use, it is only enamel bonding agent. That's the best, right? So cases like this, I would not take up in bonded dentistry. Personally, I would like to push the patient to crowns because I'm not sure if enamel is there. Finally, we removed all the decayed lesions and enamel at the margins. Okay, at least some enamel. So much of dentine today I will not do. If you refer back to an article of the most famous article in this section by Gallup Gruel in the International Journal of Prosthodontics in 2013, it was published. Till today, we follow this article telling that porcelain laminate, when is bonded to dentine, are 10 times more likely to fail than bonded on enamel. Please remember enamel. Don't touch dentine. If you're touching dentine, it's like doing a scratch here. I want to immediately seal it off. That's called immediate dentine sealing. I don't want to push it because dentine is like open. Oh my God, close it, shut it. Because today dentine is so very dangerous. D is equal to D, dentine is equal to dangerous. So on a general rule, I restrict my margin to 0.3 or 0.5. That's all. Beyond which dentine would come margin. Incisal edge, if required 1 millimeter, maximum allowed is 0.7. Today we talk about 0.3, 0.5, 0.7, 0.3. Phew, gone in the wind. So we talk about such thin restorations. Look at that. Difficult to handle. One press, gone. Then how does it be strong in the patient's mouth after bonding? It's like a ceramic tile. Maybe we all buy ceramic tiles like for flooring. Imagine I supported the ceramic tiles in 4 sides and make you say, no, come on, I will not sit, it will break. But the minute you put a solid concrete and then put a ceramic plane, people jump and play on it. The same logic. Ceramic like this is very brittle. The minute it lands on a concrete enamel, that is why I keep stressing enamel, enamel, enamel. It's solid, right? So please look at the measurements, 0.4. So the margin placement is very important. Suppose I'm taking palatally, I'm doing palatal reduction. Again, thanks to Gallup Grule, who's done the finite element analysis study and found out the red zone and the green zone. We want it always on the green zone. That is, canines alone gets overlapped. Incisors, it's a flat butt joint. We don't try to overlap because you see that pinpoint would fracture. Canines have a huge bulk, so canine I can take it inside. So incisors and laterals, central incisors and laterals, it's a flat butt joint if I am doing an incisal reduction. Otherwise nothing. And then in a canine I do my overlapping. What is more important is a proximal subcontact area. What is this proximal subcontact area? Is that when I view my patient laterally, you saw the black lines, right? If I don't take my margin inside, they become visible. Big deal. Yes, it's an aesthetic failure. It's not a technical failure, but an aesthetic failure. So what is that? There is a contact, then you go inside the contact and come out without breaking the contact. That is the most trickiest in laminate preparation. Otherwise, everything is easy. Like a crown, you do only the label reduction, it's done. But you need to go inside almost at, the burr goes almost at 90 degrees and comes out without breaking the contact. That is the only trickiest part in tooth preparation. That's what we teach in our hands-on program. So here you see a straightforward, all textbook preparations done by us for laminates. You see the proximal, you can see the proximal portion wherein it goes and comes all clean and neat, right? All on enamel. But not all cases are going to be like that. We do have cases like this wherein it's overlapped, and then you modify. I do more of distal reduction, almost no mesial reduction. So it's like this. Look at that. Distal more reductions, mesial lesser reductions. So all our customized preparations, nothing is textbook telling this is the way it has to be prepared. No, we don't work that way. And look at this. One incisor missing, overlapping, and then the fractured tooth structure there. And then I asked the patient, do you want me to just do the fracture? No, doctor, make it correct. So if you look at it, the tooth is like this, distally tipped inside, mesially moving. So I asked my lab, can we try something? Yes, we tried something. What did we do? Look at that. We did half the tooth minimal prep and half the tooth no prep. Yes, we collect all these cases and then publish this data for the dentist to know that something can be done thinking out of the box. That is what is the difference I told at the beginning of the lecture, right? So look at that. From here, the distal side, absolutely no preparation. The ceramist is on the restoration. There you are. And look at the palatal side, nothing. So what we are looking as cosmetic dentist is a beautiful treatment plan and beautiful execution at the zone of excellence. That is what we are looking. So combining these two, the key to success is customized preparation. And you can take a picture of this slide because this is the key factor here, because afterwards I'm going to show you some of my cases. Preparation, design, and material selection combination, no prep, minimal prep, traditional prep, direct composite, glass-based is Empress, glass-based with filler is Emax. Then you have the traditional, which doesn't come in laminates, it's a zirconia. Fine. So this is how is the summary. If you ask me, I could call this a popularly summary slide of what I've been talking for almost now 35 minutes. Now coming to treatment. It's very important. This is what is important for me. Design, plan, and then execute. It's not that you execute and then say, hey, come on, do laminates. No. It doesn't work that way. We design. There are so many ways in which we can design. In fact, undergone for DSD when it was 2-dimensional. Now it's all 3-dimensional. Digital smile designing, yes, an option. 3Shape Smile Studio is what we have, the whole setup of 3Shape. So 3Shape Smile Studio. Exocad is what my laboratory has. And then personally, I have my DSD, then I have my IO Smile. A lot of apps and applications are there to give us all these and take us through the journey. Without this planning, guide, without guide, I can't even imagine. I can't blindly tell get lost. Where do I get lost? Tell me, where should I get lost? That's what is important. This is from Exocad. Look at that. My laboratory does that, all the designing, and they're right in front of us even before we do that. So how many physical impressions? No, today absolutely nothing is physical for me. Analog impressions, it's all digital impressions for me. It's so very easy. It's within a minute I finish my upper lower, less than a minute, upper lower scans with bite registrations and motion scanning. Everything is done in a minute. Post processing done, models are already right in front of me. Absolutely no flaw. So that is the present. It's not the future. Please, guys who are ready to invest, please try to invest on digital, which is very, very important. Those are printed models. So what I already showed you is that we have all these printed models right in front of us, and no more stone cast. Nobody talks about stone cast. All those are 2 ceramic laminates on the printed models right in front of us, right? So that is the world today. And then how do I cement is a small, because cementation lecture is another separate lecture. So it's a glimpse. Again, you can take a screenshot of this flow chart. You have the felspathic and the Empress and lithium disilicate, a restorative material getting etched with hydrofluoric acid. 5 to 9% of hydrofluoric acid. This number of the time depends on the material what we do, and then we apply the silane coupling agent, then the adhesive cement application. Tooth, we know the etch and bond. So it is etching and bonding of tooth structure, etching and bonding of ceramic laminates, join them with a composite cement. There you are. Fine. So here is a pictorial representation. I put the acid onto my laminate. I etch. Everybody knows about tooth etching and bonding. I don't want to waste time on that. Then you put the silane bonding coupling agents so that composite bonds with ceramics. Then you put the cement, fix it. Okay, it's a little technique sensitive procedure. That's why many don't try to venture onto this, but it's all a learning curve. Once you learn it, you master it. Fine. So I'm going to show some cases and then sign off. So look at this case. This patient told that, Doc, this tooth is shaking. Yeah, tooth is shaking. Let's remove it. I put a tooth. Put a tooth. Putting one extra incisor is a crime. Fine. No. Get an ortho done, move it, and then we do no prep laminates. What? Doctor, please don't play the fool. Spoke to the patient. 4 months, there we are. Just 2 peg laterals. Then absolutely nothing. Biomechanical risk is 0. I take an impression, send it to the laboratory. Laboratory does a laminate. What did I do here? Treatment planning, decision making. That is what is important. Look at that. That is the world today, right? Patients will listen to it. It's not that patient is listening to me. If the patient doesn't listen to me, most often I get a question. What happens if the patient tells a no? I tell a no. No, you're not getting treated with me. Be firm, be firm. I'm not waiting for my patient at all because I know what is right, what is wrong. Here is another post-orthodontic case. You see a lot of designing has been done. There is a can, the teeth are retroclined, and we need to change something. When we did digital analysis, DSD, digital analysis, it was great. And the patient told, okay, then we printed the model, we put the prototypes into the patient's mouth. There she is. Look at the face. Oh my God. No dentistry is still been done. No dentistry is still being done. We just try to duplicate the digital information to the patient's analog. That's all, and showing her how it will be. It's like a trailer. You watch a movie, you see it. Dog, awesome! I want to get it done. Okay, get it done. So here are the restorations. Again, no prep dentistry. There the patient is fine. So there the dentistry is. Most of the cases are almost no prep for us. Okay, at this point, I'd like to thank Mohit Suryavamsi. You can also follow him on Instagram, Precision Dental Studio. No words to thank him because the restorations, these are the pictures taken by him, not by me. A class ceramist who can offer us so many things in dentistry, which makes our life so very simple and beautiful. Fine. So, my dear friends, And colleagues, it's not just creating happy smiles, but happy and healthy smiles, fine? So in conclusion, it is all about decision making, fine? The right decision you make, it's very, very important. Before ending, I would like to tell anybody who's interested in learning more, please join us as the AACD, the American Academy of Cosmetic Dentistry, wherein the best dentistry on cosmetics is being taught here, and beautiful education happening. We have the Indian affiliate of it, that is Academy of Cosmetic Dentistry India. We have the conference coming up in Orlando. Finally, we're having an on-site conference in Orlando in April. Please do get in touch with me. I would be more than happy to guide you through the whole journey of learning more and getting into the zone of excellence. There is much more than what is taught today. I'm happy to take any number of questions. And if something missed, you can always post me on my Instagram. Dr. Mohan B is my Instagram handle. Thank you once again for the organizers for giving this valuable opportunity for presenting what little I know in this subject. Thank you. And thank the audience for the patient listening. I'm not seeing you, but still, thank you.
Thank you. Thank you so much, Mohan sir. That was all about aesthetic dentistry. It's beautifully veneered into our 1 hour lecture. And I think we'll move on to the questions. There are many questions coming up. And sir, with your permission, may I begin? The first question,
please.
The first question is from Dr. Shahnaz. And she's asking which burrs should be used for veneer preparation. Which burrs should be used?
There are a lot of prep kits available. I have my burrs from Edenta, E-D-E-N-T-A, Edenta, Italy. They are good class of diamond burrs. So we have the, I showed you that heavy chamfer, right? So depth orientation, generally we don't use. They give all the depth orientation burrs. So we have the depth orientation burrs. In addition, we have the rounded shoulder burr. They have the veneer preparation burrs itself from Edenta, Italy.
Sir, am
Not
I audible?
audible. Yeah.
Yes, sir. Sorry, sir. The next question is, thank you, sir, for the first question. And the next question is from Dr. Saumya. What should we do in patients with a mild gingival recession if they want a ceramic crown? Should we use the pink ceramic to mimic the gingiva?
Okay. Generally, coronally repositioning flap is not very successful unless we have a good periodontist. So I would strongly suggest to use a pink porcelain. The only thing is that the pink porcelain, what is available to us is not to the shade of what we have. So I generally don't try to use that because that makes it look very, very artificial. It might be very funny, but we use segmental orthodontics, move the tooth a little bit down. Moving the tooth a little bit down will move the bone and the gingiva down and then proceed further. If it's really, really a high-end high lip line, high-end aesthetic case, I would do that.
Okay, sir. Next question is from Dr. Devyani Allen. What is the success rate of Emax full crowns?
Emax full crown success rate, if you ask me, I'll tell 100%. What is success? Success is not you do it and then for lifetime it's going to stay, right? We have a lifespan. So literature today supports 15 years of success. So everything bonding properly, occlusal consideration taking care properly, we would definitely promise a 15 years of lifespan of the Emax crown. If you consider that successful, that's successful. 100%.
Okay, sir. One more question from Amrita Kannan, Dr. Amrita Kannan. Patient has a root canal treated central incisor and she has a metal ceramic crown since 12 years. What is your opinion about the most aesthetic method of treating the patient?
So if you're planning to change the metal ceramic crown, root canal treated is okay because bonding is what you're looking at. Generally, after so many years of root canal therapy, you don't expect the dentine to be bondable. That is, the collagen gets degenerated. That Rodriguez et al. Have done a study in SCM and published pictures with SCM where the dentine gets degenerated. So there are two options, right? So you have bonded restorations and unbonded restoration, or cemented processes. Today we talk about bonded restoration. Bond is that you can bond. That means your preparation will not have a major retention. You are believing on the bonding. Whereas if your bonding is not going to work, you believe more on the tooth preparation skills. So your tens of friction. So only thing is that make sure your tooth preparation is good, and you can do an Emax crown with glass ionomer cementation. That is a protocol. That is a proven protocol. Don't feel bad that you're using a glass ionomer. There are varieties of glass ionomer cements also available. If you're still looking at some option, okay, I don't want to use glass enomer, I want to do something, I would give you U200 from 3M as an option to cement the processes. So a crown, an Emax crown, and look at the amount of discoloration. Discoloration is there. I would do intracoronal bleaching or non-vital bleaching. The best agent for non-vital bleaching is Opalescence Endo from Ultradent. I use that, reduce the discoloration, use an Emax crown with a U200 cement if you're not willing to use a glass ionomer cement.
Okay, sir. Then one more question, sir. Dr. Gibran, which gives better aesthetics, subgingival margins or equigingival margins?
Equigingival. Not only aesthetic, but also the best gingival health.
Okay, sir. Then one more question from Dr. Arya Sugumaran. Could you please explain about intraoral ceramic repair system?
Yeah, intraoral ceramic repair, when do I do it? Is it very small fracture happens? My heart actually breaks if such things happen. When all can it happen is my question. When the patient falls again, definitely it's going to break. My patient generally, what can I bite? Is a cut apple. If they suddenly bite something very hard and it breaks, if it's a small chip, it's okay. Otherwise, I would want to change the whole ceramic lot, because what am I going to repair it with? Ceramic? Absolutely not possible. I'm going to put in my furnace in the patient's mouth and do that. I'm going to use a composite, right? Okay, you're mixing two materials here, ceramics and composite. So, okay, a small one is not worth to remove it. Small cervical, small incisal, small beveling or sandblasting. Then we use the etchant, not the hydrofluoric acid, the phosphoric acid etchant, silane coupling agent, then put a composite, and then we repair it. That's the way we do it. And then polish it. You can get the gloss you want, but they are two separate materials, whatever said and done.
These were the final question. This was a final question from the chat box.
Yeah, no problem. We have time.
Do we have any questions in the YouTube, Dr. Joby, sir?
No, doctor. No, doctor. YouTube still now there are no questions.
Okay,
Okay,
thank you.
Okay, sir. Thank you so much. Sir, one more last question.
Yeah, sure. I'm happy to take.
Yes, sir. This is from Dr. Lakshmi Shekhar, and she's asking: discolored tooth with no symptoms or radiographic changes, treatment plan suggested.
Discolored tooth with no symptoms, a patient coming in for discoloration, it's happened to me, it's happening to us, and convincing the patient for root canal is going to be difficult. That to know periapical things, and why doctor just treat the we don't know when it will get flared up, or it might not get flared up. It's happened once to me. Patient was all good. I'm talking about 10 years back. We started the root canal therapy. Next day, the patient's face was like this. It aggravated the bacteria inside, and it was exacerbation of the underlying pathology, which was not visible in radiographically. It's very difficult. The patient walks in without any problem. Your treatment has created a problem. That's a very, very difficult situation. So we try to explain to the patient, this is not the way we treat you. Tooth has been non-vital. We have to do a root canal therapy and then a crown. That is the way we have to proceed further. If the patient is still insisting that, doc, it's okay, can you just cover it up? Maybe, I don't know how much I'll do it. I'll do a laminate only, because if there is necessity, I can always, my palatal is always free to do a root canal therapy at any point of time. So a ceramic laminate, very, very rare. The patient is, it's okay, doc, temporarily I want something. Again, it's temporary because you cannot bond it as successfully as what you bond on a routine enamel. So very rare options. Otherwise, I sit down and try to convince a patient for a root canal therapy and a full crown. That's all. If it was my sister, I would do that. Or my brother, I would do that.
Okay, sir. There are a few more questions, sir. So one question is about endo bleaching. Endo bleaching, sir.
Yeah. So when I do a root canal therapy and taking up the case for full crown and I find discoloration, of course my ceramics could mask it. But as I told you, the more and more masking agents you use, the more and more aesthetics level drops. So we try to do endo bleaching, and we all know walking bleaching is short notes we have written, mixing sodium perborate, suproxol, and then that nobody could do it. So we have the ready-made agent. Opalescence endo from Ultradent. We remove the GP, we put the GAC liner, put this bleaching agent, wait for a week's time, the discoloration disappears.
Okay, sir. So which zirconia is good? This question is from Dr. Unnati.
Zirconia itself is not good. Okay, fine. A low strength zirconia. I don't want to brand anything. I am looking at zirconia at a 700 to 800 MPa, not more than that. That is the best zirconia if you're blindly asking that question.
Okay, sir. Then which is the bonding systems you suggest for EMAX?
EMAX, when the crowns are retentive, we can start with a regular routine glass ionomer, move up to U200, or if it's a vital tooth, I move to Veriolink cements from the resin cements from Ivoclo Evidence. So we have glass ionomers, a self-adhesive resin cements to top class resin cement, that is a light cure and dual cure resin cements.
Okay, sir. Then we have more questions coming up. Dr. Kishan Raj is asking, how can we remove veneer if at all there is a fracture?
Okay, veneer removal is a very difficult portion. I check out if it's done by me, it's easy. Initial gross, I would just do with my erotor handpiece. Then I know it's a fine, thin portion still remaining. I use my slow speed handpiece without any water because it's all ceramics, right? And that speed would not irritate the tooth structure. So I use my slow speed, remove this. It takes a lot of time, remove. There are studies which also use hard tissue laser. So am I going to buy a hard tissue laser for this purpose? No, I'm not going to do that. It's very expensive. So let's talk practical dentistry. I'm going to use a slow speed handpiece to remove that.
So, okay, then there is another question. How much is the maximum space we can cover it with veneer?
Incisally maximum is 1 mm allowed, not more than that. Proximally also 1 mm. See, the free hanging ceramic, suppose your tooth ends here, how much more you can pull is just 1 mm, either diastema or the incisal edge. More than that, it doesn't have support, it will break.
So, a small question from my side. Sir,
yeah, please.
Can you enlighten us on the provisionalization of veneers?
Provisionalization of veneers is 100% required, because the minute you do tooth prep, you cannot leave it open. So we have these guides, right? So we have these printed models already ready with that. I create a putty index in this. We pour the bisacrylates. Bisacrylates, the most popular one is Protem 4 from 3M. We put that into the patient's mouth, and then that sets in about 5 to 8 minutes. Finish it, polish it, and send the patient. Do I bond it? Generally, all the laminates are in one unit. They are not separate units. So they get mechanical interlocking and then stay. If you are very choosy, we call it spot etching. Just one spot, etching and then bonding, and then put them. It stays there.
Sir, can you take one question from YouTube, sir? One question.
Yes, I can't tell a no to you and the audience.
Sir, Renuka Chaudhary, she's asking, can you please explain when to use ceramic and when to use composite veneers?
Yeah, composite veneers, only very simple, only 2 rules. Discoloration, no composite, only ceramics. When you're talking about tooth reductions, that is subtraction of the tooth and then putting something, then it's ceramics and not composite. So what are the limitations? Indications for composite is that when it's simply adding little beauty, diastemas, space corrections, morphology corrections, all that composite is okay, but otherwise majority it's ceramics.
Thank you, sir.
Thank you.
The last 2 questions in the chat box.
You're mute.
The last 2 questions in the chat box have been already attended. So I think we are finishing the question and answer session. One more question have come. Do we need to cement Protem?
No, that's what I just explained. I generally don't do that. If you really want, put spot etching and bonding in there.
Yes, sir. So I think, sir, we are winding up with the session. Thank you so much, Mohan, sir, for the
It's my
wonderful
pleasure.
session.
It's my pleasure. Always my pleasure.
Yes, sir. So with this, we have come to the end of the forenoon sessions. Participants, kindly note, we have scheduled a lunch break before we resume the sessions by 2 p.m. We have the sessions to be resuming 2 p.m. Indian Standard Time. So hope to see you all back. Thank you so much, sir. Thank you all.
Thank you. Thank you. Thank you.
Good afternoon, everyone. We are allowing the participants in Zoom and we'll be starting the session in a short while. Thank you. Good afternoon, everyone. We are expecting few more participants to be back in Zoom. Let's stabilize the Zoom first, then we will start the session. Good afternoon, everyone. Thank you for joining us back after the lunch break. Welcome back to the afternoon session of day 2 in Horizon Unlimited. We are ready to begin the lectures in a short while. Good afternoon, everyone. Welcome back to the afternoon session of the day 2 of Horizon Unlimited. Today morning, we had very informative session by 3 eminent speakers. Dr. Jose Paul, who talked about the considerations in single tooth replacement by the dental implants, and Dr. Vivek Hegde. He delivered a lecture on the tips and tricks in endodontics. Then we had Dr. Mohan Bhuvaneshwaran, who lectured us on smile makeover with ceramic laminates. Now we are moving on to the afternoon session. Before that, let me give a short introduction about online dentistry. This virtual international conference, Horizon Unlimited, is organized by Anu Dental College, Muvattupuzha, in association with Online Dentistry. Online Dentistry is an online dental education platform that is celebrating its 13th year of establishment in 2021 with more than 20,000 followers cross-platform and has conducted more than 500 webinars during this pandemic. It is the one-stop solution for all your dental education requirements. Here is a glimpse of our accolades since establishment. you for watching. The afternoon sessions will be handled by 4 eminent speakers. First speaker is Dr. Aparna Pandya. Her topic is Recalibrate and Reboot. Second session will be handled by Dr. Manu Johns. He will be dealing with Overdentures, an upper hand in everyday practice. Third speaker will be Dr. Karthikeyan S. His topic, Orthognathic surgery, when, where, and how. Last session will be handled by Dr. Joby Peter. His topic, catch them early and watch them grow, all about mouth breathing. Without further delay, we are moving to our first session, Recalibrate and Reboot. Introducing the speaker, Dr. Aparna Pandya. Aparna Pandya graduated from Bapuji Dental College and Hospital, Davangere. Did her post-graduation from Bharati Vidyapeeth Dental College and Hospital, Navi Mumbai. She is the university rank holder for MDS Periodontology and Implantology. Her foreign accolades include ADL, that is Advanced Dental Leadership UK, and ADA CERP, that is a recognized course of dental lasers. She also has a fellowship in facial aesthetics from Jaipur University, international speaker and panelist for various scientific sessions. Apart from academic accolades, she was the finalist of Mrs. India Earth 2019 and also the title winner of Mrs. India Vivacious 2019. She is the recipient of Paramount Achievement Award 2019, World PhD Chakra Award 2021, and Top 40 Under 40 Indian Achiever for 2021 by the Indian Achievers Club. She is also an RJ, columnist, and social activist. She is also the CEO of Shaidali Polyclinic. So we have a celebrity in front of us. Wholeheartedly, I welcome Dr. Aparna Pandya. Over to you, ma'am.
Thank you so much for this wonderful introduction. I hope I'm audible. So without much delay, I would like to start the session.
Ma'am, you're audible.
Yeah, great. Okay, let's just start the session then. Okay, can you see my screen?
Yes, ma'am.
Yes, great. Okay, so recalibrate and reboot. So this is going to be a very brief session. We'll be able to only touch the important points. And we all know that the entire world is ruled by only a 2% of the people. So those are the people we call the cream people, you know, Warren Buffett, Bill Gates. Those are the familiar names. We don't know the neighborhood Sharma or Shankar or Madhavan. We don't know them. So that is the difference between the mass and the cream minority. You attending this webinar in itself shows that you aspire to be those 2%, one among those 2%. So congratulations. First of all, a great applause to yourself that you're attending this Horizon Unlimited and you're trying to make the best out of it and be the best. So in today's session, we'll be seeing maybe the 4 life zones to bounce back. We'll be having a reboot of personal life, family, practice, and wealth reboot. In between, I'll try to inculcate activities and there'll be an interactive Q&A session. But if in case we do not get the time for an interactive Q&A session, you know, you can always come back after the session and we'll be happy to clear your doubts. So first, let's start with a story. Just a minute. Okay. So once upon a time, there was this millionaire. He had every luxury in the world, anything that you can imagine, big house, big car, lot of money, and absolutely luxurious life. But he had just one problem. He had an eye pain which could not be resolved by the best of the best doctors and physicians. He tried to take several treatments, medicines, injection, anything which was put forward to him, he was ready to accept it. In spite of that, he could not solve his eye problem. So that's when he heard of this old monk who used to stay very far away. He decided to go and meet the monk to find out if he could find any solution for his eye problem. So the monk, he examined the millionaire and he found out that, there was this particular problem. And he said that there is only one solution to your problem. The man was all ears. He was really excited and he was very desperate as well to know what was that one solution which could cure his eye issue. So he asked, and the monk said that you have to look at only green color for a couple of days. Man said, all right, no problem. So he painted everything around him green, starting from his huge mansion, his car, anything and everything you could imagine. His eyes would fall on, was completely painted into green. After a few days, what happened is that the monk, he decided that he'll go and visit his patient and see how is he doing. So the monk went to visit the very rich man, and as his servants saw this monk approaching towards the house, they ran towards the monk carrying a big gallon of green paint and poured all over the monk so that their master didn't have to look at anything but green. So to this, the monk started laughing and he said that if only you could invest in a pair of green glasses, you could have saved a lot of trouble. You could have saved yourself from so much of hard work and trouble. You could have saved yourself from a lot of money that you spend on it. You could have saved everything around you if only you had invested in a pair of green glasses. So what did you learn from the story? It's all about perspective. It's all about the way you look at things. So, you cannot change the world, that's for sure. But one thing most certainly you can do is you can change the way you look at things. You can change your perspective. That is what makes a whole lot of difference. That's what makes the majority different from the minority, the mediocrity different from the best. That's where we have to work on. It's all about attitude. It's all about looking at things differently. So I'm sure you know him. He's Dhoni, very, very, very famous. I'm sure everybody knows him. So in an interview, he's known for being very, very calm and composed, if you know. Whether the team is losing or winning, you will see the same expression on his face, calm and composed. So once in an interview, he was asked, how do you stay so calm, while the team is winning or team is losing? You're very calm. What is your secret? Please share with us. So to this, Dhoni had said that the only thing I focus is on what can be done. It's so important. I want you all to focus on this. His answer is so inspiring. What he said is, he focuses only on the things that can be done. What do? We always focus on the things which has not even happened. We always think of what could have gone wrong, and Dhoni thinks about what can be done. It's a big difference. It's a big, big difference in attitude. So this is the difference between great and mediocre. Now, with this, we come to the BMS rule. It's very, very important. All these will be dealt in detail in a masterclass in association with online dentistry, which will be coming up very soon. Everything will be going into detail, but right now, due to time constraint, we are going to go in a very compressed fashion. So BMS rule is nothing but body, mind, and soul. We all have 24 hours. You have 24 hours. I have 24 hours. Everybody have only 24 hours. It's about what you do in this 24 hours that matters. That is going to create the difference. So we have to balance our work and life all in this given amount of fixed time. Nobody is given a gift of 26 hours or 28 hours. Nobody is deprived of 24 hours and given only 4 hours or 5 hours in a day. So we all have that same, we all start with that same, same line in the race. But what matters is what we do in the race. So today I want all my participants to promise me that out of your 24 hours, you are going to give me 1 hour every single day. So this 1 hour, not exactly for me, but for yourself. But what you're going to do in this 1 hour is purely selfless dedication and love for yourself. So what you're going to do is, in the BMS rule, we have seen first is body. So 20 minutes out of that 1 hour, I want you to completely dedicate for your physical activity. It could be absolutely anything. It could be playing a game, skipping, or it could be doing dumbbells, going to the gym, absolutely anything. But 20 minutes of compulsory physical activity is necessary. Be it pandemic, be it anything, whatever might be your circumstance, if you can get up and walk, you will do physical activity. So this is a banana sapling. Can you expect apples to grow on banana sapling? Of course not. You cannot expect that. So how can you expect to eat junk food and be healthy? So this quote is so beautiful. I want you all to listen so carefully. You are what you eat. Whatever you put into your mouth is what you become. You cannot put unhealthy food and expect to be healthy. So from today on, promise me that you all are going to be very, very conscious of what goes into your body, because that is what you are going to become. Be like a bird. Try to have healthy snacks. Healthy snacking is very, very important. Just because you have this habit of snacking around, it's not absolutely bad. You can snack around on fruit, raw vegetables, salads. So it's very, very important. So as important as your body is your mind. So I want you all to invest 20 minutes every day out of that 1 hour I was talking about. In that, the first 20 minutes goes for the body, second 20 minutes goes for your mind. Readers are leaders. Readers are leaders. It is so, so important. Just the way exercise is important for your body, food is just the way food is important for your body, exercise is important for your body. That way itself, it's very, very important to exercise your mind. Read good book. Just the way food is fuel for your body, good information is fuel for your mind. It sharpens your mind. Most of us, majority of us, whenever we conduct this courses, when we ask people, how many of you all read books after your college, after you passed out from college? There are very, very few hands that goes up. And out of these few hands, they are the ones who have read books once in 2 months, once in 3 months. Once a case comes up, just when you have a particular case, that's when you read that particular topic. That's not how things work. No, you have to have that continuous learning habit. It's very, very, very crucial. Very crucial. Warren Buffett has said that the more you learn, the more you earn. Isn't it so true? Learning never stops. The actual problem lies when learning stops. Growth stops when learning stops. You no longer grow as an individual if you stop learning. So it's very, very important that we continuously train our mind, challenge our mind, and keep our mind sharpened. There are studies which shows that professors are less likely to get, psychiatric disorders, and they are less likely to have Alzheimer's. That is because they're continuously training themselves. They have to teach. So first step to teaching is learning. Continuous learning is absolutely important. And so this no longer these days crows don't drink water by putting stones. These days our modern crows, they use straws. So we are no longer in the information age. Now we are in the social era. We are surrounded by information, a lot of information. Now what we really want is to keep updating ourselves with the things that matter. So it's very, very important that we do that. This is my favorite quote of Robin Sharma. To double your income, you have to triple your investment in self-development. Self-development. Formal education will give you just a living, but self-education is going to create a fortune for you. It's very, very important that you keep learning never ends. Now, the beautiful part that once you come out of college, you choose what you want to learn. You have the liberty of learning what you like. Unlike in college or schools when you have to learn what you are told to learn. Now you have the liberty to learn what you want to learn. That is going to make a huge, huge impact. And whenever you join a course, always remember that the priority is not the cost of the price. It is the value that you're going to get from the course. Always focus on who is the mentor, who is the speaker, and then invest it, because what you're going to get out of the course is going to be a lifetime investment. Okay, so even in case of a pencil gives you a beautiful life lesson. What the pencil teaches us is that what is within you is so important. What is within the pencil? Lead. Okay, so unless what is within you comes out, you cannot create an impact. Without sharpening your pencil lead, you cannot write beautifully. You cannot create an impact. So that is the wonderful lesson that pencil gives us. Now coming to the S part of BMS, soul. So I want you to invest 20 minutes in your soul. How do you do that? So very simple. Now the common misnomer is over here is that people confuse between being alone and being lonely. They are two different things. Sometimes, say for example, sometimes when you are with your friends, you feel when you're sitting with your friends, you feel lonely. You feel that you're not involved in the conversation. Has that happened to you? So that's being lonely, even in the crowd. But being alone can be so productive, so productive. 20 minutes you have to spend with yourself. No smartphone, no family, no friends, nothing, just you in a room. Promise me, from today on, 20 minutes just for yourself, your soul. That can be so rejuvenating. What you have to do is, if you like to meditate, you can do that. But if you're not a good, if you don't prefer meditating, just sit in silence. Just sit in silence. Contemplate. Think about your entire day. Just sit in silence. Your mind is going to be so calm and composed. You're going to get answers like in a jiffy. It's going to create a huge impact. Try inculcating BMS rule from today onwards. So this is you and me. We sleep with our phone, we wake up with our phone. Phone has become a wireless organ in our body. It's just a part of our body. You feel incomplete if your phone is not in your hand or not around you. So even this is very familiar for you. You are in a family dinner and then there's this phone ringing, there's this ding dong notification messages coming around and you're completely distracted. You're with your family, but not exactly with them. Now, I don't understand what is happening. People are constantly being distracted. There's this smartphone syndrome which is happening. Even if you're not having your phone in your hand for 2 minutes, do you feel that restlessness, that anxiety? Like, what if somebody, your phone is right there, it's in ringing mode, but still you are like, what if some message comes? And if message doesn't come, you still want to see. Why has it not come? That is the smartphone syndrome that we are all suffering from right now. What is it that we are expecting? Are we expecting PM Narendra Modi ji to call us and say that, my God, Sukumar, you have this, I was just calling you to tell you that I want to give you a membership in Joint Parliamentary Committee or something. Or if you don't pick up the call, it will be a huge loss for the nation. What is it? Now, if you don't know this person, this is Kumar Mangala Birla. If you still cannot relate to who he is the chairman of Aditya Birla Group, which is an empire of more than 5 lakh crore. So in an interview, he was asked that how do you manage your family time? You have this huge empire. How do you actually manage a family time? So Neerja Birla, who is the wife, this is their family photo. So Neerja Birla said that there is one rule in their house. At 8 p.m., the entire family members, everybody should give their smartphones to the mother of Kumar Mangala Birla, and then only then they sit for dinner. It's a rule, it's a ritual in their house that they will all give their smartphones, keep it away, and sit for dinner. Aditya Birla, chairman of Aditya Birla, can do that. He can afford to keep his phone away for his dinner time. But you and me, we cannot do that because we are expecting some important calls, and yeah. So this is Sachin Tendulkar. Now this is again another inspiring personality. He's also called the god of cricket sometimes. Yeah. So he was he told in an interview that He does not check his smartphones in the morning unless he practices 500 balls. 500 balls every morning. After that, only he checks his phone. So to that, the interviewer asked, what if the previous day you had scored a century and you want to know what photo of yours is posted on social media, or what caption have they given about you? Aren't you curious to know that? So to that, he said, if I waste my time to check my phone in the morning, I will not be able to reach where I want to reach. It is so important. I'm going to repeat it again. I will not be able to reach where I want to reach. So Sachin Tendulkar, a celebrity, does not check his phone before he practices 500 balls to check about what is written about himself on social media. But you and me, we have to check our phones to see what people have posted about other people. What an irony. Okay, so now if you are inspired with at least one person inspired with these real life stories, I want you all to take up e-fasting. So what is e-fasting? E-fasting is just regular fasting. Everybody should do it. Everybody must do it. You have to try it and let me know what is the result. Okay. So for 15 days, you're going to keep your electronic device, your smartphones, away from you for 3 hours. 3 waking hours, not when you're sleeping. Don't tell me that, I kept it for 6 hours away from me. No. 3 hours of waking time or in your day, you're going to keep your smartphone away. And you can not necessarily a tech chain, this is a tech chain, but you can keep it absolutely in any secure location, like probably your cupboard, or give it to someone you trust, your spouse or your family member, your mother, anybody. Keep it anywhere, secured location, but you will not touch it for 3 hours. And after this 3 hours, when you take your phone, immediately you're not going to open and check your messages. No. You will ask yourself, why am I opening my phone? Why am I checking my phone? Is it absolutely necessary? Only then I'll do that. And turn off all the notifications. Now, the important thing over here to note is that messages, when somebody sends you a message, that person can wait. It can never be very important. Messages can never be very important. Calls can be important. Then they have to get the answer that then and there. But messages mean that when you are free, you can check your message and reply to the message. Not that the message notification rings and then you suddenly take your phone. Oh, hi. Okay, now let me reply back. Hi. No, that is not. Because we are living in a world of complete distraction. Even 1% of focus means you're ahead of a lot of people. And the next thing I want you all to do is sanitize upstairs. 10 days of G fasting. Okay. So 15 days of E fasting, 10 days of G fasting. G fasting means no gossip. No talking about other people, what other people are doing, why they're doing, why they're not doing. All these are not a matter of your concern for 10 days. And you will keep yourself away from energy vampires for 10 days. Now, this sounds easy, but it isn't easy to talk about other people and gossip about them. And even if somebody comes and gossips to you, telling them, no, I don't want to gossip, is also not very easy. So, every time you gossip, I want you to put a penny, a coin in your piggy bank. Do this for 10 days. And at the end of your fasting, at the end of 10 days, check how much money did you spend on talking about other people. That was the amount of time you could have spent on doing something productive. Now, art of time management. This is a very, very vast topic. This is very vast. And this will be covered in detail in our masterclass in association with online dentistry. And so now the important question for you to ask yourself is, do you run your day or the day runs you? This is a very, very crucial question that I want you to ask yourself. There are a lot of strategies of time management. There is a lot of ways in which you can create more time in less time. And there is a lot of ways in which you can make the most out of the 24 hours in a day. But to start with, the important thing is knowing, having a self-awareness that you're losing your time. Having the self-awareness that, do you feel that at the end of the day, do you sit in the room and you're so frustrated that you didn't do so many things that you could have done? You could have studied so many topics, but you did not. You could have started preparing, you could have started something, but you did not. And you wonder where your time went. So after our masterclass, you're going to have this complete transformational thing, which is going to happen. But before that, I want you all to ask this question to yourself. Do you run your day, or the day runs you? And now, this is again a very familiar thing. So we all have prepared for exams. 6 months everybody have their own timeline. Some people start 6 months prior, and some people study the entire year also. There are a few people who do that. But now again, when you start your preparations, how does it happen? 6 months you are taking those huge books, and you are starting, you probably have 3-4 huge books around you, and you're making notes, you're reading, jotting down your points, and you don't have time to go to parties, you don't have time to talk to your friends, you don't have time for anything. You're preparing. 5 months, similar situation. 3 months, now you have less time. So you go to your senior and you ask him to mark those important things, put a star or put a tick mark next to the important topics, and you start reading that. Again, last 2 months, 1 month, you're going to go back. You don't have time for anything. Now you are like, okay, let me try reading just questions. And finally, 2 days before exam, 1 day before exam is the actual preparation, is when you are totally focused, and then you become Quick. Jim Quick, he is actually a memory coach. He's a very famous memory coach. So you become that person. Now you can memorize absolutely anything, because now you have the focus, what you did not have 6 months prior. So this is what Parkinson's rule says. He says that work expands so as to fill the time available for its completion, which means that, in simple words, if you have a seminar to give 2 months, in next 2 months, you start making your seminar, but you keep adding slides, you keep removing slides, then you feel that you have to add this, then you feel that it's not good enough, then you don't do something for 2 days, then after 5 days you start, you open your laptop again, some more slides, you just do things haphazardly. But 2 days, 3 days before your seminar, you actually sit down and then you focus. That is what Parkinson's rule says. He says that if you're given more time for the thing that doesn't require that much time, you are more likely to waste time. So allot time according to the need only. Don't give yourself more time. If you give yourself more time than required, you're more likely to waste your time. Communication skill. This is so important. So important. I cannot emphasize more. This is by far the most important quality that every dentist should have. If you're a good communicator, 3/4 of the battle is over. Not just with the patient, because you have to talk to your hygienist, your assistant, your receptionist. Everybody should be in part. They should all know what exactly you want. Talking to the patient is all again secondary, but first you should be able to communicate with your own staff. You should be able to communicate with the patient relatives, pleasing them. Are you a good dentist or not is actually judged by far, most importantly, by your communication skills. Okay, this could be the best example for it. I want you all to carefully watch this video.
Finally, Tanya was very excited to meet his dream boy David on their first date, and David was also too thrilled to meet Tanya. They decided to meet at 10 at a coffee shop near their house the next day, and David was there exactly on time. He called up Tanya to inform her that he had reached, but she didn't pick up. He waited 15 minutes, 20 minutes, half an hour, and kept calling, but she didn't pick up. He got very depressed and at the same time angry. On the other side, Tanya was peacefully sleeping, and finally she woke up at 10:30. The first thing she did was check her mobile. She saw David's missed calls and was puzzled to see 13 missed calls in the morning and called him up immediately. He was too irritated and started shouting at her that where was she and he had been waiting since last half an hour. Well, what was the confusion all about? Let's rewind it again and see. When both spoke to meet at 10, Tanya assumed that it would be PM, and David assumed it would be AM, and none of them confirmed about the same. They both started arguing and blaming one another. Tanya says, "Who wakes up so early on Sunday?" And David says, "Who has coffee at 10 in the night?" So as you saw, just an AM PM caused so much of an issue because their communication wasn't clear. So I hope you liked the story and learned the moral from it.
That is by far how important good communication skills are. Be it to your patients, we are going to cover all of this in detail in the masterclass. But for now, let's move on. So coming to family reboot. So if there is one thing that Corona has taught us, it is that how important family is. Family is by far our biggest support system, the biggest skeleton we have. So again, I want you to do this activity. Get a paper and pen quickly. It's a self-analysis activity. I want you all to just write numbers. Write how much time do you spend with your family each day. In total, how much time? It could be 5 hours, 10 hours, 15 hours. Just write down how much time do you spend with your family each day. Okay, once you're done with that, now you have to write how much quality time, okay? Quality time do you spend with your family each day. It could be half an hour, 15 minutes, be it any number, just write it down. And finally, how much quality time do you wish that you spend with your family? What is that imaginary number that you wish you spend with your family? I hope you are done with that. And just, it's a self-analysis thing. Just do it for yourself and don't have to show with anyone, don't have to share with anyone. Now, I want you to write 3 reasons why you're not able to spend time with your family. It could be absolutely anything. It could be because you don't have time, because you have this busy schedule, you have a lot of patients' appointments queued up, you have your timings which are not popping up. And on the other column, you have to write how do you think you can modify your day so that you can spend quality time. Maybe you can reduce the number of appointments. Maybe you can modify your day such that you can spend more time with your family. Okay, just it's a homework. Go back and do this. Now this is Warren Buffett and his beautiful wife. I'm sure you all know him. He's one of the richest men in the world. Okay, so on his 50th wedding anniversary, he has over 15 companies which are in Fortune 500, and for his 50th wedding anniversary, his 63 CEOs together they had organized parties around the world, across the world, several parties across the world. And the concluding party was in London, where they were dressed in black. Now, an interviewer, very curious, asked Warren Buffett, "What is the secret for your happily married life? What is the secret that you would like to share with us?" Now, to this, his wife answered. She didn't allow Warren Buffett to answer. She did it herself. She said that the secret of a happily married life is that not a single day in these 50 years has it been that we have not had dinner together at 8 p.m. Second thing is, there has not been a single day in a family life in this 50 years that we have not gone for a walk alone for half an hour. Every single day. And the third most important thing is, not a single day has passed by in their family life where they have not sat down to tutor their children, then their grandchildren, then their great-grandchildren, so as to impart their family values to them. Very, 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 very important. Very important. Warren Buffett has the time to do all of these things, richest man in the world. We do not have time to spend with our family. What is going wrong? We have to analyze that, and if you are inspired by this, we have strategies so that you can do it. Time blocking is one of the most important keys of time management. Time blocking that time for just doing a particular activity only. Follow SPF rule. What is SPF rule? SPF rule is spouse, pals, and family. Spouse, pals, and family. Now, if I tell you that you have to spend time with your family, you will say yes. And then after the session, you will forget it. Okay. So lectures are listened and rituals are followed. Okay. Lectures are listened and rituals are followed. What does that mean? Now, however busy you are in your day, however tight scheduled you are in a day, do you brush your teeth in the morning? Or do you say that I have a lot of patients waiting for me, I don't have time to brush my teeth, I'm going to go now? Do you do that ever? No. So that is a ritual. Now, but if I tell you, I lecture you, you have to brush your teeth twice daily for 2 minutes, you will listen to me, you will forget, you will never do it. But if I say that it's a ritual, it's a very, very important ritual that you have to brush your teeth, you will do that. That is why, even in several religions, it's not lecturing, but a lot of rituals. You have to light a lamp at 6 p.m. You have to pray to God. All these are rituals. Rituals are always followed. Okay, so coming back to connection rituals, it's very, very important that you have a connection ritual, a family time, half an hour with your family, when you spend time with your family, your mother, your children, your spouse, everybody together. Probably you could play a game or teach your children or just have a good family dinner, anything. And as similarly, very, very important is grown up time. Spend some alone time with your spouse as well. It is very, very important in this social age that you spend some alone time with your family, spouse, your husband or wife, probably just cooking together or probably just gardening or watering the plants or just talking about life or your visions or your goals, anything. But that amount of time is very, very important. I've written half an hour, but it can be more. But a minimum of half an hour should be invested in family. Should be. Okay, now this is energy vampire. There are a lot of energy vampires. What do I mean by energy vampire? Now, have you talked to someone for some time and then, after you talk, you're like, I'm completely exhausted. My God, what was that conversation? If that is what you have felt after talking to someone, so this person is energy vampire. You need to stay away from that person as much as possible. We all are on earth with limited time. We do not have time to waste on people who are draining us. They are energy sucking vampires. Stay away from them. Stay away from them. Every joule of energy that you invest on, every joule of energy that they suck out of you is the joule of energy that you could invest in something productive. So stay away from energy vampires as far as possible. How can you do it? You can do it by affectionate detachment. What is affectionate detachment? First of all, forgive them. Forgive them for wasting your energy till now. And the second thing is, very lovingly, very caringly, you have to tell, no, I will not spend time with you. But it should be in a very loving and gentle manner. So that is affectionate detachment. Now, to the most interesting part of the, most awaited and most interesting part is the practice reboot and the wealth reboot. Now, in practice reboot, we know that everybody is having wonderful practices. Why is one practice different from the second practice? It's because you have to dare to be different. What one practice is different from another practice is only by the difference in something that they're creating. What is that something? Now, if you have heard about Dale Carnegie, he is one of the pioneers in personal development, self-development, and growth. In Dale Carnegie Institute, they have done a study in which they have shown that a person's success, okay, when you say that someone is successful, how is that person successful? What are the qualities that he has? So 85% of his success is contributed to his soft skills. And 15%, a mere 15% is his knowledge. So, in other words, what you learn from schools and colleges contribute to 15% of your success. And what you have never learned in your schools and colleges contribute to 85% of your success. It's a huge number. Now, if you want to really understand this, it means that each one of us have come from colleges where we are taught similar things, more or less similar. We have all learned the similar books. Okay. Now, the knowledge that we all have is more or less similar, okay, comparable. Baseline seems to be fine. Now, soft skills, which we are not taught. Some people might be already knowing how to talk properly, their communication skill, leadership skills might be a little better. So now that contributes to the major part of their success rate, which we are never taught to. So after attending our class, our master class, even if you learn one or two things, you're already ahead of majority. Majority of people don't have these skills. So if you learn even a few things of it, you're already ahead in the race. Okay, so now again, we all have seen this. We all have seen that, our batchmates or our friends, we all know that someone who have studied with us. We have similar background, same college, same books, same teachers, same everything. But after coming out of college, one person is more successful than the other person. So what is the difference? Even if you see in clinics, most of the clinics are giving all the treatments. Okay, mostly if you go to a dental clinic and ask for a treatment, it is very rare that somebody will say, I don't practice this treatment. It is very, very rare. At least they'll get a consultant. So most of the clinics are doing all the same things. Then why is one clinic better than the other clinic? Now, there are some strategies that you can apply in your daily practice, which can contribute to a huge success. First is dare to be different. Now, if you create a small visible difference in your practice, it is going to create a huge impact. What do I mean? Now, if you're thirsty and you're asking for a bottle of water, now I keep 3 bottles of water in front of you. Which bottle of water would you choose? Now, all the bottle of water are the same. Water is just the same, okay? It's tap water. And the bottle packaging, everything is absolutely same. Which would you choose? Okay, I'm giving you 5 seconds to think. So you'd probably choose the bottle which is closer to you. Fair enough. Okay, it's all the same. So you're going to choose, you don't want to go farther, you are going to choose the one which is closer to you. Now, what if I give you one bottle in a tray and the others are just kept like that? Now, which one would you choose? Okay, now you would probably choose the one which is in the tray because it's more presentable to you. Now, on a hot sunny day, I'm offering you chilled water and the other bottles are just the same. Now, which one would you choose? Again, probably you would go for the chilled water because it's very tempting. Now, one bottle of water costs around 20 rupees. You go to a 5-star hotel and you order for a bottled water. They're going to charge you around 200 rupees. That's around 10 times more. But very happily, you will pay 200 rupees for that bottled water and you will cherish every sip of it. What has happened? Bottled water is same. It's the same water, same packaging, everything same. Only the cost is different. Now here, you are not paying for the bottled water. You are paying for the ambience. You're paying for the courtesy of the waiter. If he has said, hi, welcome to our hotel, please be seated. You're paying for that. You're paying for the sitting arrangement. You're paying for the chairs. You're paying for the lighting. You're paying 200 rupees. Very happily, very happily, you're going to do that. Now, the same scenario, I'm telling you that Ram is very poor vendor. I want you to please pay 5 rupees extra, 25 rupees for the bottled water. Will you pay that 5 rupees extra and buy from him? Most likely, the answer is no. Okay. So, what is this whole difference? What is happening here? Thing is, moment the patient enters your clinic till he leaves, he is continuously judging you. He does not know A of dentistry, but he is judging you because he doesn't know. He's trying to understand. So, you can create a difference in every single point and create a huge impact. Difference can be very small, starting from the name of your clinic to your tagline, to the way your waiting area is, to the way your receptionist is dressed, to the way your operating room is, to the way you present your treatment, to the way you present the cost, to the way you present your success stories. Every single step matters. Every single step matters. Because you're continuously being judged by the patient. He doesn't know if you're a good dentist. He doesn't know how much marks you scored. He doesn't know if you know your work or not. But he knows what he sees. If you have not read this book till now, please, I highly recommend you to read this book, Road Less Traveled. and take the road less traveled. Now, wealth reboot. Every one of us wants this dream house and that dream luxury car and that wonderful luxury destination, vacation. Everybody wants that. What are we doing about it? Okay. Now, if you see, it is very, we all are in this race to make money. Okay. Everybody wants to make money. What are we actually thinking? We are thinking of ways to make more money. What are we thinking? We are thinking of ways to make more money. How can I charge more for scaling? How can I charge more for my restorations? How can I convince my patients? How can I stop them from bargaining? This is what we're continuously focusing on. What are we doing about the money we actually earn is the biggest question. Because if you're thinking of being rich, you cannot be rich by continuously earning. At some point, you should stop working and the money should make money for you. Only if the money works for you, you can make exponential money. Otherwise, there's a limit to which you can work. Okay. So for that, you have to have complete financial awareness. As dentists, as doctors, we are great at treating. We are great at our job, but we are poor financial managers. Now, if you look at the scenario, you have seen that we're actually running out of time. Okay, so if you see that, those students who were in our schools, who were not so bright, who were those backbenchers, who didn't score as much as we did, probably took a BCom, MCom or something, and then they took a different line. They are now our financial managers. Okay, we are the ones who studied very well, tried to get admission in good colleges. We were called the bright students. We are not managing our money. Okay, we are asking those not so bright students. I'm not judging. Okay, I'm not saying that they're not good. They are good at what they do. But what I'm saying is that we are not that, we are not that dumb. We are also smart. Only thing that we are lacking is awareness. Simple things. The simple things that if you know, it's going to make a huge difference. So financial management is as crucial, as important to have awareness of, just as other dental subjects, which we are not taught of, which we do not discuss. Nobody teaches us at home about how to manage our finance. We have to learn it on our own. But important thing is having that awareness that we do not know it and start learning it. It's very, very simple. There are only few things in it. First thing is knowing where the money is going. Have a tab. Know where your expenses are. Where is it diverging? How is this money going? Where is it going? How is it going? These are few questions that you should know about the money you already have made. Then we can think about making more money. Okay. Now there are few terminologies that we have to be aware of. What is assets? What is liabilities? Most of us already know about it. But still, for those people who do not know it yet, assets are the ones which gives us money, which makes more money, and liabilities are the ones which drains money out of us. Okay. For instance, a car can be a liability because it has fuel consumption, it has maintenance costs. Most of all, there's a lot of depreciation associated with it. Now, again, house can also be if you have a huge house, it could be a liability. Okay, because you have this maintenance cost. Now, what do you do about it? How can you turn a liability into an asset? Now, if the same car is given for rent, if you give it for Ola or Uber, it's going to create some amount of revenue, cash flow. So that is how liabilities are different from assets. Assets always creates money, and liabilities drain money. Just because you want to show off, if you go and buy a car which is out of your budget, it's going to be a huge liability. That's an amazing way to create liabilities. Going out of budget. Know your budget. Stay within budget and perform. Okay, that's just on top view. And this is by far one of the most important slides of this entire presentation. Like I told you, nobody teaches about finance at home to us. Nobody does that. Parents do. It's a huge taboo in our Indian culture to talk about money problems or money or finance or how money is coming into a family or how it's spent. We do not discuss at all. Most likely, there is this one head of the family, male or female, depends. Most likely male, who will be managing the entire finance. Nobody else in the house will be knowing where all we have bank accounts, where all we have insurance, where all, what is the password, what is the login ID. Nobody knows. Let alone knowing the amount of money which we have in savings or fixed or whatever investments we have. Let alone knowing that, they don't even know where all we have accounts. Okay. Mostly females are completely ignorant about what is happening in the finance of the house. They just want a fixed amount of money and then they'll spend it on the household things. But how is the finance managed? Wife doesn't know, children doesn't know, nobody knows. If God forbid something happens to the person who is managing the finance of the home, nobody knows, nobody has any awareness of where all, what all are there. This should not be the case of you all. I request each of my participants from today on have financial transparency at home. It is very important. I'm going to repeat it again. Have financial transparency at home. It is very, very important that you discuss finance at home with your wife, with your husband, with your children. What all accounts you have, write it down. Have a tab of it. Either write it down or save it on your laptop, save it on your system somewhere where everybody can have access to it so that they know in case something happens to you also, they can manage. Otherwise, they will be completely blindfolded, knowing nothing about what is happening in the house. So from now on, all the password, all the user ID, where all accounts are there, where all your investments are there, if you have, everything should be jotted down and it should be transparent. There is nothing wrong in it. It is very important that we give some amount of financial education to our children also. If you have not started doing it, please do it. Please give them some amount of financial education. If they ask for 100 rupees, don't just open your wallet and give them 100 rupees. They should know how it comes. And if possible, let them earn that 100 rupees from you. Okay, that's all a huge topic to go into detail. So, like I said, it is very, very important. Most of the people, most of the doctors, they are great doctors, but they are not very much aware. Problem is lack of knowledge, lack of awareness. You can get information. If you know that you don't know, you can start reading. But if you don't know only that you don't know, how would you do anything about it? So this was just the tip of the iceberg. We are coming up with a master class along with online dentistry, where we will be discussing in detail from the perspective of dentists how they should do and why they should do. All of these will be discussed. But for now, we have totally run out of time. And thank you so much for listening to me. And please promise me that you will inculcate some of these habits in your daily life and create an impact. And let me know. Let me know once you do that. Thank you so much.
Thank you, Madam, for that motivational and enthralling session. It indeed was very informative for all of us. We have some queries in the chat box. The first question is from Kevin Renji. Do you have any advice for fresh graduates who wants to start a clinic but is afraid of failure due to the competition and other factors?
I'm sorry, I didn't listen to you. Yeah, can you repeat the question?
Yes, ma'am.
Yeah.
The first question it's from Dr. Kevin Renji.
Yes.
Do you have any advice for fresh graduates who want to start a clinic but is afraid of failure due to the competition and other factors?
Okay, so if you are certain that you will fail, then 100% you will fail. Okay. So what I advise you is that start it. If you start it, you will know whether you will fail or not. If you don't start, you will definitely fail. And if you start with the failure perspective, you will definitely fail. Everybody has started from the starting line. Tell me one dentist who has started a practice knowing everything. Nobody has done that. You and me, we have all started practice from scratch. Okay, now there's another case wherein you have this family, your father is a dentist, grandfather is a dentist. That's a different story altogether. But in a normal scenario, everybody is starting from scratch. You and me, we are not different. Start it. You will face a lot of challenges, but unless you start it, you will not know what are they. And we are all strong enough. See, we have survived our BDS and MBS. We can definitely have a private practice. Not an issue. If there are certain areas wherein you are not good at, call consultants. Don't be afraid of calling your friends. Call your seniors. Let them help you. But if you have the privilege of starting a private practice, do it. Do it today.
Okay, ma'am. The second question is, what is your theory regarding practical asset management for a professional who doesn't have much liabilities and has an above average income?
So can you repeat the question?
What's your theory regarding practical asset management for a professional who doesn't have much liabilities and has an above average income?
Okay, so talking about asset management, if you have above average income, and see, starting of all, like I said, we all are not great financial managers. We have to be one, but we are not great. If you have the privilege of getting a financial manager, if you have the privilege, if you have a friend who's a CA, or if you have a friend who is already in these areas of investment, talk to them. Go for lunch with them, go for dinner with them, have more acquaintance with them. Let them manage your money for some time with your awareness. What is awareness? You should know where your money is going, how it is going, why it is going. Make a tab of it, talk with them, have a discussion. So there's a very, very important, I don't know if it's a folk saying, if you know what that is. Okay? If you're Malayali, you'll understand. So they say that if you are a poor man, you have to take a rich man for dinner. Okay? If you are a poor man, you have to take a rich man for dinner. You will be like, why should I take a rich man for a dinner? I mean, why will I spend? I already don't have money for myself. Why will I spend? That's not the point. If you take a rich man for a dinner and make it a nice 7-course dinner, let him talk. What will he talk? He will talk about motivational things, about his stocks, where all he has investments, how he had a huge empire. Maybe he's boasting, but you will get inspired, and that is going to create a huge difference. And if you have to invest, start investing today. The biggest problem that we are doing is we are all in this question mark. Why to invest? How to invest? I don't know about investing. You start, then you will learn. It's a process. You never knew about dentistry. You never knew about crown preparation. Didn't you learn? We all did, right? So investment is just like that. Start investing on those safe stocks, the ones which are long term and which will definitely give you returns. Start investing in those stocks. If you have not taken insurance, take it today. Talk to 3-4 insurance companies. Talk to 3-4 agents. See which is the best suited for you. Get an insurance. These are some things that every individual should be doing in their lifetime. Start doing it.
Thank you, madam. And for the information of all the participants, if you have any more queries, it will be answered in the WhatsApp groups. Thank you, madam.
Yeah, most welcome. And so kindly share the feedback forms so that they can give us the feedback.
Yes, ma'am.
Yeah, thank you.
Participants, kindly note any queries and doubts regarding the topic should be posted in the chat box and shall be discussed after the session or in the WhatsApp group according to the time permits. Our next session is on the topic Overdentures and Upper Hand in Everyday Practice by academician and clinician par excellence, Dr. Manu Jones. Dr. Manu Jones graduated from Mar Baselios Dental College, Kodamangalam as the best outgoing student and completed MDS in Prosthodontics in 2013 with 5th rank from Rajiv Gandhi University of Health Sciences. He has secured several awards and recognitions during his undergraduate tenure itself, both for curricular and extracurricular activities. He has to his credits publications in national and international journals. Currently, he is working as assistant professor in Department of Prosthodontics and Crown and Bridge, Anu Dental College and Hospitals, Muattabura. He is also the chief mentor for the advanced implantology course conducted by Anu Dental College. and the most sought after prosthodontist and implantologist of the region. It's my pleasure to welcome Dr. Manu Jones for the presentation. Over to you, Dr. Manu.
Thank you, Dr. Pradeep, for an huge intro about me. Am I audible?
Yes, doctor, you are audible right now.
And my slides are visible.
Yes, yes.
Good afternoon, Horizon Unlimited. I'm Dr. Manu Jones. I'm a reader in Department of Prosthodontics in Anu Dental College. So first of all, let me thank the team Anu with its dynamic principal, Dr. Jiju Baby George, and the Peter HOD, Dr. Joby Peter, and the entire online dentistry coordinators for giving me an opportunity to share my thoughts with all of you. So, to start with, how many of us dentists practice complete dentures? Almost all of us. But for those who are freshly graduated, whenever a complete denture patient comes, they will think, oh my God, it's trouble because I have hardly done few cases and your patient is definitely going to come back with complaints. But most of us does complete dentures. If you do complete dentures, you will definitely have incidents like this happening. This is a viral video that you might have seen over the net. So where do you think your patient, this patient will be the next day on her birthday? She'll be there right at your practice, waiting with a complaint. So how many of us have patients coming back like this, telling that, doctor, my denture is good, but unfortunately, I can't laugh. I can't blow a candle. I can't eat anything. So that is trouble. You do one thing, you keep this denture and I'm going because I have no use with these dentures. You can expect patients like this. As I was going from Wayanad to Calicut on a curvy road, I felt dizzy and I vomited. And later only, I came to know that I had lost the denture to the highways. Or it's a Sunday morning. Your patient is telling that, doc, I went to the pond to have a dive. And when I came back, I couldn't see my dentures and God knows who is using it now. So all these are troubled situations. And you can expect in your office pairs of dentures laughing at you, which was given by your patients telling that it's of no use to me. You can actually try trimming it, scaling it, polishing it, but you are sure that your complete denture patients are going to come back because whenever you give a denture, you are marrying that patient for the lifetime because they will definitely come back to you sooner or later with retention problems. So with this mind, how did your patient miss all those 32 teeth? Keeping the Hippocratic oath to do no harm. Are you responsible or is it the patient? So I'll show you a picture of a maybe 100-year-old grandma sharing her happiness with her son. But if you notice carefully, you can see a single standing tooth which would have served the masticatory purpose of that grandma. So my idea is, if that long standing tooth has stood across the test of time, why should it be removed for giving a complete denture? So this presentation, what I'm trying to share with you is one single thought that have you ever removed a non-mobile teeth? Have you removed a teeth that is grade 1, 2, or even 3 mobile? Or have you removed a impacted third molar or therapeutically removed a single long-standing third molar for the purpose of fabrication of a complete denture? So the idea of the story is that whenever you give a complete denture or a denture, if it has to stay inside the patient's mouth, it should have a lock. So how can you give a lock inside your patient's mouth? The one and only answer for that is by giving overdentures. It can be either tooth-supported overdentures or implant-supported overdentures. Or else, what happens? Definitely your patient is going to come sooner or later. But the unfortunate thing in our curriculum is that nobody in the undergraduate level does overdentures. When we are in the prostho department, so as to complete our CD cases, what we do all the complete dentures. If there is a single tooth remaining, it will be converted into an RPD case. So we'll just send the patient as a student to the surgery department, pluck off their teeth. The patient comes after some time, you will fabricate the complete denture. In the surgery department, we'll be posted. We need to complete the cases of extractions. We'll just pluck off whatever is there inside the patient's mouth, and it's a complete denture. So none of us, or very few of us, practice overdentures regularly. What happens? What is the reason for this? The reality is that fabrication of a overdenture is much, much simpler than that of the complete denture and the subsequent patient compliance. The idea or the theory of overdentures goes with Divine's dictum, which means the perpetual preservation of what is remaining is more important than the meticulous replacement of what is lost. So, if you have a patient, which is a prospective complete denture patient, you can fabricate an awesome looking denture by removing all the teeth, doing whatever periodontal surgeries or bone correction surgeries, because there is a lot of space inside the patient's mouth once he or she is edentulous. But if he has something left over, no matter whether it's a single tooth, impacted tooth, or even a root piece, it's a trouble for you, thinking that it will create some other problems, but never. If it is possible for you to retain those things, it will help in the patient compliance and satisfaction. So the idea is not new. It was even practiced in 1856 by Ledger by leaving roots of natural teeth to support the denture. And it was known by different names, starting with biologic denture, hybrid denture, telescopic denture, and so on. So the Prosthodontic Bible, GPT, says it as a partial denture or a complete denture that covers. It need not be covering, it can even rest on one or more remaining natural teeth. It can be roots of natural teeth and or implants. That itself explains everything. So what is the basic rationale of tooth-supported dentures? The first and foremost thing that separates overdentures from complete dentures is the presence of sensory input of the anterior teeth. As you all know, if you have even a strand of hair on your tongue or your lips, you can differentiate it. So the acute sensory inputs from the anterior part of the teeth or the face helps in retaining the dentures. The dimensional perception. Just imagine you holding a piece of needle and a piece of floss. You can discriminate between the sizes of the floss as well as the needle. Maybe it's in a matter of millimeters or microns. How is it possible? That is just because of the sensory inputs that is being given by the periodontal ligament of the teeth that you have. But if it is a complete denture, your patient is entirely dependent on nothing, because there is no nerve supply that's being offered from the periodontal ligament, which helps to discriminate the size of the food particle that is between the occlusal surfaces of teeth. As you all know, the canines in the dental arch is most commonly used as an abutment for overdenture. And it is also the only tooth which is having the maximum nerve supply, which will help you to coordinate in giving retention for your overdenture. And another thing is the directional sensitivity all of you will have complete denture patients telling that when I bite on the right side, it lifts on the left side. When I bite on the left side, it lifts on the right side. So if you have a teeth that is retained, the sensory input that is being given by the nerves from the periodontal ligament can respond to pressure regardless on the direction which it is applied. It also has one more role, couple of more roles like proprioception and salivary secretion. It has an indirect role by regulating the salivary reflex and the type of masticatory stroke so that the retention is maintained. You might probably think if there is a long-standing tooth, the patient is old, it's going to shed off soon, but it is having some bone support. And that little bone support is well and good enough to give that proprioceptive inputs to the brain by which it can coordinate the mastication. So this overdentures, in short, comes with a lot of advantages. Let me brief it. It is definitely a superior method of treatment because the retention that is being offered to the patient is far anything. You might think the construction of an overdenture is complicated, but it's never so. You may be little bad in bottom molding because you might have done few cases in your undergraduate curriculum for fabricating a complete denture. But let me tell you one thing, if you fabricate a overdenture, even though you are little bad or on the downside on bottom molding or the sequence of procedures in complete denture fabrication, the retention that is offered by the overdenture will surpass the side effects or the limitations that you have in fabricating a complete denture. It's easy to maintain, and the stability, retention, and the open palate that is possible with overdentures gives the patient a lot of comfort. You might also think it is expensive or it is very expensive, but let me remind you that the expense factor of an overdenture is highly flexible. It can be almost as expensive as a routine complete denture, and it depends on the patient's affordability. It can start from nothing to everything. The overdenture procedures are also completely familiar. If you know how to fabricate a complete denture, if you know how to do a centricillation, and in FPD, if you know how to make a post-pace impression, you don't need to know anything more in fabricating an overdenture. And since there is tooth preserved, the step of centric relation recording is also easier when you fabricate an overdenture. The other advantages include, you should imagine or you should visualize that the overdentures are being supported by teeth or implants, which offers complete immobility to your dentures. So when your dentures are stable in your patient's mouth, there is no or absolutely no movement of your dentures on the soft tissues, which will reduce the amount of post-insertion complaints of the patient. I do get patients with overdentures with post-insertion complaints, but how many times? Most of your overdenture patients comes once after the insertion appointment for adjustment, where when you give an overdenture, you can expect a little bony undercut around the abutment teeth. The next week or the next day, the patient will be coming back to you, doctor, everything is fine, but I have an ulcer in that region. You just need to relieve it and everything is fine. Once your patient is happy, you can use attachments. You can even convert it into a complete denture. Like, unfortunately, if your abutment is lost due to some other causes like periodontal causes, periapical causes, or anything, you can just reline it. It's as simple as anything. Just take an impression and send it to the lab. The lab people will give you a complete denture. So the reversibility is also an advantage. And the best part is fewer post-insertion problems. As this video, my own patient only says, few disadvantages also with the overdentures. Since the volume of bone is preserved, the denture franges may also have to come over the bulky bone. As you can see in the video, the labial fullness may be a little more. And if the patient has a little compromise in dexterity, like a Parkinson's patient or a little excessively old patient, they may be finding it little difficult to clean it or taking out the denture from the mouth because the retention will be so good. But considering the advantages, especially the retention, all of it is negligible. So how to start with the diagnosis? You should evaluate the patient for the selection of abutments, its location, bone support, the space between the tooth, the number of tooth available, the masticatory load that can be expected if the patient has an opposing natural tooth, and the type and design of processes. That's an entirely different topic, but I will concise it. So how will you plan your treatment? The teeth that is there in the patient's mouth has to be evaluated for the periodontal status, the endodontic status. You will have to manage any caries. You will have to do some positional considerations, and more importantly, economics. Coming on to periodontal considerations, let me be precise. Most of the patients, it is the geriatric population that we are talking about, they will be having n number of medical issues, especially diabetes. Your teeth, the patient's teeth may be mobile. It can be grade 1, grade 2, or grade 3. But my idea is, no matter whether it is grade 1, 2, or 3, if you see bone around the tooth, try to save it. What's wrong in it? Just chop it off at the gum level, start with an RCT, and wait for a couple of weeks and see if the situation is getting better. You know why I am telling this? I have seen cases where the teeth will be having grade 3 mobility, maybe at least 10 mm of bone around it. But what is the basic reason for that mobility? You should know that that single tooth is bearing the entire load of the masticatory arch. Your patient is probably using that one single tooth for his or her entire masticatory needs. Just chop it off at the gum level, give it some rest, it will come back to its original stage. Coming on to the endodontic considerations, caries management has to be done. The tooth has to be evaluated for vertical fracture. That is the only case or a situation where I go back, take a step back, and tell this can't be managed. But if it's a vertical fracture on a lower molar, going right through the furcation, you can actually try hemisection. It comes out perfectly all right. And the other situations like perforation, broken instruments, all can be managed with a specialist support. Because when you try to remove the teeth, in the case of a perforated tooth or a broken tooth or a horizontal fracture, you are definitely going to remove a lot of bone, which is going to preserve or help in retention of your denture. Coming on to positional considerations, this is a textbook photo. They say the anterior teeth are preferred over posterior teeth. Why? Because the nerve supply to the anterior teeth is much more than that of the posterior teeth. The position is like there should be 2 teeth in each quadrant, which offers an ideal situation. It offers the best stability. A tripod configuration with 3 teeth in each arch is also good enough. But what I would say is, if you have even 1 teeth, try to preserve it, as in the picture that I had already shown. It will offer you comfort with the patient not coming back to you with complaints, and the patient also a lot of retention for the coming years, or as long as that tooth is there in the mouth. Most important thing that you will be concerned is the economics. Why economics? Whenever you tell your patient about a complete denture, you will be telling a range of money. And when you add this preservation of tooth, it will add to the intentional RCTs, it will add to the copings, it will add to the attachments, and so on. But let me tell you, it is a totally flexible option. Let's say your patient is not financially very stable. What you can do is you can just leave the teeth off and fabricate a denture around it. Nothing will happen. It will stay for another couple of years if it is not mobile. But if your patient can afford a little more money, chop it off at the gum level, do a proper RCT, and just fill it with a composite or amalgam, like the third picture that I'm showing. That is called as root copings. If the patient can afford a little more money, you can give a short coping with or without RCT. If the patient can afford more, and if the patient needs more retention, you can give a directly mounted attachment. And if the patient needs even more better attachments, you can give ball attachments, you can give multiple attachments, you can give bar attachments, and it goes on. So what I'm telling is the overdenture treatment is a totally flexible option. If the patient can afford a complete denture, he can definitely afford an overdenture. So there is no reason for removing a long-standing teeth or multiple teeth for the purpose of giving a denture. So this overdentures comes in different varieties. You can give a denture for a patient who is socially active immediately after removal of the hopeless teeth by preserving the tooth that can be retained, and that's called as an immediate overdenture. So few of the teeth are retained, few of them are removed because they are hopeless, but your patient needs a denture. You can give a transitional overdenture, into which you can even incorporate the tooth that has been chopped off. And finally, once everything is settled, you can give a definitive overdenture. But if the patient is not ready for any of this, you can just give a denture with a hole around the tooth, and that is called as a Q-cell denture. Coming on to the overdenture copings, that is the other area. Hartwell has classified copings as non-copings, copings, and attachments. I'll show a video of a patient who needed a denture. I gave him a cast partial denture, but was not ready to remove his one and only one teeth that was having hopeless prognosis. So I couldn't use that teeth for placing my clasp. So what I did is I just chopped it off at the gum level, did a post-endo filling, and fabricated the routine removable denture around it or on the top of it, and it stays till date. So those are non-coping overdentures. If your patient needs more retention, you can actually have an entire library of copings, like long copings where you don't even do the intentional RCT. You just prepare the tooth to a length of 6 to 8 millimeters and give a coping. And subsequently, you can give a telescopic coping in the dentures. If the inter-arch space is less, you can give median copings, which is about 4 to 6 millimeters. You can try giving medium short copings, which is used for supporting bar attachments, and even short copings, which is hardly 1 to 2 millimeters in height above the gum level. If the patient can afford more, you can have copings or attachments. There are thousands of attachments that is available in the market. In India, the most commonly available attachments are the ball attachments, the bar attachments, and the Sika Prisi-Clicks attachments. You have locator attachments also available nowadays. So it all comes in different ways, different shapes with different indications, but that is not in the scope of our talk. Coming on to what you should know about overdentures, the clinical procedures. Let me make it simple. The first thing that you should do when you get a patient with few teeth remaining is make an impression and articulate it. So once you have got a diagnostic cast, try to articulate that diagnostic cast with a huge piece of wax in the patient's mouth. Ask him or her to bite, and try to articulate that cast on a normal articulator. If you're planning to proceed with attachments, you may have to go ahead a little more further till jaw relation and see how much of space is there between the arches or between the teeth so that you can place an attachment. So the most relevant question comes, how much of inter-arch space do we need? So if you are going to give a short coping, so that tooth itself will take another 2 millimeters of your inter-arch space. So that is 2 millimeters. You are going to give a ball attachment. That ball attachment will take another 2 millimeters. And the ball attachment needs a nylon sleeve, which will take another 1 millimeter. The nylon sleeve will be present inside a metal housing. That is another 1 millimeter. The denture base of your teeth denture will require another 2 millimeters. So that is another 2 millimeters, which totals about 8 millimeters. And finally, the denture teeth will require another 5 millimeters. So a total of 13 millimeters is required per arch for giving a overdenture with attachment. This is the most important thing that you should know when you are planning to give an overdenture. Rest is a piece of cake. You should be considering one more thing, that if you are giving an overdenture on the upper teeth as well as the lower teeth, you need a lot of space if you are proceeding with a overdenture with attachment. So that's about something more than 20 millimeters of freeway space between the arches that you require if you are planning for an overdenture on the upper as well as lower arch. Just what you have to do when a case comes like this. You have a long-standing canine on the lower arch, multiple upper teeth, few root stems. Take an X-ray and see how much of bone is there or how much of bone support is there for the teeth. I would say if you have more than 10 millimeters of bone support, you can definitely use that teeth as an overdenture abutment, no matter whether it is grade 1, 2, or 3 mobile. Because if you take the case of this canine itself, when I had seen this case, it was grade 3 mobile. I chopped it off and I waited for a couple of weeks, started with the intentional RCT. The entire situation was changed because I believe the mobility of this tooth was due to the traumatic occlusion that was there. Okay, so what you need to do is do the necessary endodontic procedures and periodontal procedures. Remove the hopeless teeth, the totally hopeless teeth. Remove only totally hopeless teeth and just routinely proceed with the endodontic treatment and chop the tooth at the gum level. So I'll go through the pictures, textbook pictures of what need to be done. Once you have chopped off the teeth at the gum level, you can use certain drills on a micromotor. They are called piezo reamers. It comes from sizes number 1 to 6. Start with number 1, go to the apical 2/3, and for a proper impression of the post space, the root canals has to be expanded to at least number 3 or number 4, so that you can record or register the post space impressions comfortably. Okay. So once you have made the post space preparation, you should do a coronal preparation, which includes a ferrule formation. So what is a ferrule? It's a design or a metal collar that has to be incorporated into your copings so as to prevent the vertical fracture of the abutments. So that has to be incorporated into the coronal preparation. And once that's done, you can make post space impressions directly or indirectly. So directly means you use something known as pattern resins or patterns or inlay wax to record or register the imprint of the post space as well as the coronal tooth structure. But the easier way is that if you know how to manipulate light body, just inject light body into the post space with the Metapex tip. You can stabilize or you can give strength to the impression material in the post space by placing a small piece of burr or a file or even a bent metal post or even a orthodontic wire that has been bent into the shape of J and make the impression. Once that is done, you send it to the lab. The lab people will give you the copings. You just need to cement it. Once it is cemented, the procedures are same as that of a conventional complete denture. So once you get a conventional denture, you can give to the patient and the patient will be happy. You can modify the dentures if the patient's finance allows. You can remove the palate. You can give a cast partial framework to the denture in order to prevent any possibilities of fracture. Some cases, as the video I had shown previously, the patient may have an issue with the labial fullness. If the patient can afford, you can actually prepare the tooth, give telescopic copings, and give a denture which is much more comfortable to the patient. You can give attachments if the patient can afford it. You can give hybrid dentures. Let's say this is case of single long-standing third molar. You can give attachments onto it. And if your patient can't afford any of this, you can just literally make a window on the denture and place the denture around it. So that's called as windowed removable partial dentures or QC dentures. To summarize, what are the advantages that we have as well as the patient have when you have a teeth that is remaining? As far as the patient is concerned, it improves the retention manifold when you have a single long-standing tooth. As you can see in this picture, you can appreciate the amount or the chunk of bone that is being preserved. And as far as we are concerned as dentists, you are getting an RCT, you are getting a coping, and if it is a second ledu, if the patient agrees for an attachment, that is extra revenue and less patient complaints or peace of mind from the patient side. And if the patient has more tooth, more the revenue and more the comfort to the patient. What about an impacted tooth? In yesterday's presentation, as rightly told by George Polzer, why should we remove any impacted tooth? What is the need of it? Do we need to extract it therapeutically or just follow it up once in every 6 months? Because in this picture, you can appreciate the amount of bone that is being preserved because that tooth is there. You might think that once the denture is given, it will get exposed and you are going to be in trouble. Let it be exposed. If it gives trouble, you just remove it. Otherwise, for another 4 or 5 years, the patient is going to be happy because the bone is preserved. So my request to you people is think before you pluck. I hope my fellow oral surgeons will excuse. And when a case like this comes to you, you have nothing to offer to the patient. So I will summarize the stepwise procedures for an overdenture in one slide. Articulate and evaluate for adequate interarch space. Do root canal treatment on teeth that's going to be saved. Chop off the teeth near the gum levels. Make post-space impression and send it to the lab. They will do a nice job. Lute the post with or without attachments and complete the procedures like a conventional denture. Go to your home with peace of mind that the patient is not going to complain. And you have an easier way, just call any prosthodontist. They will do the job for you. But if the patient is telling, doc, I don't need this teeth, I need something better. There are options like implant supported dentures, but it comes at a price. So how can you develop retention and retain your complete denture patients? Because let me tell you, if your complete denture doesn't stay in your patient's mouth, they can be the worst publicity that you can expect. They will be telling everyone that don't go to this dentist. His denture is not at all staying in my mouth. I'm having difficulty and I'm just keeping it at the beneath the pillow. So what should you keep in mind when a prospective case comes? I will show you a slide of an Oscar-winning movie, Saving Private Ryan, starring Tom Hanks, who was a battalion leader. He was sent into the field to bring back one soldier, that is Matt Damon. What happened was that he was one among the 5 sons of a family, and he was the only one left behind because all the other brothers were killed in action. And there was an executive order from the army to bring him back to America so that he can support the rest of the family. So the entire team had gone to bring back this Private Ryan back to home so that he can support the family and the lost people. That is my idea. Try to retain what is left behind. So to finalize, the alveolar bone with its overlying mucosa was never intended to receive a full force of complete dentures. So even though the overdenture concept resembles the complete denture, it has its important differences just because of the neuromuscular perception of the retained natural teeth that is being sent to the brain. So the dental profession itself has expanded the preventive dentistry concept into prosthodontics to bring about the new prescription called overdentures. Thank you for your patient listening. Thank you, Anur and Online Dentistry, for giving me an opportunity to present my thoughts before you.
Thank you, Dr. Manu, for rendering such a wonderful talk on overdentures. You have given us great insights into the field of overdentures. So we have some queries popped up. Could you please answer them? Shall I just read it out? Veena Paul has asked about when do we use magnet-supported overdentures?
Magnet-supported overdentures are a very good option in those patients with limited dexterity. Because these overdentures, they go and seat into the mouth in a precise fashion. There is only one path of insertion. So what happens is, if you have an old patient who is having some medical issues like Parkinson's, it may be difficult for them to insert or remove the dentures. But if it is a magnet retained dentures, it's all self-aligning. You just need to keep it into the mouth. Because of the magnetic attraction, it goes and seats into its correct position. But it also comes at a good price.
Thank you, sir. Hope this answers also question. Since another question, since most of the teeth remaining may be periodontally involved, how do we evaluate their prognosis for this therapy, the overdenture therapy?
My idea is, in geriatric patients, most of the teeth will be periodontally involved. But there is something known as the crown root ratio. Whenever we start an interventional RCT and chop off the teeth at the gum level, what happens is it gives the tooth a lot of time to heal. In most cases, the periodontal problems or the mobility will be due to the trauma from occlusion. Because there are only few teeth remaining, there will be a lot of load from the entire masticatory system to these few teeth. So if you relieve the teeth of that excessive load, it heals by itself with the help of a periodontal therapy.
Okay, sir. Another question regarding the use of root stems, that how root stems can be used for overdentures and how can we evaluate these root stems if they can be used as abutments?
As I already told, root stems, if they have bone support, what's wrong in preserving them? Because these root stems, in fact, preserves the bone. I already showed you a couple of slides with one single tooth. So if it is there, it preserves the bone. If possible, try doing an RCT. If the patient is not ready for doing any manipulations on the tooth or the root stem, you can just leave it behind. Follow it up, whether if it is giving any periapical problems or any other problems concerned with the cyst. Otherwise, let it be there.
Okay, so another question about the difference between hybrid and flexible dentures. What is the difference?
This hybrid dentures, they are kind of a mix of removable partial dentures or overdentures. So you can have an overdenture coping. You can have a tooth that is not touched. As I already showed in the video, the second video, there was an hybrid denture. It's not exactly a overdenture. The anterior section, it was all overdenture copings, and it had one tooth also, the third molars. So they are hybrid dentures. Flexible dentures are RPDs only. You can give flexible overdentures, but the basic science of complete dentures is that the denture base should be rigid. It should not be flexible. So I'm not sure if flexible dentures are recommended, but when you give a flexible complete denture also, it is not that flexible. So you can proceed with a flexible denture, especially in those patients who with allergy to acrylic.
Okay, so another question about will retaining a strong unilateral canine in the mandibular region be a good option for an overdenture?
Definitely, yes. I have all my patients with only 1 or 2 teeth, mostly 1 teeth, that's the canine. You might be probably thinking, if you retain 1 teeth, will it affect the occlusion? Like if you bite on one side, will it get lifted from the other side? That is a theoretical possibility, but let me remind you, the presence of even 1 teeth can give a lot of retention when compared to that of no teeth. So why to remove it? Let it be there as long as the tooth is there.
So we have one more question, that is there any contraindication for an overdenture treatment?
I haven't seen one, but if the patient is not ready for any of this, you can at times see very skeptical patients in the house's classification, skeptical patients who doesn't need anything. They will be very adamant telling that, doc, remove all my teeth, give a complete denture. And those people, we can't help it.
Yes, sir. And about the best material for fabrication of overdentures too.
These overdentures actually are notorious for one thing, especially in unilateral overdentures. You can probably expect fractures of the overdentures at the midline. So what I would recommend is, when you're going ahead with an overdenture, you can either use a high strength or high impact acrylic base, or you can even strengthen it with a mesh, or you can even try using a cast partial framework for the overdenture, which will reduce the chances of fracture.
Thank you, sir. Due to the shortage of time, we are moving on, and any other questions shall be addressed in the WhatsApp group. Thank you, Dr. Manu, for rendering such a beautiful talk. Thank you, and we are moving on. Up next is another interesting topic by a renowned speaker, Dr. S. Karthikeyan, an orthognathic surgery on orthognathic surgery, when, where, and how. Proudly introducing Dr. Karthikeyan Sundaram, MDS, FDS, and Bachelor of Medicine and Surgery. Dr. Karthikeyan Sundaram works as a consultant maxillofacial surgeon for Shrewsbury and Telford's Hospital, United Kingdom. He is the director for the We Care Medical Group and a fellow for Cambridge Implantology course. He has special interest in head and neck skin cancer and orbital trauma reconstructive surgery, and has passed the International Qualifying Exam GDC in 2004. Dr. Karthikeyan is accredited as an oral surgery performer by the NHSC Midlands and East of England. Sir is a core member for the Skin and Head and Neck Cancer, a multidisciplinary team. He is the editorial member, a peer reviewer for the International Journal of Oral and Maxillofacial Surgery. He has been awarded the Good Practice Award by the British Dental Association in 2009. He is a faculty for the Head and Neck Skin Cancer and Reconstruction course at the Queen's Medical Center. He has over 15 peer-reviewed publications to his credit. He is a member for the British Association of Maxillofacial Surgery, General Medical Council, and General Dental Council. Other than academics, Sir is interested in cricket, golf, and badminton. We are very proud and privileged to invite the speaker for the session, Dr. Karthikeyan Sundaram. Over to you, sir.
Thank you for the very kind introduction. I'm just about to start sharing my screen. Very good afternoon to everyone from a surprisingly warm United Kingdom in September. It's usually quite cold at this time of the year, but it seems like we have good sunshine. A very interesting talk. The previous talk, it brought me back memories from my days of dentistry. So it was a wonderful talk, and credit to the previous speaker. As I was introduced, I am a maxillofacial surgeon in Shropshire, the county of Shropshire, at Princess Royal Hospital and Shrewsbury Royal Hospital in the western part of the United Kingdom. My topic today is orthognathic surgery. Now, when my dear friend Dr. Joe Spall contacted me and requested me to give a talk, he said I have to cater this to a wide range of audience, and it's not surgeons in the audience. Most often, it's dentists. I will try and keep this concise and brief because it's a very vast topic, and I'll try and give a broad outline. So for the surgeons in the audience, this might sound very basic, and for people who are not used to orthognathic surgery, some of the jargons might not appear familiar to you. So I apologize in beforehand. In terms of the broad topics that I'm going to cover today, I shall give you a brief introduction of orthognathic surgery. We'll look at why we do orthognathic surgery, look at some etiology, look at when we do them in terms of timing, how we do them. My focus at most of these points will be to try and bring the general dentists into the equation, because they are the gatekeepers for most of the cases that we tend to see in the United Kingdom and broadly around the world, because most of the patients start their journey by going to their dentists, and either a diagnosis made by the dentist or the patient has requested a particular reported for a particular problem. So I'll try and tie up the whole pathway of orthognathic surgery to the audience that we have today. I'll take you through a relatively complex case because it's got some extraneous factors, and it's important to assess the patient holistically, not just look at their deficiencies or the deformities as a case pathway. And then we'll look at some of the simpler cases, and then I'll end by talking to you about pitfalls. So what does orthognathic mean? Orthognathic in Greek, orthos means straight or correct, and gnathos means the jaw. There's nothing straight or correct about the jaw. It's in itself is a misnomer, because you tend to get different shapes and sizes in every single individual. But broadly, the field of orthognathic surgery is diagnosis. It's sort of assessment and planning and trying to figure out what the dento-osseous disharmony is, and also the allied soft tissue deformities, and try and correct it. Now, this obviously falls into categories of occlusion, teeth, skeletal, and then soft tissue. I'm going to leave soft tissue out of this because it's out of the scope of this talk, and the talk will get very long if we end up going towards soft tissue deformities. In terms of etiology, it's nurture versus nature, the typical cliche, really. If you have a genetic, most of the extreme cases of dentofacial deformities tend to be from genetic aberrations or inheritance. So we talk about craniofacial syndromes. And the environmental factors, for example, habits, the popular ones we know, the thumb sucking and mouth breathing and tongue thrusting habits, are sort of the environmental factors that come into the equation. And often, as the average practitioner who's not involved in doing super big craniofacial cases, it's usually a combination of both. So most of us dentists, oral surgeons, orthodontists who come across these cases tend to have a combination of both of these etiological factors. So the cause and effect is quite well reflected here. A little bit of history, really, no topic is complete without having a little small historical perspective. Simon Houlihan, who's an American surgeon way back in the early 19th century, is credited with the first documented orthognathic procedure. So he did some form of a mandibular body osteotomy. In those days, it wasn't called mandible, it was called a lower maxilla. There was an upper maxilla and a lower maxilla. And he was a medic. He wasn't a dentist, he was a medic. So when he set up his practice in Pennsylvania, some of the medics around him got annoyed with him. And as a jest, as a joke, they sent him a pair of chickens with broken legs to mend them because he was doing bone surgery. So he mended those chickens, sent it back to them. And the story goes, he asked them for a fee and they didn't pay him. And eventually he took them to court and successfully sued them and got money for mending the chicken. So knowing orthognathic surgery has many other advantages. Edward Angle, everyone knows Angle's classification, has heard of his name, a pioneer in orthodontics towards the end of the sort of 19th century to the turn of the 20th century. He, along with a couple of the followers of Houlihan died very young, as you can see, at 47 because of pneumonia. Whipple and Blair then went on to become quite an eminent orthognathic surgeon. They were not students of Houlihan, but they sort of followed his legacy, and they then contacted Angle and said, listen, we've got these complex patients with all these jaw deformities, what do you want us to do? So Angle gave them some ideas about how to deal with it, so thereby laying the foundation for the first embers of multidisciplinary approach that we now absolutely follow to the core in terms of orthognathic surgery. So, even back 130 years ago, Angle had the forethought of liaising with the surgeons, and he's credited with making the first splint for orthognathic surgery. Now, orthognathic surgery would be any talk in orthognathic surgery would be completely rather incomplete without mentioning Hugo Overdentures, who's the father of modern orthognathic surgery. And he and his teacher, Richard Trauner, then postulated the sagittal split osteotomy, which completely revolutionized orthognathic surgery in the mid 1950s, and since then has took on another dimension. And I was fortunate enough to listen to Professor Overdentures and also work in the same hospital he worked in the UK, but where many years after, but I was fortunate enough to see some of his old records of his old patients. And he came to the UK and lectured a few times. I mean, that's sort of a historical perspective, but the modern orthognathic surgery really in India, I have to mention this at this juncture, Professor Jinwala, Professor Srinivasan, and more importantly, somebody from the state of Kerala, Dr. Varghese Mani, really set the stall. Then the mantle was taken up by Dr. Kishore Naik. I mean, these names, when I was growing up doing my master's, were legendary names in orthognathic surgery in India, and they have done tremendous amounts of work, which now makes it easier for a lot of the younger people to follow. Why do we do orthognathic surgery? What are the aims? What are we trying to achieve here? Essentially, function is the most important factor in orthognathic surgery, where masticatory functions, respiration and speech are slightly out of the scope of this talk because of sleep apnea, cleft related, but sometimes we do get speech issues in patients who have simple dentosseous deformities, not just cleft palate patients. Aesthetics, obviously, facial harmony is important, stability of occlusion is important, and more importantly, it's a very time-sensitive concept. So you've got to start the patient on a journey and finish the patient at a certain time, otherwise you end up having issues with completion of treatment. These are the basic goals. Then we look at the specific goals, and we're all familiar with these terms: overjet, overbite, cross bites, open bites, correction of skeletal deformities in all the planes, the AP plane, the horizontal plane, the vertical plane, and again, correction of soft tissue deformities we won't touch on today, but we'll just stick to the dental and skeletal parts. In terms of the the maxilla per se, looking at the skeletal excess, it's really simple. You get the anteroposterior plane, the vertical plane, and transverse plane. You just have to imagine that, as you see in the photographs, there is a excess of the maxilla skeletal, excessive skeletal growth. That could be genetic, that could be environmental, that's caused disharmony in the occlusion and facial balance. Mandible is a little bit different because it hangs from the skull base from the condyles, so it has anteroposterior deficiency in excess. But when it gets vertical or vertical excess, it tends to rotate because it's an L-shaped bone, and you get counterclockwise and clockwise rotation that makes it complex to assess. And sometimes surgery, you might think surgery is required and you don't need to do it because it auto-rotates. But there's mandibular asymmetry with condylar hyperplasia, you have hemifacial syndrome cases. So I'm not touching on any of the craniofacial syndromes today because that's completely another topic, and it would just complicate this talk. And then you get chin deformities with genioplasty. Where we do genioplasties. We'll come to that in the next part of the talk. Simple dental deformities that we come across, they are usually the effect of either a skeletal overgrowth or just dental deformities. Vast majority of the time, I mean, when we need orthognathic surgery, there is a skeletal component. Very rarely, occasionally, we would do an orthognathic surgery to actually change the occlusive plane to improve lower facial height and harmony when the problem is only dental. But that's not in many cases. It's usually you have a skeletal problem. So you've got the typical class 1 to class 3 and all the different discrepancies that all of you are aware of. So that's sort of why we do orthognathic surgery. Now, that's sort of a brief overview. I haven't gone into much detail because we've got to keep the talk fairly short. When do we do them? And now this is interesting because surgery as a late component of orthognathic treatment, wherein the patient comes in, we do pre-surgical orthodontics, sees the dentist who does the orthodontic part or sends it to the orthodontist who does the orthodontic part, and then we tend to go into surgery, is the classic way of doing it. And in Britain, we still do a very old-fashioned traditional way of doing orthognathic surgery, where surgery is a late component. The rest of the world is changing. So typically in the UK, an orthodontic referrer would come in with the age of 15 to 17, we would see them as surgeons in a joint clinic with the orthodontist, 16 to 18. And then they would have 18 months to, a couple of years of orthodontic treatment. Sometimes it takes a couple of years, sometimes it takes a year, sometimes it's 10 months, but roughly 18 to 24 months. And then once the pre-surgical orthodontics is complete, we tend to go in for the surgical procedure, whatever the right procedures. We'll come to what types of procedures in the next part of the talk. And then they have tweaking of, after the surgery, the orthodontist tweaks the bite and gets it into the right place, fine tuning it. I mean, sometimes when we operate, we don't get ideal results, and the orthodontists tend to fine tune them. I mean, if you get a 5mm open bite, then the orthodontist will be upset with you. But vast majority of the time, they're happy to fine tune the occlusion if the occlusion is not 100%. Surgery first is becoming a fashionable thing now, and a lot of surgeons are pioneering it. Particularly, there's a chap in Spain who I admire a lot, Professor Federico Alfaro Hernandez. He is the modern great, one of the modern greats in orthognathic surgery. He tends to do a lot of his orthognathic work the other way around. So he does surgery first, and he says it does reduce post-surgical orthodontics. So it doesn't take 2 years or 18 months for them. They tend to finish in 6 to 10 months. Bear in mind, his is a private practice driven by the need to do aesthetic procedures a lot, because a lot of these patients require instant aesthetic aesthetic satisfaction rather than actually it being an occlusal discrepancy, which is usually the case when surgery is done second. And a lot of these patients are adult patients. Surgery only approach is also possible in orthognathic surgery, and often it's sleep apnea patients. Now, I'm not going to elaborate on this because, again, it's another talk on its own, but we work with respiratory and sleep studies technicians, respiratory physicians. We get patients with sleep apnea. Sleep apnea is a huge problem in the Western world. I think it's now becoming a problem in India as well, because of obesity. These patients tend to be on CPAP machines. Everyone now is familiar with CPAP machines, unfortunately, because of COVID. It's a horrible thing to have for the whole of your life. And often these patients don't look after themselves well, and they die early of pulmonary hypertension and myocardial complications. There are a fair number of patients that benefit from orthognathic surgery to improve airway in terms of the oropharyngeal and velopharyngeal airway to improve their sleep apnea, which has a huge bearing. I've known a lot of patients come off CPAP machines. Now, part of all of this is one must know when not to offer surgery. One must know when not to take on a patient for surgical procedure. One must know when not to take on a person for orthognathic treatment, orthodontic or surgery, or combination of both. So there are a group of patients, which I will touch on as we go through the talk, that you do not want to get involved in and treat them, because they're usually patients with dysmorphophobia, and they come to you with a picture in their hand saying, I want to look like, I don't know, Cindy Crawford, supermodel in my era. But those are the kind of patients you've got to be careful of. And sometimes there isn't an indication. Surgery is not the answer. The treatment or any form of therapy is not the answer to every problem, every small issue the patient has. Often you can't make that much of a difference. So we've looked at when, and I've given you a brief idea that surgery usually is second to orthodontics, particularly in the UK, but it's changing now. And this is where dentists come in as you dentists, as gatekeepers of the primary gatekeepers of primary dental care. You will see all of these patients. So awareness of dental skeletal deformities is crucial for you to pick up these patients and treat them appropriately, either with a team around you or you refer them on, however your setup is, because orthognathic treatment, surgery or orthognathic treatment is a multidisciplinary approach. So I've included the dentist here because they usually are the first point of contact, but they don't get involved in meeting and discussing the treatment plan. Some do, some are very keen. They come over and sit in our MDT meetings and want to know what's happening to their patients. But usually it's an orthodontist, a surgeon, prosthetist. A maxillofacial prosthetists are absolutely invaluable in orthognathic surgery because they are the backbone of what we do. They plan everything, they do everything for us. We plan it, but they transfer everything onto models. Now we have softwares that do it, but we still depend on models, and they make the splints for us. And these splints need to be accurate. So they're technical. I'm fortunate to work with them. They're a really good team. Clinical psychologists. I can't tell you how important clinical psychologists is. 20 years ago, when I first came to this country, there was only one unit, Eastman Dental Hospital in London, that had a clinical psychologist. No one else had a clinical psychologist. Now, I don't think there is an MDT that does a team that does orthognathic surgery without a clinical psychologist, because a lot of these patients have underlying issues, particularly the adult patients that we come across have underlying issues, and it's important to recognize and treat them. Restorative dentists, sometimes we depend on them to come and, sort of tidy up the dental issues that exists. Anesthetists is very important from my point of view. I'm not going to elaborate it, but they are very important because managing airway during an orthognathic surgery is very important. The rest of them are ancillary, again, related to sleep apnea and cleft kind of deformities. A general treatment pathway. So what happens to a patient when they walk in? So it's like anything else, like any other medical fraternity. In fact, any other specialty, really. We tend to take a history, do a clinical examination, do the investigation, get a diagnosis, then have a treatment plan, start them on orthodontics. They then complete their orthodontic treatment, then have their surgery, and then their post-operative treatment is complete, and they get debonded after 6 months, probably 6 months after surgery. But the only thing that's different is the clinical psychology evaluation, really. That's quite important. In terms of investigations, I think we all know cephalometrics, OPG. Cone beam CT is becoming quite an important tool, because we now have software that extracts this information and gives us 3D models, and I'll show you in the next slide what we do. 3D models are becoming important, but the bog standard impression and good study casts are still yet to be beaten. And someone like an old dog like me, who's trained in the old-fashioned way to start with, now I've converted myself into using a software to plan these patients. I still depend on study models. My eyes look at study models, and I find that that's more informative than depending on a software. Sorry, I've just gone into some sort of, there we are. Planning and assessment. So as I said, model analysis is important. We have photographic analysis. We got true lateral photographs taken for patients. What happens with these modern softwares is as you can see, that's one of the patients who's had planning done. So the photograph gets inserted into the software. The cephalometric X-ray gets amalgamated into the software, and then we're able to then pull over a soft tissue cover. The software then produces a 3D image for us, and we can plan it. 25 years ago, when I was a resident, or even longer than that, when I was a postgraduate resident in India, in Annamalai University, I used to sit and trace these things in a butter paper or tracing paper and cut them and realign these pieces of paper to find out what profile it produces. But that was invaluable learning, because that's the basis we still use even in these computerized software. Cephalometrics can be amalgamated into true lateral photographs, and as you can see, we can move these jaws and move the teeth and create the different angles and harmonize the facial sort of the balance, and we can actually predict soft tissue. But soft tissue prediction in orthognathic surgery was the holy grail till the software industry took over, because we just the soft tissue changes were unpredictable to start with, but now we have the ability to predict. Splintless surgery is coming. It's gonna become common. I want to elaborate on it, but the 3D stereophotogrammetry is something that all of us need to know. It's going to come into our lives, and I'll spend a couple of minutes explaining to you what it is. It is essentially multiple cameras taking photographs of a certain part or the whole body in movement. And the biggest industry it's going to be used is, if you think for a second, we buy clothes and we stand in front of the mirror as a shirt or a top or a skirt or a jeans, and we just wear them, and we think that we're going to stand still in front of a mirror and look at it and it feels good. But actually, we never stand still. We're always moving. So the clothing industry is now looking at 4D imaging, which includes movement for someone's size of clothes. So sooner or later, in the next 10 years, you're going to get a biological passport of your 4D image that will then, you can then go into a clothes shop and say, there's my image, find me the clothes. That's coming. So it's used in sports science. It's now being used in orthognathic surgery at Queen's Medical Centre in Nottingham, a couple of hospitals in London. They have the cameras, and it's coming. It's a fascinating concept. I've been to a couple of courses on these. It's an absolutely incredible concept, and it changes how we look at life in all facets of life, not just medicine, surgery, in all facets of life. We move on to how we do it. And part of how we do it is orthodontics. I work with fantastic orthodontic colleagues, and that the aim of orthodontics is really to facilitate the occlusion, level the occlusion, decompensate the compensatory movements that the teeth have had, correct all the inaccuracies, and then create an architecture that then will fit with the skeletal movement that we need to produce both functional stability, facial harmony, and a stable occlusion. That's the aim of orthodontics. So that's why they spend 12, 18, 24 months getting this right. And I work with a bunch of really good orthodontists. One of the lead orthodontists in my department is quite a senior person, and he's a wonderful orthodontist, a wonderful counsel to pick his brains. And as you can see, these are couple. Is a case where they've sort of aligned the arches for us to perform surgery. Moving on to surgery. How do we do surgery? I mean, I'm not going to go through the complexities of operating. I'll just mention some of the things. Some of the words will be familiar to the surgeon, to some dentists and some orthodontists, but some might not be, so I apologize. Le Fort 1 is a maxillary osteotomy, and bilateral sagittal split osteotomy is a mandibular osteotomy, the absolute workhorses of orthognathic surgery. So there's a Le Fort 1 osteotomy in schematics, and there is an image of a Le Fort 1 cut going across the maxilla. There's your nose, there's your teeth, and that's sort of a schematics of a Le Fort 1 osteotomy. So if you can imagine the whole maxilla is down fractured from the skull base, moved backwards or forwards, or set up impacted. They can be set down fractured. They don't produce very stable results. You need a bone graft for that. Sagittal split osteotomy, as I mentioned, Hugo Obvigeza, he's credited with it. There's a picture of one of my cases. It's hard to show sagittal split osteotomy. Essentially, you are sagittally splitting the mandible, leaving the nerve, ID nerve on the distal segment, and the proximal segment then moves freely. That has the condyle in it. So you slide the mandible forwards and backwards to set it either forwards or backwards. Genioplasty and the segmental anterior posterior osteotomies. Le Fort 2, Le Fort 3 osteotomies are uncommon. They are only done in craniofacial centers. I've done a few Le Fort 2s. I've been involved in Le Fort 3 fractures, never done them on my own. They are very complex operations. You require neurosurgery input. Vertical subsigmoid is still practiced in the UK in few of the centers for mandibular setbacks. This will be relevant to some of the surgeons sat in the audience. And distraction osteogenesis. Distraction is a concept. Again, I'm no expert at it. I've done a few distraction cases. In fact, I'll show you one of the cases. And that's about surgery, really. So there's surgery, there's orthodontics, we've covered planning and assessment, and the MDT approach. That's how we go. So that's how we go about doing the getting a patient through the pathway. Now, the next part of the talk is going to be about one case, and I appreciate this case may sound a little bit more complex than the average Skelly Class 2 Division 1 or a bimaxillary protrusion. But the reason I present this case in some of my talks, and I've done so before, is because it gives you an idea of how holistically to approach a patient and what issues you have. So this was a direct referral from a dentist. So one of the dentists in the town I practice in, this lady registered the dentist, went and saw him, and he sent me an urgent referral asking me to see this patient. It's very uncommon to get an urgent referral for orthognathic surgery. Usually you get it for cancer. We've got a 2-week wait referral pathway for cancer. We're meant to see all our cancer patients within 2 weeks of referral. And this was a 38-year-old lady who had a complex deformity, but interestingly, she had a teratoma removed from the right side of the head in the temporal region, abetting onto the right side of the face. You can see a teratoma on the left side. That's not her, but that's just an example. I don't have a picture of her when she was younger, before she had the teratoma removed, because it was removed when she was an infant. And that left her with a terrible deformity on the right side of the face and temporal hollowing. And she also had a very narrow arch palate, a skeletal class 2 profile. And subsequently, they've had a few goes at trying to fill her temporal bone, and also and a zygomatic arch was completely asymmetric, and it was pretty bad appearance. And as you can see here, She's got a pretty bad temporal hollowing. Her zygomatic arch is about 2 or 3 centimeters below where it needs to be. And that's partly because of the teratoma that was removed from that part of her head. And she had a class 2 profile. Psychologically, she was a complete mess. This clinical psychologist who works with me, he consulted her on a few occasions, even before I got to the nitty-gritty of what we need to do. I'd seen her once and referred her on to the clinical psychologist that I work with. And she was on a multitude of medications, particularly for mental health. But he said to me, the clinical psychologist said to me, underlying this, I think she's a very sensible person who would actually go through a complex treatment process. So that was a CT scan. As you can see, that's the implant on the right side of that. There's some sort of an acrylic implant there placed there, but you can see where the zygomatic arch is here, and the zygomatic arch is meant to be there. It's completely on the. It's so low, and clearly this scan shows you how the zygomatic arch is quite low down, and all the tumor that was removed here pushed this arch down. So again, we follow the same method. We go and we have a chat about her in an MDT meeting with orthodontists, clinical psychologists, anesthetists. We sit down once in 2 weeks and we discuss patients. We discussed her and we agreed the first stage was orthodontic treatment. So there's a narrow arch palate, her skeletal her class 2 profile, with compensatory movement of teeth that was then beautifully corrected and set up for surgery. So this took about 18 months. Whilst this was happening, we, as a team, we decided that it was best to remove the temporal implant and correct the zygoma first before we go in and corrected a skeletal class 2 mandibular hyperplasia, maxillary excess. So I raised a bicoronal flap. That's an incision for a bicoronal flap. We're raising a bicoronal. It was fairly common in maxillofacial surgery to do bicoronal flap for frontal bone approaches. And that's a zygomatic arch, it should be here. Zygomatic arch should be here. It was here, and that was the old acrylic implant, completely inadequate. I then osteotomized the zygomatic arch, as you can see here, and I'm using one of the materials that I absolutely love using. It's called Norian CRS, cranial replacement substitute. It's like a putty. I published on Norian CRS, I think in 2004 and 5 in the JMS on late reconstruction of frontal bone fractures. It's a wonderful, stable material to use. It's alpha tricalcium phosphate. It's osteoconductive, not inductive, osteoconductive. And it's a very stable material. We then corrected a temporal hollowing, corrected as I osteotomized zygomatic arch, fixed it to the right place. And there she is after the correction. So you can see even now her zygomatic arch is not right, but purely because you can't, it's a difficult thing to correct, but it was so low that it was worth correcting some of it, but it's not perfect, but a temporal hollowing has definitely got better. And that's her after a bimaxillary osteotomy and debonding there. So from there to there, she's had a mandibular advancement, a maxillary impaction and mandibular advancement that gives her a better facial profile and, more importantly, a better occlusion, as you can see from where she started out. And that's her. So the essence of this was she then became an administrative clerk in the hospital and told everyone her story, from being a withdrawn person in a dark space to finding herself another life. She was living on her own, didn't have a job before, to finding a job. She found a partner eventually, and she's now happily settled, works in the same hospital that I do. And she is one of our patients who talks to other patients who come in. She's she's invaluable, and I'm thankful for her. She lets me present her case in meetings as an example of a person who was psychologically affected by her facial disharmony and her dentofacial deformities, and turned her life around. And I couldn't have done it without the help of at least 4 or 5 valuable members of the team. So that's a patient pathway where we go through, assessment, planning. We look at orthodontics, and then we do our surgery, and then post-surgery, the patient gets post-surgical orthodontics and debonded, and that's an eventual outcome. The next part of it, I'm just going to run through some cases because this talk will get very long. Otherwise, I won't deal too much with it. This is vertical maxillary excess. I explained when I spoke about the different types of deformities. We spoke about vertical maxillary excess. This is a delightful young girl. She didn't have any psychological issues, but she came to us because she felt that she didn't have competent lips, and she had a very very gummy smile, and was actually struggling to masticate well. There's a functional component. She underwent a Le Fort 1 impaction, sagittal split, lower jaw advancement, and upper jaw impaction, and that's a result. But she didn't like her nose, so I ended up doing a secondary rhinoplasty on her. So we took the hump off the nose to create, and nowadays in the NHS this is not being allowed because it's a aesthetic surgery, it's not a functional surgery. So it's been I did this case about 3 or 4 years, maybe 5 years ago. This is now diminishing now in terms of what we're able to do in the health service, because it's more functional. All of these surgeries are free of cost, so they're now clamping down on aesthetic procedures. There she is, before and after. Clearly she's happy with how she looks. She's changed the color of her hair, and I think she also changed her boyfriend to suit her current looks. The next one is vertical and sagittal maxillary deficiency. So we saw an excess. This is a deficiency of the maxilla. This was a delightful girl. She wasn't bothered about how she looked. She didn't come in with a deficiency. Her problem was she couldn't bite into a sandwich. As you can see, she's got a big gap between her front maxillary and mandibular teeth, and you can see how she looked in the lateral cleft, how grossly deficient the maxilla is, and the relative mandibular excess. So we ended up doing a bilateral sagittal split osteotomy. She had pre-surgical orthodontics. Set the teeth up, do the compensations, upright the lower incisors, retrocline the upper incisors, and then we then did a sagittal setback of the mandible and advancement of the maxilla, and that's the finished result after she was debonded. She was delighted that she could eat something, bite into a burger and a sandwich and an apple, because that's, if you imagine suddenly not being able to do that, or rather not suddenly, but realizing as you grow older, this is not getting right. And as you get older, you still are struggling to eat and bite into something that's almost as basic as our human rights. This is an anterior open bite, very common. As you can see, she's actually got a class 1 occlusion relationship, but then there's deficiency in the anterior maxilla, there's excess in the anterior maxilla, deficiency in the anterior mandible. The plane at which the growth happened was wrong, so she ended up having the arch was wrongly curved, ended up having an open bite, a gummy smile. She again came in with a similar complaint. So the previous one was a class 3 skeletal profile. This is more or less a class 1, but it's got an open bite. Ended up doing a Le Fort 1 impaction. We do a posterior impaction of the maxilla, which is absolutely imperative in correcting open bites. The surgeons in the audience and the orthodontists will appreciate this. And we impact the maxilla. The maxilla is usually the maxilla is downward, and we impact the maxilla up. We have to then impact that maxilla anterior a little bit. If you overdo it, then it causes issues. So you have to impact it accurately up and to set it up. Now, with this girl, we didn't have to do we could have got away without doing a mandible because the mandible auto rotates. However, when it auto rotates, it also increases the stress in the muscles in the back of the jaw, and then thereby can cause relapse. So we ended up doing a sagittal split and just set it into the occlusion. We didn't advance it, but you can see the mandible rotating that way tends to bring the chin forward, and she's got a lovely profile compared to where she was before, partly because the maxilla has gone up, the soft tissue around it has changed, and the mandible then with a sagittal split rotated upwards and gives a better occlusal plane. This is a really lovely girl who actually was a theatre stage actor. So she came in and she said she doesn't like the look of her bite, and felt that there was every time she smiled there was a gap between her teeth. And she had a class 3 profile with an asymmetry, which is quite complex. And the orthodontists did their magic, corrected all the occlusal discrepancies. We ended up doing a Lefort 1 advancement and a mandible setback. So the maxilla was brought forward, the mandible was set back, so the class 3 profile gets corrected, and there's a finished occlusion. So this was referred by a dentist. So she went to a dentist, typical. So one of you sitting in the audience could get a patient like this, which you then refer on and then complete the treatment. So it's important to pick up these things. So the other issue with such a profile, with such an occlusion, is they are prone to get long-term temporomandibular joint issues, particularly asymmetric patients. So it's important that you pick them out, because I also do some temporomandibular joint work, and sometimes it's related to occlusion. We don't in the UK do orthognathic surgery for temporomandibular joint, prevent temporomandibular joint issues. It's usually for functional issues. The add-on is you prevent TMJ problems. We prevent TMJ problems. Rarely do we ever take up orthognathic surgery for predicted TMJ issues. So that there's facial asymmetry, and you can see it's almost 2.5 units swung to the left. The mandible, the occlusal part, and the chin line is off. We corrected it by doing a Lefort 1 osteotomy, impacted it, brought it forwards, and with a slight anterior impaction because she was showing too much teeth. But you've got to be careful with, because it's a class 3 patient. And then we rotated the mandible unequally towards the right after doing a sagittal split osteotomy to set the center line and get the occlusion. So the orthodontist has to set the teeth up in view of us doing all of these kind of movements. So they complete the treatment, and then they say, right, we now set. This is how much the maxilla needs to move. This is how much the mandible needs to move. This is the direction it needs to move. And then we get a wafer done and we complete the surgery. So it is a relatively foolproof way of doing it, but we still, during the operation, we're still dealing with soft tissue envelope. It's never predictable. So you do get difficulties. This girl, particularly, her unequal rotation of the mandible was quite tricky, because you were stretching one side of the mandible and rotating it to the other side. But that's a result. Again, she had a nasal hump. I did a secondary rhinoplasty on her just to reduce it. Very simple procedure, and she was delighted with the outcome. Now, there was one concern she had, was she was a theatre actor with her previous looks. She wondered what would happen with her new looks. We were able to, this is where the software planning came in. We were able to give her a predictive look on the software with the photographs and say, look, this is how you're going to look. We can reasonably match this. And she was quite happy to undertake the procedure, and was eventually delighted with the outcome. And I haven't heard since. So I suppose her theatre career has continued well, hopefully. To finish off the cases, a case of mandibular retrognathia distraction. Again, I'm no expert in this, but clearly it's the philosophy was developed by a Russian chap called Elizaro in the early 20th century, where he elongated long bones by making a cut in the bone, attaching 2 metal bits to the end of it and a rod in between, and then distracting the periosteal envelope to let bone deposit to distract it. It is absolutely pivotal in craniofacial cases nowadays. We've stopped doing these gruesome Lefort 3 osteotomies because we now distract every suture in the hair, in the upper third of the face, to either bring to asymmetrically or symmetrically move the upper part of the face forwards, and it's become really crucial. They do some really good work in Nottingham. They do good work down in Southampton and London. There's There are some outstanding results of distractions in craniofacial cases, but a simple mandibular case that I did a few years ago that clearly shows that's the osteotomy cut. And there's the distractor with the distraction screw in place. You turn the screw every day, and then once that screw gets turned every day, slowly the mandible then distracts, creating a gap that then stretches the periosteum, and there's bone formation. Without really going into the complexities of how distraction works, that's a simple philosophy on what works. So this lady opted to have distraction, not a sagittal split osteotomy, because it's advantageous. It produces less chance of neuropraxia, nerve damage, but there's still nerve damage in distraction without question. You do get some form of temporary paresthesia sometimes. And that's the outcome, eventual outcome. That's sort of the cases. So we've run through a few class 3, class 2s, open bite. Hopefully you've got the gist of how the workflow happens, where dentists come into this pathway very early on. You could be the orthodontist dealing with it. I know a lot of dentists do orthodontia now, and you could liaise with a surgeon. The last bit of my talk is pitfalls in orthognathic surgery. This is important because your case selection, as I mentioned previously, if you get someone walking in with a photograph of a famous supermodel in their hand and say, I want to look like this, run a mile. Do not even engage with them, because you will not be able to satisfy them. Their problem is not in their dental osseous deformity, it's in their head. You can't cure that. It's very hard to cure that. So be really careful. And also there are some tricky cases that you can come across where you might think it requires a certain type of treatment. So it's important to discuss it with your colleagues. Always give treatment options to patients. Often one of the reasons why people get themselves into a hole is because they go down one treatment option, convinced that that's the option for the patient. Always give the patient, say that you don't have to have anything done. You look perfectly okay. You've lived 24 years or 18 years or 35 years, however old they are. That's sort of always an option, but just be careful about treatment options. Always give them different options: camouflage orthodontics, surgery with orthodontics, surgery before, surgery after, no treatment. I think that's quite important. Even as a dentist, as you're starting to talk to patients, it's important to set the stall up with everyone about how you go about doing this. Orthognathic surgery is all about understanding what the patient comes in with and what you have to provide the patient with, and having the team, a systematic approach and a team around you to get these kind of things through. One of the issues that we have, or we had before, was transfer of patient records onto articulators. So the study models that were made, we would do a Facebook transfer on them, and we'll end up having inaccuracies. And from that point onwards, a wrong splint is made, and it doesn't fit whilst you've cut the mandible and the maxilla in the operating table. It doesn't fit in. So that's been circumvented to a large extent by software planning and CT scans, and that sort of approach is made our lives a lot easier. But we still have issues transferring accurately models onto a anatomical articulator. Occasionally, if you get it wrong, then you get into trouble with it. Complications of surgery: bilateral sagittal split osteotomy is renowned for producing a mental paresthesia. The inferior dental nerve gets affected. I think the figures in literature are temporary paresthesia, 50 or 60% of patients. Long-term paresthesia is down to about 10-11%, and permanent paresthesia is down to about 4 to 5%. So you do have a risk of patients losing sensation in the lower lip. With maxilla, the problems tend to be you can get intraorbital paresthesia. Vascular complications of the maxilla are rare. Touch wood, I haven't seen them yet. I haven't seen one. But you can get complications. Relapse in orthognathic surgery is not uncommon. If the planning is wrong patients end up having a worse problem than when they started off with. It is horrendous to correct a bad relapse in orthognathic surgery. It's not that straightforward. And last but not least, follow-up. These patients require, as you see, 18 to 24 months of orthodontic surgery, 6 to 8 months of post-op orthodontics, follow-up for another 2 years. You're looking at a 5 to 6 year journey to get a good optimum outcome out of these patients. So you need to prepare them from day one that this is not a paracetamol that's going to cure a headache. They are in it for the long run, and they have to see it through, because the worst thing you can do is start orthodontic treatment and decompensate them, and then they end up saying, I don't want surgery. That is a hard sell at that point. Really difficult, because then you've actually decompensated some of the compensatory mechanisms. The orthodontist is in strife. So follow-up is really important. Keeping the patient in the journey is really important, and seeing them through. I'm going to end by something my professor often used to say. I think it's a fairly common cliche in surgery, but he had repeated it 1,000 times. It stuck in my head. He was my mentor for 4 years. I think I've got another mentor of mine sitting in the audience, but he was a mentor of mine for 4 years, and I did my postgraduate surgery, and he gave me certain skills that I hold good to this day, and I thank him for that. God bless his soul, he's no more. But this is something he often used to say applies perfectly to orthognathic surgery and orthognathic treatment. Timing and knowing when to do an orthognathic surgery is very important. Thank you one and all for your patience and listening to me, drabble on about orthognathic surgery, but hopefully it gave you an overview and gave you an idea of what's involved. Thank you.
Thank you, Dr. Karthikeyan, for rendering an in-depth insight on orthognathic surgeries. It was indeed very informative and useful, sir. We have a couple of questions. May I read out them?
Sure. Sure.
So the first one is, how often do you prefer surgery first approach in cases which may be indicated for?
Surgery first approach is usually patient driven. It's usually for aesthetic reasons. They come in, usually it's in private practice. They come in, they want a quick change in their facial harmony and their facial profile, and then surgery is indicated. Vast majority of the time, we tend to do orthodontics first. Although that is being challenged and changed, particularly in Europe now, that I have done maybe 5 or 6 surgery first cases now, and they all have had reasonably good outcomes. We haven't come to the end of the treatment pathway, so we wait. That's why I haven't presented them, but we tend to do them. It's not an issue as long as you pick the right case. And as long as you make the right movements and the patient understands at the end of surgery, their facial harmony will be good, but their occlusal harmony wouldn't be as good and still requires at least 6 to 8 months of orthodontic treatment. But figures say that orthodontic treatment is concised or shortened if you do surgery first. So it might change in future, in another 10 years' time, that might become the norm.
Thank you, sir. And one question personally from me, sir. What is the extent of maxillary advancement or setback which is sustainable without much relapse, sir?
Good question. Setback is not something we attempt. It's quite difficult to set a maxilla back. You'd have to take off the pterygoids to set a maxilla back. You can impact a maxilla. I have that class 3 case. One of the pictures earlier in the occlusal discrepancy that I presented was a young chap. I don't have his whole complete set of pictures, but I remember moving his maxilla by 12 millimeters. I have moved them by 14 millimeters. The problem with the soft tissue envelope and the soft palate, you've got to mobilize the soft palate well. And usually we now, particularly for impactions, and this is now, sorry, I'm digressing completely. This is going into surgeon mode. We only fix the anterior part of the maxilla if you're impacting them, because the back, we don't want to fix it. We want to let the orthodontist have the maxilla sprung up so they're able to put the occlusal pressure so it sets it up. But if you're advancing the maxilla that far forward, then you'll have to fix it at the back and at the front. But even when we fix it at the back, it's just 2 whole plates. You don't need rigid fixations at the back, but you have to fix it if you advance it that far forwards. But it's unusual to advance it that far forwards. We tend to get very disharmonious movements if you advance it that far forwards. That's why we set the mandible back, and obviously your rickets aesthetic line comes into play, and you know where the lip line needs to be.
Thank you, sir. Dear participants, if any more questions are there, kindly requesting you to post them in the WhatsApp group for clarifications. Thank you, sir. Thank you, Dr. Gaines.
Thank you very much. I thank the college, Anur College, and Online Dentistry for providing a wonderful platform and giving me an opportunity to speak to an audience. Thank you.
Moving on, up next is yet another Anurian on the podium. Dr. Joby Peter might not need a special introduction in this platform. He's the founder and academic head of Online Dentistry, dedicated to online and offline training for dentists, and have done 400 plus free webinars since March 23rd, 2020. He finished his graduation from Manipal College of Dental Sciences, Mangalore, and did his post-graduation in pediatric and preventive dentistry from Raja Muthiah College of and Hospitals, Annamalai, Chennai. To his credit, he has numerous national and international articles in various journals. He also co-authored a chapter titled Systemic Fluoride in the upcoming edition of textbook of pediatric dentistry by Professor Dr. S.G. Damle. He holds a PG diploma in criminology and forensic science. He also got certified training for Tobacco Intervention Initiative program from NIMHAMS, Bangalore. He holds to his credit the Limca Book of Records, Asian Book of Records, and Indian Book of Records for traveling for 10,000 kilometers in 27 days, covering 13 states for a noble cause, Tobacco-Free India, a nationwide campaign organized by IDA head office under the able guidance of then National President, Dr. George Thomas, and Secretary, Dr. Ashok Doble. He's a member of Indian Society of Periodontic and Preventive Dentistry, American Academy of Pediatric Dentistry, Academy of Applied Myofunctional Sciences, California, USA. Apart from being an international guest speaker for Academy of Dentists International, American Academy of Pediatric Dentistry, Kenyan Association of Pediatric Dentists, he holds to his credits more than 160 guest lectures, 110 CD programs with hands-on in IDA, ISPPD, and ADI centers at various regional and national areas. He is currently working as professor and head of the Department of Pediatric and Preventive Dentistry, Anur Dental College, Muatupura, Kerala. May I now welcome the next speaker, Dr. Joby Peter. Over to you, sir.
Thank you so much, sir. Good evening, all. Sir, am I audible?
Yes, sir.
Am my slides are visible, sir?
Yes, sir. Yes, sir, you are.
Thank you so much. So we had a 2 day of intense activity, intense knowledge gaining. Thank you so much for this support that you have given. My topic of today is a topic which is being projected in many platforms, but still I can see the support. Thank you so much for coming in large numbers here. I take my opportunity and I welcome you all to the prestigious Anur Dental College. And we all are there at your service, and we are a proud Anurian there. Thank you so much. Now, my first question to all of you, can you identify this picture? If you identify this picture, can you come to the chat box and tell me what is it? It may be a stupid question, but tell me, what is that? Can you come to the chat box and type what you see in this picture? See, it's evening time. People are tired. Hectic session today. Just to make your fingers moving an activity. What you see is here. Okay, okay. Tripod stand, Dr. Soumya. Great, great. Tripod. Okay, you're not sleeping. Good. My aim here is to make sure that you're not sleeping, because we are a huge what lectures each and every speakers has delivered the best and the maximum in a virtual world, and we should be really proud and privileged and honored for them, because they have given the best they could do that. Hats off to them. So it's a tripod stand. Yes, it's a tripod stand. Now, my next question with respect to this tripod stand is, have you ever seen something like this happening in your home? Somebody is in this posture sleeping in your home, or you heard patient coming and telling that my son sleeps like this. It's a tripod stand or posture sleeping there. It's almost the same. Bumps up, heads down, like a tripod. Support that. Now, my topic of today is not only a pediatric aspect of it, it can be applied into any aspect. And I'm very glad that Dr. Karthikeyan sir said about mouth breathing, palatal architecture, constriction, expansion, so many things are told about it. So we are talking about a condition which is 18 plus years, but I am talking about a condition which is developing very young age, and what could lead, and a dentist should know all about this. This is leading to somewhere, and how we can prevent this is my posture. The same child can sleep, and we all say so cute, but the mouth is open. 3.5, 4 years of age, the mouth is open there. And what happens if the child's mouth is open? For us, it is not that much significant. Parents, it's not that significant. As long as the child is sleeping or not causing any harm to them or not disturbing them, they are very happy. But the child is sleeping with on his dad's shoulder or mother's shoulder with mouth open. Is it significant for us? Should we think about all those things? Parents don't have any idea. As a dentist, should we think about this? As they grows up, and when they grows up, this is the one thing. This is a new normal in our home. Be it be wife, husband sleeps or snores, makes sounds when they sleep. They are irritated, or they do not have a good sound sleep at home. So it is only option for the partner to tell, shut your mouth, shut your mouth, you just shut your mouth. We start with cuddling each other, we sleep, but at the middle of the night, after some time, we comes to our reality. And it might end up in a condition where partner is pushed out. Now, when I ask parents one question I ask them, how does the child sleep? Yes, the child sleep nicely, so no problem. Okay. Then I ask one question, does the child kicks you out? Oh, doctor, he always kicks my, and we out of fear, what we do is we go and sleep on the floor, and the entire room or the bed is required for him because he does this kicking. Now, that is very significant. That takes the attention of the parents. Oh my God, somebody is asking what is happening in my family. That is very, actually it's very emotional. It's actually bonding the dentist towards the family. Oh, this dentist is something different from others. There is some kind of connection I can have with this dentist, because This is daily happening. I've been telling my husband, everybody I'm telling, but nobody's attending. But this is something which I was longing for. Why does my child get up from the sleep, cry from the sleep, kicks me, twists and turns? Nobody asked me this question. So that leads to a connection towards that patient, parents, and the family there. This is nothing but which I have not told. You must read this amazing book called Shut Your Mouth and Save Your Life by George Catlin. And one of his description goes like this. It's like a story. Okay, amazing story. You should read this book. He goes into this red African or American tribes at 6:30 p.m. almost like this time. He goes there and he can't see any lights on the house. The streets are dark. Nobody's walking in the street. And he goes to the colony and see no sound coming. Everybody is fast asleep. Nothing happens there. He comes back to London. He's from British Columbia. So he comes back to London and he walks the same thing. He just walks through his own city. And he could see that everybody's awake at 10:30. People are buzzing around, can see apartments with lights on, something is happening. And he compared and he could see there's some differences there. One place of the world, people are sleeping comfortably, very positively. Other place, it's still buzzing around. That's how he came. And he compared the disease. He compared the alignments that is happening and those community and here, and he could find a drastic difference there. That is why he came with this book around 150 years before, that Shut Your Mouth and Save Your Life there. You look around to any animal, you might have domesticated cats there, cows there, goats there. Look into them. Do they breathe through the mouth open? Apart from dogs on a hot day, if you look into any animals around you, they breathe through the nose. And only one species in this world does this, and they think it is normal. They think that it's not going to happen. What is the problem? I can survive. As long as I survive, nothing's going to happen. And dentist is there to take care of my beauty and aesthetics. So they are not worried about that part also. So I just want to tell you, do you have any idea a person who opens the mouth, whether it be a kid or whether it be an adult patient, who opens his mouth, snores or sleeps with open mouth posture like this, has got a 3 times more chance of getting early diabetes. He will be prone for that. It's a studies have said, and is 5 times more prone for cancer, to be detected as a cancer. And the most important thing is 15 times more chance for getting a traffic accidents. Now, this again takes us into one of the famous proverbs. I want to just put that one of the famous proverbs which says that a disease enters through the mouth. It's a very famous Chinese proverb. It enters through the mouth. So now I just want to mold this. With your permission, let me mold this into this. Death enters through the mouth. The disease, if enters, if sustains, it's permanently there, then invariably, inevitably, one point of time, the death enters, it has already entered through your mouth there. So we have to shut it off. We have to seal it off. And it's very important. And I'm going to talk about that. Now, a person is breathing through the nose, like that is supposed to be do that. Now, what is so importance of breathing through the nose? Why so much, so much talk is happening or videos are happening around the world about you should breathe to the nose, you should breathe to the nose, breathe to the mouth. There are different things. Why? What is that significance of breathing through the nose? Is there any significance in that? As a dentist, we should be know that. Now, to understand that, you need the basic physiology. There is no time to go into that. Let me tell you that we have a nasal cavity and we have oropharynx, nasopharynx, and hydropharynx. That's a compartment. And each compartment plays a very important role. Even though you consciously or unconsciously you're breathing to the nose, if you take a breath through your nose, this compartment plays a very important role. For example, I'm just asking you, can you take a deep breath? You know, in my offline sessions in IDA or any place, I tell them to take a deep breath. I make them relax. I tell them, okay, you're relaxed, your posture is correct. Now take a deep breath. When I ask them to do that, you know, they take a deep breath and I could see the sound. I can see the hissing sound going inside. I can see the neck going up. I can see the shoulder go beyond the ears. That's the way they take a deep breath, because that's what when we ask them to take a deep breath. But I just want to show you, I'm going to take a deep breath. When I say deep breath, doesn't mean that you have to breathe deeply to create that sound or create that expression like this. No need for that. When I ask you to take the deep breath, or if you look into me, I'm taking a deep breath, but you can't see any sound or any expression. Let's see how it has been done. So I'm going to take a deep breath on my count. 1, 2, 3. I'm going to take a deep breath. But just observe what is happening. Does any sound you're hearing, any movement you're hearing it? And if any movement is there, what is the movement that you are seeing? Okay. So on my count, 1, 2, 3, I'm going to take a deep breath. I took a deep breath, but you did not hear any sound. No vigorous movement, no nothing. I took a deep breath. So there are a lot of things that we need to learn. Even we instruct our patients, take a deep breath. Tomorrow you go to your clinic and ask your patient to take a deep breath. This is exactly what happens. They take a deep breath. You can hear the sound like a hiss. You can see the neck, shoulder, everything is going too much. Is that the right way to take a breath? So when you take that breath, whether right or wrong way you're taking it, but when you are taking a breath through your nose, you know what is happening? These 3 compartments is working in tandem. What are they doing there? Now, this compartment has got something called, you know, small hairs. You can see small hair, no, fibrous hair. That's a hair that is at the orifice of your nasal cavity. That's a nasal orifice. You can see that they actually filters the bigger particles. They filter the bigger dust particles or pollutants, whatever it is there. They do that and they gets pure air inside, almost like a pure air inside. And your concaves there, the inferior, superior, middle concaves are there. They just warm the hair because they are richly supplied with blood vessels, rich supply of blood vessels, and they just warm it because blood comes there. It is more, temperature is more. So when the air goes through in between them, they just make it warmer. And second thing is, you can see there are mucus secretions there. These mucus secretions, what they will do, they humidifies that. They humidify. So if filtered, warm, humidified air goes into your lungs there. And this function is done by your nasal cavity, your oropharynx, and the last part, which are those hydropharynx there. And why do we need this? Because our lungs is so delicate. It's got alveoli, and alveolus are so delicate tissues, they cannot take up this dust particles there. So a dust-free, warm humidifier air goes inside. And that is very important for easy gaseous exchange between the capillaries, and our alveoli and alveolus are very delicate. They cannot take that. And one more point I want to talk at this point of time is our nasal cavity or paranasal air sinus. They are the biggest producers of nitric oxide. And let me tell you that nitric oxide is important very much important for your normal functioning of the cell, neural cell, memory, anything you talk about it. Nitric oxide is so important to supply oxygen and maintain the normal circadian rhythm in our body. And who are the biggest harvesters or the suppliers of nitric oxide is your paranasal air sinus. So you need to breathe through the nose so that the nasal cavity supply it when you take air inside your lungs there. So what happens the other way around? If you do not, or if you are a mouth breather or a combined, it can be combined. What happens is the moment you open the mouth, what happens is the dust particles enters there. There is no filtering happening there, no filtering there. Dust enters there. Whatever dust in the atmosphere enters into your mouth. But you have oropharynx and you have hydropharynx there. There are some structures in these two compartments because you ignored the nasal cavity that is bypassed. So the rest two structures are there. Now these structures have God-given protectors are there. Still they try to protect. And now what are the protectors there? There are, so we have dust-free, less warm, less humidified air entering into your body to the mouth. Still we have protectors. And what are the protectors? We have adenoids there, we have tonsils there, which become active now because they have to become, because there are a lot of dust is there, a lot of irritants are there, pollutants are there, so they become very active there. How they become active? Because they have been constantly bombarded with irritants, so they try to absorb everything, try to block everything, and they become hyperplastic. They try to increase their cells, so they become bigger and bigger. So what happens to that? The tonsils and the adenoids start enlarged, hyperplastic they become. There is no problem, but the problem is they completely block the passage. That's a problem. They completely block the passage. So how many of you, whenever a patient says that, oh, my son or a child, or I'm a mouth breather, adult 45-year-old says, I'm a mouth breather, I breathe through the mouth. How many of you look one step ahead? Look into that tonsils. Are they enlarged unilaterally or bilaterally? Is there sufficient space present there or not? Maybe patient does not have a tonsillitis, but it is enlarged or blocking. As long as it is functioning normal, there's no infection. But how many of us at dentists look into that? In the adenoids and tonsils, do we look into that? You know, what you require is just a tongue depressor. You can buy this steel tongue depressor, which can be autoclavable, but what I use is the wooden one. Wooden tongue depressors are available like this. You can buy it in bulk and you can use this. And I even give it to the patient. And because this can be used at later stage for exercises, muscle exercises, I can use that. So this wooden tongue depressors are available. You can buy it and keep it and give it to them. Just try that. So you, along with your armamentarium of mouth mirror, probe and tweezer, if the patient complains of this, get that alone also and try to see with that. Sometimes if it is not available, even the back of your mouth mirror, back head of your mouth mirror, at least ask the patient to open the mouth, just put the tongue down and see the tonsils are enlarged unilaterally or bilaterally or not. To see the adenoids is a little bit difficult. You need some more training to do that. You can do in clinically, but you need some more training for that. Second intraoral feature is the palatal architecture. What is the palatal architecture of that patient? How narrow the palate is, how deep the palate is. Have you ever noticed that? See this palatal architecture, so constricted the palate, high arched. It's so high, tongue cannot go high because it's so pointed and deep it is. No chance for the tongue to go high. Such constricted arch it is, high arch palate or not. Is it V-shaped? No, our arch, dental arch, you know, if you ask any orthodontics, they always use round shaped wire. The wires are all round shape, you know, ovoid, squarish. So it's all round to make the arch bigger. So what kind of arch the patient is having, is it anteriorly constricted or not, is another feature, because mouth breather might have this transpalatal width. Another important factor, that is it normal for the developing age, or if the child is fully developed adult, what is a normal transpalatal width of that? Is it less or it is normal or not? Find out that. And crowding, as you all know, another feature of a intraoral feature that you can see is crowding. So guys, what I have done here is I went the reverse way. If you attend any lecture on mouth breathing, it would be other way around. It will be around extraoral feature. Now let us come to no, I went the other way. What we actually as a dentist should be looking is not the extraoral, forget about it, but what you look is from deep inside the mouth, from the adenoids, tonsils, come forward for the palatal architecture, come to the transpalatal width, see any crossbite, crowding, deep bite, overjet, see that, and then comes to the extra oral features, because you know mouth breathing can change the face and alter the face. Mouth breathing and endofacial development is closely related. If the patient opens the mouth, it entirely tilt or disturb the equilibrium position of the tongue and normal facial growth. So I am not going into detail about that, but it disturbs that. So what happens? The mouth breather becomes the facial change. Because of all these children, if you see, one of the features which I said will be present at the point that you're examining, or might have already presented, like recurrent upper respiratory tract infection was present. Oh my God, doctor, when she was 5-6 years of age, every month I used to give her antibiotics. I used to take her to pediatrician and they used to give me Moxclav or whatever, and she used to take that and she used to get over. But another 3 months, again, in a year, 5 to 6 times, she used to get that. But now it is not there. Fine. But the facial development has now already altered. That is what you see 9, 10, 11, 12 plus age of years. This is what is happened there. The face changes there. So you know that the increase in the facial, especially the lower facial height, increases for a mouth breather, because it opens the mouth. Mandible has got a downward and backward rotation that happens. So you have increased facial height in the lower part of the face there. And you can call it as a long face syndrome. You can say the maxilla is underdeveloped, mandible is posteriorly placed, retrognathic, all those things you can say, but it comes to a long face syndrome and is very evident in a mouth breather. Second thing is, as I told, receding chin. You may not have a long face syndrome, but you can see a retrognathic mandible, posteriorly placed, underdeveloped mandible, you can see, which is very evident from a convex profile. It's so pointing out down in a very young child. You can see that a convex profile pattern also you can see. And one of the things as a dentist you should look, these are all textbook and posture change. What happens for a mouth breather? Now, why does the mandible is retrognathic, or what happens, or what compensatory mechanism that is happening for the child to make him sustain? Because he has to breathe, somehow he has to survive. So what the child or the patient is doing is he's trying to bring the head forward so that the posterior airway opens up there. So there will be a change in head posture happens there. Now, once the head posture happens, the entire equilibrium of the muscle changes, because they also have to get adapted into the constant forward head posture. Imagine you have an assignment, you need to have 18 hours constantly, you have to sit to fill up the assignment, and you're putting in the computer and doing it. We have to bend the head forward. You can say, oh, my neck is paining. You know, it's happening. You will feel that. Now, for this child, it is normal for every day for 24/7. So what happens? A developing child, the bones get adapted, the shoulder get adapted, the muscle get adapted, and this posture is okay for at this point of time. But when it grows up, the child can have a lot of other problems like neck and shoulder pain, migraine, or so many postural headaches, all those things will slowly start precipitating because of the postural position of the head. From one age, it started developing because that is not natural there. So what about a normally fully developed patient? A patient is well developed face and every developed. If you look into this picture, you can see a well developed, well groomed patient where you can see that even the nose is straight. And I really appreciate Karthikeyan sir said that a bumpy nose, the nose hump, the goose hump on the nose is one of the reasons for a mouth breather, because the nose is not properly, the cartilaginous tissue which was present because of the continuous pressure, it molded to provide that happens. But in a normal developing person, you can have a normal nose, wide nares is wide enough, you can inhale and exhale, you can have a competent lips, no pressure while closing out, forwardly closed, maxilla is automatically placed forward so that posterior airway, if maxilla is wide and forwardly placed, which compartment? Remember the three compartments which I've told you, oropharynx and nasopharynx. The nasopharynx, enough wider space is given there. So maxilla is forwardly placed there. So the enough space in the posterior pharyngeal area is available. Well aligned teeth, no much crookedness there. Mandible, if maxilla is forwardly placed, mandible will just follow it that. So forwardly placed mandible you get, and a wider airway. So a well-developed, well-groomed face without this problem will have these features there. You look into any athletes, you can see a Google picture which I have taken, into a athletes like football, soccer, cricket, you can see the face are well developed there. Or you go into any models, their face, their mandible is well forwardly placed and they have a well proportionally developing face there. So I have a question for you. Can you come to the chat box and ask me this question? This is who is the father of sleep medicine? Can anybody come to the chat box and tell who is the father of sleep medicine? Anybody in the chat box? Who is the father of sleep medicine? Anybody? I'm waiting. No idea. Now I ask you this question: who is the father of Indian sleep medicine? Yeah, Mujideen, that's correct. But who is the father of Indian sleep medicine? Let me tell you, it's our own Kumbhakarna in Mahabharata. Our own Kumbhakarna in Mahabharata is the father of sleep medicine, because it's years and years, because the sleep is a very important part of our daily life there. But as you said, William C. Dement, he is the considers as the father of modern sleep medicine, because he has done so much study on human sleep, its cycle, its effect on daily routine, and has, please read his articles and some amazing articles about him. So he is considered as the father of sleep medicine, William C. Dement there. I hope we are almost towards the end. I hope you are not at this status now. Because it's a Sunday evening in India, you need to relax with the family, you go around, hang around. I don't mind. I hope we are doing, because we have 2 cases to discuss, which I have completed. It's a long-standing cases, which I have been following it up. Even though I had very difficult during this Corona time, but somehow the parents supported it. And I almost in the close stage of completion of 2 different situation that you can come across in your clinical practice there. One case is a 7.5-year-old child who came with complaints of crooked teeth. Their main complaint is a crooked teeth. So as any dentist in India, they will never walk and come and tell that my son and daughter has got a mouth breather, she's nosy. Very rarely it happens there. Here the same complaint, same as usually you experience this complaint of a crooked teeth there. So these are the pictures, and this was a situation there. And she was under a care of a dentist. Pretty good treatment the dentist did, because almost all the caries teeth has been filled, extraction done, space maintenance were done. These are the intraoral pictures. Whatever the dentist could do, a pretty good job, it has been done, but this is the condition there. Now, the thing, when I asked her, what is the problem? Now, my daughter is having a crooked, the new teeth came, are not aligned properly, so I'm worried about it. I asked them, okay, So then the question, then we start discussing with the parents. The parents say, no, doctor, what you said is right. She opens the mouth and sleeps. Even I told to the dentist also, they said, okay, mouth breathing is there. It's a very thing that is happening in my house. Okay, fine. So she is a mouth breather. So whenever this comes in our current practice, whenever the parent says that, oh, it's a mouth breather, fine, okay, mouth breather, okay, crooked teeth, mouth breather, you know, it can lead into vertical growth, it can lead to, you know, the syndromes and can cause a lot of things. Now, only 7.5 years, let me try something. So, oh, it's a mouth breather. So what should I do for a mouth breather? The current concept is give some kind of appliance, which we have learned from our textbook or undergraduate, is give a oral screen or a vestibular screen. You can name it anything. Or now the newer thing that has come, which is either silicone thing called your trainer, give them as early as and try your leg. That is what you try your leg. So when I asked this patient, okay, fine, you know, there is something, mouth breathing is there. So we need to break that. We need some appliance to break that. You need a sort of protocol to do that. The mother opened her bag and put a appliance in my table and said, sir, we have been using this for the past 7 to 8 months, but you know, she tried to put this, but she can't sleep with this. She removes it, or next day morning, I can see that it is either on the bed or down. Once she removed it and she fell over it and she broke it. So we have to refabricate it also. So many histories we hear that she can't wear this. She cannot wear this. So we came for a second opinion. Now the truth comes that we have come for a second opinion, that we tried something, it's not working. Can we do something there? Now there comes the holistic screening for a mouth breather. Any dentist who is into practice can apply this. There is no rocket science there. You don't need an additional degree or any qualification to do that, but you need to take that family into your confidence. The trick or the tip I can give you is, you need that family into your confidence. For that, you need some diagnostic protocols. Any case, even if orthognathic, even if you're root canal, even if anything, you have some diagnostic protocols to be followed to make the patient confidence in you. And once they have confidence in you, whatever you do, they will completely or follow you because they trust you. So dentists should do ethically, professionally accepted methodologies, and you should have a time to spend with the patient to make them understand this is important, this is what is happening. So you need a holistic method. I spend time with the patient. First appointment is 30 minutes to 20 minutes. In department also, even in consultation also, I take them along with me, discuss with them, have a separate chair, sat with them, show them and discuss them. It takes 20 to 30 minutes, and we have a screening form, which is a comprehensive screening form for exclusive for mouth breathing, exclusive apart from anything, just for mouth breathing, a huge screening form. We have that. And with this, we come to the list out the problems there and comes to a final diagnosis there. For this child, we had the screening form, discuss with the parent and make sure the father and mother should be there. At least mother should be there. Otherwise, sorry. Sometimes they say that my wife is working in Gulf. Fine, have a video call. Nowadays, the technology is there. Let the father sit in front of us. Let the mother comes in his video call, and I am sitting, child is sitting, father, mother is sitting. Let's have a discussion. Let me fill this form. That's very important. And we come into and this is, if you see, so many things are there, which I have no time to explain. But what I want to project here is the personal history of the particular person. Very important. This is where the parents, the family feels that this dentist is one of us. I'm connected with this dentist. He is not like a particular dentist who just takes some impression, put the clip, put the money there and go. No, he's connected. I have an attachment to him because he does things in that way. It's a bridge form. That's what the importance of personal history in our curriculum there. So I asked them whether you're drooling. Yeah, she does that, snoring, but it's all, we all do that. But have you ever asked, how is your child sleep? When does the child go to sleep? When does he get up from the sleep? How does he sleep? Have you asked about it? Does the child has got bedwetting at this 8 years of age? Is having or not? Appetite. How is your child's appetite? Is it loss of appetite or is too much? I have a patient who is a mouth breather. He want to stay awake. So what does this child does is, Amma, I'm hungry. He want to stay awake. Amma, I'm hungry. 10:30 night also, the mother is giving him chapati or something because he say, I'm hungry. He's actually not hungry. He want to stay awake. So that is why he say, I'm hungry. I want milk. I want biscuit. I want that. And he becomes overweight because he want to stay awake late and then go to sleep in the abnormal way. So, I mean, so many things are there in this case sheet, which I have shown you. Frequent upper respiratory tract infection, tired and irritable. Oh my God, when you ask this question, the mother says, doctor, 8:30 is the class. She gets up at 8 o'clock and she says, I want to sleep more, doesn't gets up and irritated, like attention deficit, all those things gets there. Chronic fatigue and poor academic performance. I don't have time to go in depth into that, but this is a comprehensive. You can take a screenshot of it. That case sheet summarizes something. It's more than the child. You are getting connected to the family, to the parents. And I'm telling you, if you do this, out of 10, 3 to 4 husbands will come. Sir, I have this problem still now. Can you help me? Or wife will tell, my husband having this problem, or husband will tell, my wife is having, or my father is having this problem. Can you help me? It is all happened. We have seen in our clinical practice. That is what dentistry is beyond our scope. We can include this in your practice. There is no scope there. So this is what in my 25 years of practice, let me tell you, mouth breathing has got a very important role into other alignments, which I have experienced personally, which I have got corrected in my wife, my children, everything we have experienced that. So there are some around 30 alignments which are there. So let's see these 2 children who is in front of you as a patient and what social responsibility is not just breaking the habit to change the family and around with you, how it can be done. So the normal respiration, to understand the abnormal, you need to understand in a normal respiration, when you breathe, you and me, if I ask you to take a breath, when you breathe, the main thing that is happening is your diaphragm is expanding and your lungs is like an expanded balloon, getting contracted, getting expanded. And who is playing the major role? The diaphragm there. And what happens? The lungs completely filled with air, the oxygen goes into the bloodstream and the carbon dioxide brought back. You are safe. You have a normal pattern there. Now, when you open the mouth, the things happens is this lungs, which is supposed to get expanded to the maximum potential to take the outside air through the nose, it goes down because you don't need to that much expansion of the diaphragm. There's a shift from the diaphragmatic breathing to the neck and shoulder because you're opening the mouth. So the neck and shoulder will become active there. So what happens? Lungs expands, but it does not expand to the potential the diaphragm can do. So maximum intake of air doesn't happen. So the reverse thing, maximum contraction of the lungs doesn't happen. Expelling out of maximum carbon dioxide doesn't happen. So a normal status come, a flat tire or a flat balloon, it survives and it keeps on maintaining you to survive. That's all, but full potential is not reached there. So what happens? It's like you open up a Pepsi bottle or a Limca bottle, the air goes out and what happens to the water? What fun into drinking a bottle which is being all aerated, gone out? No fun in that. So exactly that happens in a mouth breather. That child is being deprived or it doesn't have any sort of enthusiasm to develop because it's deprived of oxygen. Too much carbon dioxide pulled inside, which depresses everything, cannot concentrate, become irritated, become noisy, messy, cannot concentrate. And I told you the facial features also start developing and makes the child slowly mold the child into a face of open mouth posture, a mouth breather. If you search, you can say a stupid person in Bollywood movies or Hollywood movies, Tare Zameen Par, you can see, or any other Hollywood movies, you can see a stupid person is, or mouth breather is always represented as a stupid person. Child slowly develops into that. Moreover, next part of it, moreover, let's imagine this child is going to sleep. The tongue goes back, the mandible goes back. So what happens during the sleep or in between the sleep, child has to get up because the tongue is falling back and obstructing the airway there. So he has to get up there. So there is a gradual reduction in the oxygen. There is gradual increase in the carbon dioxide. Now, one problem with the carbon dioxide in the body is it is a powerful CNS stimulant. It just knocks the stimulant, say the CNS, and say, you get up, you get up. So what happens? The patient gets up. Whenever the oxygen saturation in the blood goes down and carbon dioxide increases, what happens? It stimulates the CNS and you are forced to get up from sleep. That's why child get ups, then goes to sleep. Get up and go to sleep. It's a powerful stim. So you get a disturbed sleep there. What is the authenticated methodology to find out? You need actually a help of an ENT or a pulmonologist. I would say pulmonologist will be the best. You need the help of that when you see a child with this. So you can imagine, where are we going? A child who came with a mouth breather, I made an oral screen and tried to put it inside, child is not putting it inside. Do you want to lose that patient, or do you want treated holistically or not? So that depends upon a lot of parameters. Whether should I refer to an ENT, whether should I refer to a pulmonologist, there are different parameters, but generally I'm talking about this. If you find a child who cannot cope up with this kind of things, then the one way to determine is a polysomnography. So this is a polysomnography of a child with an obstructive sleep apnea, but you won't understand. It's like we are looking into a MRI scan. Can you understand anything? The neurosurgeon might say yes, yes, yes. You will also say yes, yes, but will you understand? Exactly. If you lift up an OPG and tell the patient this patient won't understand anything, but at least patient knows that you understood something and then only you are telling to me. So this is what our position right now. We should understand in detail about it, and then we can make the patients or the parents into confidence. So forget about that thing. In this picture which I put, just look into SaO2. What is SaO2? Saturation of oxygen level. Okay, so you know this, your oxygen saturation levels. You know after the corona, everybody might have a pulse oximeter in your home. You keep it inside, you can get that exactly. Only that part I need to see. So a child or a patient went to sleep and having a sleep disturbance. At the peak of that, the patient's oxygen saturation level is drastically reduced to less than 3%. So you can see 87, he will die. 87, 88, he will go. That is why the body wants to give a signal, you are dying, get up. That is why the child gets up, suddenly gets up, or suddenly twists and turns, kicks happens, and then he sleeps for some time. Again, this cycle continues there. What happens? Oxygen saturation level goes down there. So I told you the tripod. This is available in YouTube. A video a mother has posted, the child sleeping posture, daily sleeping posture of the child. You can see he cannot sleep in one posture, and this is his favorite sleeping posture because he wants to breathe. That is I call the tripod sleeping posture. If any of your patient or any of you know has this posture, that is a sign, that is some indication that you need to take care. So that is what happens there. Our children who has this problem of simple mouth breathing can lead into a lot of other physiological problems. Into this, cannot concentrate on classes, cannot upgrade to the newer concept that is happening, cannot get restless, cannot communicate with others, or become very naughty in the class, anger, stubborn, all related to this. Now, I am as a dentist, as a pediatric dentist, I am going little away what you feel, but these are the things which can connect you to the patient, to the family, and take the help for advantage of this. So what I want to say is, what is gentler than a wind in summer? What is more tranquil than a musk rose blowing? It's the sleep. Everybody love to sleep peacefully. And what is the role of us into this science of sleep? No dentist has got a role. And what should we see as a pediatric dentist? I am so glad that I've taken this profession because I see them from this age group and I mold them, and this is my piece of cake. But adults, please do not get apprehended that adults, we can change this with the newer development in dental technologies there. So we, as a young child, as a dentist with mouth breathing, we are worried about malocclusion. Tooth are crooked, let me correct the tooth, and we are good in that. Then comes facial development. Oh, okay, the facial development might change, already changed, what to do there. But the next part of dentistry, the next step, one more step in your archive should be disturbed sleep or sleep dentistry. And as a the practicing dentist, you should be concentrating more onto that child, mother you are treating, veneers, root canals. Look into that child, see how that child keeps the mouth at rest posture. Talk to that mother, ask these questions, the screening questions. The mother will be, oh my God, doctor, I never ever, whatever you ask is there in my daughter, my son, my husband. He might say, it's a family holistic dentistry. That's the future. That's there. So this can lead into a varieties of alignments, starting from this. All are research oriented. You can search, you can see the mouth breathing or sleep apnea with this is all related there. So I do not myself to call as a dentist now. You all, after attending this, would be upgraded to an oral physician. You are not a dentist anymore. You are an oral physician because you are holistically treating. Starting from day one, which George Paul sir talked about, the myths, to Jiju sir talked about your amazing concept of drug and holistically to how to do that, and implants, to all the lectures. If you see, we are finally culminating into a part, into a composite knowledge in these 2 days, where you are not a dentist, you are not just painting the tooth, you are an oral physician, where you take about the whole body of the child there. And not only child, even adult patient will come to you. Can you please help my bruxism? Can you please help my snoring to be done? Can you please help my mouth breathings to be done? I have pain, neck pain, I have myofunctional pain dysfunction, which are all related to this. Can you please help me into that? That is what as an oral physician there. So guys, let's do a simple exercise, and we are done with that, finishing that. It's a breathing exercise, which I go into all the classes I will do. Why I'm telling you is this exercise is very important. Only one exercise I want to teach you is very important exercise. It's a simple breathing exercise. Now, I will just show you these exercises. It is 1, 2, 3, 4 exercise and 4, 3, 2, 1 exercise. What do you mean 1, 2, 3, 4? It's actually called a river exercise. It's like a flowing like a river, smooth, slowly, and that feel, and you should feel that nature in you. Every time if you feel stressed, every time you feel you are not balanced, you are irritated, something is not going your way, too much stressed, oh man, this day is hectic. Whenever you feel stressed, it can be a patient whom you are expecting, which is going to be very taunting to you, or it can be a seminar you want to present, sir is going to ask a lot of my questions, I want to get relaxed, or it can be an examination, or it can be anything, a major surgery. This is an exercise any time of your life you can participate whenever you are stressed. There is a big psychology behind that, big science behind that, but I'm not going into that. But it's a very simple exercises. 20 repeat of this exercise can really calm your body into normalcy. Your BP will come down, your stress will come down, your pressure will come down, your pulse will come down, your breathing will come down. You will become with the nature. That's called river exercise. It's been called. So that's simple exercise. 1, 2, 3, 4, 4, 3, 2, 1. It's very simple. You have to sit very relaxed position. Take some normal breath as if you are doing regularly. No, simple breath you are taking, and then start when my count 1, 2, 3, 4. When I say, you inhale. So still I said 1, 2, 3, 4. You have to inhale, and 4, 3, 2, 1. You have to exhale it out. So it's a cycle. Half cycle, half cycle. Very simple. Amazing result. You can 20 repeat. Do it for a week. You can see change in your attitude, in your profession, in your every aspect of your life. It will be changed. So what do you have to do? So on my count 1, 2, 3, you keep inhaling, not kind of inhale, very gentle, please, very gentle, no sound. And 4, 3, 2, 1, you exhale it out. So it's a cycle. So we are going to start on my count 1, 2, 3, 4, start. 1, 2, 3, 4. You inhale, exhale it out. 3, 4, 3, 2, 1. It's a cycle. I know that you may not have followed this now, because we always have that inhalation. No, it is very slowly. Very slow. 1, 2, 3. Slowly you inhale, slowly you exhale. Try this so that your body gets enough oxygen, your body flush out enough carbon dioxide. A balancing thing will come. It can change. This is one of the best first exercises we tell our patients to do when we start mouth breathing there. So for this child, what has been happening for this child is clinical assessment has been done with that screening question. We have done the clinical assessment there. Seal the lip. So child's lip is sealed. And now this is again a big thing that you need to learn. What all things can, how should do this. Initially, if you tell to seal, the mother will say, what you're talking, sir? How will we say? She will die of no, how can she breathe? A lot of questions we should go. So there's a way to make this happen in a clinical practice. But what are the powerful methodology to find out whether child is having a mouth breathing or not, to seal the lip, and the width of the seal tape, and which tape has to be used, which is the best, because hairs can be there and that can cause pulling. When you pull it out, it can cause so much pain, and child may not try to put the next time. So many things are there. How to seal and how for a mouth breather is very, very important. Which tape is the best? I will talk about some of the brands which are available there in the coming session. That you try to buy that, and I use that, and that doesn't cause that much pain and discomfort to the patient. So how long will you do? You do for 2 to 5 minutes. Ask them to do that and find out whether the child can sustain it or can breathe through the nose by sealing that. If not, we will think about an additional interdisciplinary program called an ENT referral. With the report, we have a case sheet, we have a referral form, we also have a chart where we get a report of the patient, and with this we send to the ENT, and they know, okay, fine, they tried everything, it is not possible. So then we think about this with the ENT referral. One of the ENT referral which I say that I tell them, I suspect this because she cannot do that, please do your reference. So when they see that if it is required, that ENT doctor will do a nasal endoscopy, not for all the patients, but those patients whom the dentist says that it might be required, they might do that, and they give a report saying that the hypertrophy or whatever is there. They give us report that 95% of adenoid hypertrophy is present there. So it comes into a category or classification of mouth breathing called obstructive mouth breathing, because something is obstructing, really blocking the nasal passage. Into this patient, you cannot give that oral screen or that lip seal exercise. You can't do that because child cannot do that. So what could be the option here? The final diagnosis of that 8-year-old child is a patient with a crooked teeth, whatever it is, with the obstructive mouth breather. In an obstructive mouth breather, can I start with oral screen, myo brace, lip seal exercise? No, you need the additional support, multidisciplinary support, the ENT specialist, the pulmonologist, everybody work together and they say, let us remove that adenoids or tonsils because it is causing the problem there. Once it is done, they cannot go home. They can go home, but they have to come back to your office again. And you should start. Now, the obstruction is being removed. You should start with various myo exercises. There are sequence of these myo exercises which differs from different patients. So like lip seal exercises. Now I can try slowly this exercise at stipulated time to these patients there. With a micropore tape, I told you a 3M micropore tape is one good thing that you can do. And deep breathing exercise. Deep breathing doesn't mean sound wise maximum air inside with the neck and shoulder. No, diaphragmatic breathing is the one. You should train the mother to do this diaphragmatic breathing, and they should feel, oh God, this is the way that my child's supposed to breathe, not the neck and shoulder. They should teach them that. And you know, the myo tape which has come for adults and for children, it's available in online. You can buy that. And this also, after the myo exercises, will help that patients to close the lips closer while sleeping or while activity. And at the same time, you have already trained this child to do through the nose. And additional or adjunctive appliances, a combination of appliances like Air Max and Breathe Right are the other appliances which are adjunctive into that. So you do this myo tape or do this lip tape along with that to keep the nostrils which are collapsed to make it wider. You do this additional appliances also. So for some adult patients, especially not for children, these are for adult patient who has got a collapsed nostrils or constricted at that point of time, you give these appliances along with the myo tape. So the combination treatment happens there. And this is the result of the same patient after 15 months into treatment there. Adenoidectomy was done. Then she came back, and after that we started doing myo exercises there. And the same lip seal and the vestibular screen was the appliance which is being given to her. And this is a result from 8 years. Almost she was 9.5 years of age. That was the time when the corona came there. She's almost 9.5. We can say 9.5 to 10 years. So then the corona came, and I have no follow-up with her because she also went to their native place. Parents did not come back. And what happens is last 3 months back, after the break and everything is done, they came back, and luckily the patients are being performing well from this to this. And now the canine is coming because of our myo exercises. Sufficient space was there, but still the canine is buckily coming. So we did a model analysis. Mild to moderate space deficiency is there to accommodate the canine. So we gave something called expansion appliances, an important parameter. The second phase of treatment called expansion, slow maxillary expansion. And this is appliance I delivered to her, and she's using this appliance there. So should we incorporate expansion in mouth breathers? Studies, this is one of the studies you must read. Does rapid maxillary expansion, it can be slow or rapid, have a long-term effect on airway dimensions and breathing? I have, please do not see this. I never put a table like this. So please don't ignore that. It's a review article, and just see the red column there. All the outcomes of the previous studies, what they say is it improves the nasal and remains stable. It improved the nasal airway. It improved breathing and condition and was stable after 11 months. Improved the nasal breathing and remained stable after 9 to 12 months. So either slow or rapid maxillary expansion. Rapid can be a little older age group. Slow maxillary can be a younger age group. But if you do it judiciously, rightly, after the model analysis of that, you can get a tremendous result there. Rapid maxillary expansion and the nasal cavity, one of the famous studies which says that when you do rapid maxillary expansion, you expand the nasal cavity, you provide room for the nasal passage there. And there's a tremendous increase, transverse increase in the skeletal and nasal passage increases there. This is a free article you can get in the PubMed. It's a free PubMed article by Mario. And you can find that this article also says that by expanding maxilla or rapid maxillary expansion, airway improves there. And OSA and rapid maxillary expansion, the next thing that is, it tremendously widens the nasal cavity, reduces the nasal resistance of air intake, improves the nasal breathing, increase the posterior nasal spray. Remember the compartment I told you, it increases that compartment. It reduces apnea. Remember the child gets up. I told you the child gets up and go back to sleep. HI index, that reduces drastically in a rapid maxilla, and good option for patient with OSA. And that is the reference article Perilli and Villa, and reduces the nocturnal enuresis. I told you bedwetting or nighttime, multiple times patient is going into bathrooms because of that reduces. There's a philosophy, there's a reason, physiology behind that, but I don't have time to explain that. It's all been documented there. Timms and Cournot et al. These two famous articles, we can read about it. It reduces nocturnal enuresis there. So the second page, I just sum it up. The second page has the same problem. The child was 9.5 years of age, almost 10 years of age. She's worried about it, and she had a sleep disturbance, academic performance, everything was bad. And mother said, sir, can you do something there? This was a upper arch. And we expanded the upper arch with rapid maxillary expansion, widen it. And now she is almost 15.5 years of age. Perfect. Expansions done. Teeth are erupted normally. This is from her to this is around 6 years of age. When she was 9.5, I started. She's almost 15 to 16 years of age now, with an expansion of the maxilla with the RM is there. All of you know this guy. How many of you know this guy? I'm done. How many of you know this guy? This is a very famous swimmer. Anybody know this person? Can you come to the chat box and tell me who is this person? It's a very famous swimmer in this. Anybody knows him? Nobody knows this guy? Nobody knows. Yeah. Great, Gagan Mohan. At least you're following sports. You are a little into sports. Yes, this is Michael Phelps. He is regarded as one of the pioneer or the epitome where any athletes can reach. Any athletes can reach. Forget about swimming. He's very famous as swimming, but any athletes can reach, because he got 23 gold medal in swimming in Olympics, and his whole life he's got 23 gold medal. Altogether, he got 28 medals in his lifetime, in his career. And you know, Mr. Michael Phelps was attention deficit hyperactive, diagnosed as an attention deficit hyperactive kid at the age of 6th grade. His teacher told, oh, I cannot, please take him out. He cannot concentrate. He scribbles there. He does a lot of nasty things in the class. He can't write properly. He cannot focus. So please take him out. That was the class teacher told the mother when he was in 6th grade. And look at this things that has happened. If you look into him, he has got all malocclusions which I have told. Long face syndrome, constricted maxilla, vertical growth, retroclined anteriors. He is a mouth breather. If you check the internet, you can see his picture. There are very few pictures where he closes the mouth. Rest of all the pictures, he opens the mouth. His mouth is open posture, tongue low posture. But how did he has become? He has become the boss in his field. I went into research. I went into his entire history, and amazed to find out that his regular follow-up, regular effort. You know, when he was in 6th grade, when the teacher told this, his mother used to take him and he used to spend 6 hours in the swimming pool. 6 hours a day, constantly swim, put his head down in the water, and he used to develop a resistance to carbon dioxide. Reverse. That is what he did. He knows that he has got limitation because his mother doesn't have money to spend to expand the maxilla, to do this orthodontic treatment. He didn't have the money to do it. So he understood his limitations. But what he has done is experience, trained, spend more time, and he overcome his limitation. And finally, the researchers found out that he has got a high resistance to carbon dioxide. That means his body has developed resistance to carbon dioxide, so that when he put his head down, no oxygen goes in, but he can survive with that limited amount of oxygen, and carbon dioxide doesn't create any effect on him to open the mouth there. This is a motivational thing. This is not happening for every kid we see that. Please, that is not our patient. He's a motivation. Just tell you that things like this is also there in this world. But our kids cannot survive that. Our patients who cannot do that type of, so we have to be forefront in identifying that because this is unusual. It's a superhuman being. Salute him, superhuman being. That's how he is there. But every patient who is in your chair are not this. This proves that if you do not, if you have carbon dioxide in your body, you have to open the mouth, and you might go into that mouth breathing syndrome, and all those factors will cause you if you are not a superhuman. But our all patients are not superhuman, so we have to treat them. A person was crossing across a river, and suddenly he found out that he has got a leak in his boat. He ignored it. Oh, it's a small leak. What is going to happen? I just cross the river and go. My life will be continued there. But when you reach almost the center of the river, what happened is the leak increased, and entire boat along with him capsized, and he's drowned. So my take-home message is use treat the root cause, not the condition. Mouth breathing can appear as dental problem, skeletal problem, facial problem, but find out the root reason and assess is that. So thank you so much. This is my college where I'm so honored and privileged to work here with the entire team Anurian, and this is our department, entire team. We work as a team and we improvise the best that we can give to the patients. Thank you so much and welcome to Anur at any time.
Thank you so much, sir. That was indeed a very interesting talk. And we have a few queries. Sir, I'll just read it out. So the first question is, how can you confirm that if there is an upper airway obstruction?
Okay. Is it, my sound is echoing? Okay, your sound is echoing through that, I think. Doctor, I'm fine. Can I answer that?
Yes, sir. Yes, sir. Please proceed, sir.
To confirm the upper airway obstruction, as I told you, one way is a lateral stuff will help you. We have a upper airway analysis by Dr. McNamara's analysis, which can be done. But what I suggest you is an ENT and endoscopy can be a confirmatory diagnosis along with that, where the adenoids, the endoscopy will really show you the adenoids are swollen or obstructing there. And even there are grades on that. Please don't just follow up with that. There are grades. They have a grades like a plus, like that. There are mild, moderate, and severe. And if depending upon that grade, then only they will recommend a treatment of adenoidectomy or whatever it is. Because even if you do adenoidectomy, there's a higher chance that you can grow back again, because again we are exposed to the same environment. There is no change in the environment, so remnants of that will be there. It can again grow back. So the catch is that if there is a adenoid obstruction that you find, if it is upper airway, important thing is the dentist and the ENT doctor should work in tandem and see that we can remove, even avoid an adenoidectomy, or with conservative management can. I always go for conservative management. Try to do these exercises for a month or 3 months. If it doesn't work, then again go back to the ENT. ENT said, Dr. Joby, I don't think so the patient can do that. And sometimes you can do a sleep study and the pulmonologist says, Dr. Joby, he has got a very disturbed sleep also. So why don't we remove that? It's a developing stage. We take the confirmatory call by combining all those 3 factors there. So there is no one cut rule saying that in SUF you saw this, in endoscopy you saw this, that's upper airway obstruction. No way. You have to combine a composite analysis by taking in all this disciplinary, multidisciplinary one and you should tell about it.
Yes, sir. We have another question regarding the diagnostic methods to find out the mouth breathers. So
Oh,
could you-
diagnostic method to find mouth breather. There are so many, the water holding test was one of there's so many tests that you hold the water. But there are a lot of flaws in this water holding test is because you are doing this test on a child. So if you do this test on a child in a new situation, the psychology is important here now, because the child will become either conscious or child become a little more scared or anxious and he might spit. So you may never get a correct value there. So we have something called this lip seal exercises, which I've told you as a protocols are there. And we give them a chart, a weekly chart, we tell them, and we report us back and we evaluate it. And we get more acquainted with the child and make the child feel confident and tell the child to do, and that will be more accurate way to assess, especially for a child patient, to do this mouth breathing test.
Sir, we have another question on how long we need to give oral screen and other devices to treat mouth breathing.
If you look into this patient, which I've told you, she has been using it for 18 months. She was using it for 18 months, one appliance called vestibular screen. Now, there's a difference. Now, many times we see oral screen doesn't, and vestibular screen are actually equal, but you should take an impression where the screen edge just goes into the vestibule. This is exactly what has happened for this patient. And 1.5 years time, actually, I kept the muscles away, did the exercises, and really brought the maxilla and mandible safeguarded from the extra oral the muscles and developed it. So 1 year to 1.5 year proper exercises. According to the Myofunctional Society, they say 18 months to 20 months is regular required for any myofunctional exercises to be established properly and to get a result with these exercises.
Sir, also the most common treatment modalities for adult mouth breathers.
Adult mouth breathers, let me tell you, you need a different protocol because this kind of screen and all will not work for adults there. There comes counseling and what is happening. The screening form is very important, and note it down. What is the reason for the mouth breathing there? And the model analysis is very important. Sometimes I have given even a slow maxillary expansion for a 45-year-old also, and I found out I just a little bit expanded the mandible, the maxilla. And what I've done is, along with that, just train the tongue to be on high posture. So given enough room for the tongue to go up, hold the tongue at forward position. And this patient, even though was a mouth breather, concomitantly, the patient had infantile swallowing pattern or a milder form of tongue thrusting was also there. So we diagnosed both that and trained both. And now the patient is in a appliance where tongue training and mouth breathing is done. So once you find out the cause, then this adhesive tapes which I have shown you works wonder. Many times this lip seal exercises and breathing exercises. So please try to understand that patients are busy with their routine practice. They have hectic schedule, stress on them, IT field or whichever field, business field, whichever it is, they have stress. I've seen and experienced it. So you need a little more compassionate, feel that I have come to a family where the doctor understands me, because habits, if you want to break, you have to take them, feel them that I've come to a family where this doctor understands me. He is not mechanical. He is little more connected to me. So that plays an important role in breaking any habits, because it's a deep-rooted habit. Mouth breathing, tongue thrusting, anything it is. You need that connection with that patient and the family there. And adults, it works wonders. You don't need huge appliances to do that, but these connections can really change the patient's perception, and he will try to put an effort to break this habit. And then appliances are assistant. It's like a reminder. Our dentistries, our forefathers have done it like this. They trained them first, then gave the reminders appliances, whatever it is, you can do that.
Thank you, sir. That was indeed a very wonderful session. And up next is a valedictory function, and we are moving on. And we have a chief guest for the day, Dr. Lisa George, the dynamic vice principal, Anu Dental College and Hospital. We welcome you, ma'am, to this valedictory session. Proudly introducing the chief guest for the day, Dr. Lisa George completed her BDS from Ragas Dental College, Chennai in the year 1996 and MDS in Conservative Dentistry and Endodontics from the prestigious Tamil Nadu Government Dental College, Chennai in the year 2002. She has successfully completed her fellowship in Comprehensive Cosmetic Dentistry in the year 2016. And she is a faculty of Department of Conservative Dentistry and Endodontics in our institution since 2003. Since then, she's successfully training the MDS students of our institution. She has more than 30 indexed national and international publications to her credit. She is a member for the ISPRP, the Indian Society of Prosthodontics, Restorative and Periodontic Society, member of IACDE, the Indian Academy of Conservative Dentistry and Endodontics, and a member of CAESOK, the Conservative and Endodontic Society of Kerala, and a member of the Indian Dental Association, Malanadu Branch, Kerala. She is an editor for the Malanadu Dental Journal, the official publication for the IDA Malanadu branch, and a member of Review Board of Conservative and Endodontics Journal, the official publication of CAESOK, the Conservative and Endodontic Society of Kerala. And she was a faculty for numerous continuing dental education programs nationwide. And she has a particular interest in microscopic endodontics and aesthetic dentistry. Very proud to welcome you, ma'am, to this valedictory session of Horizon Unlimited, the virtual international conference. Welcome, ma'am. Now, we have an exciting announcement for the best college with maximum number of registrations for the program. Any wild guesses? Yes, obviously it's Anu Dental College and Hospital, but since we are the hosts for this program, we'd like to acknowledge the second and third colleges. The second college with the maximum number of registrations for the program is Malabar Dental College and Hospital, Edappal. I'd like to see if there are any representatives from Malabar Dental College. Kindly raise your hands if there are. Okay, I think there are no representatives. We shall move forward. And may I now invite Dr. Lisa George to present the certificate to Malabar Dental College for the maximum number of registrations for the program. Please. Congrats, Malabar Dental College. Now announcing the third maximum number of registrations for the program. The college is Assisia Dental College and Hospital, Kollam. Ma'am, could you please present the certificates for the maximum number of registrations? Congrats, Assisia Dental College. We are now moving on. May I now invite Dr. Binu, CEO, Online Dentistry, to speak a few words. I introduce the speaker, Binu. The Online Dentistry is a dental education firm which is celebrating its 13th year of establishment in the year 2021. With over 20,000 followers cross-platform and having successfully completed 500 plus webinars during the pandemic, it is a one-step solution for all the dental education requirements. We proudly invite you, sir, to address the gathering. Over to you, sir.
Hello. 3,000 odd delegates, 2 days of knowledge-packed session. Guys, virtual dental conference is the way to go. We at Online Dentistry is extremely happy and proud to be associated with Anu Dental College. Actually, I thank Anu Dental College team trusting us and giving us this technical support of this virtual conference. And I hope and pray that we did justice to the job given to us. And we are not stopping here. In association with Anno Dental College, we are planning full programs on endodontics, pediatric dentistry, and even Aparna Ma'am's Recalibrate and Reboot program, one full day planned under the platform. Thank you so much for the support shown to online dentistry. And thank you so much for this kind of huge registration numbers. 3,000 odd is not a joke. And we are not stopping here. We have planned hybrid versions also coming up soon. So I think hybrid is the new terminology coming up. We are planning that one hybrid next month with people seeing us offline as well as online all around the world. That's also being planned. Anyways, I take this opportunity to thank the entire team of Anno Dental College and online dentistry, working 24/7 for almost a month now, maybe more than a month, for the success of this program. Thank you, one and all. Have a safe day. Bye.
Thank you so much, sir, for your words. With this, we are winding up, and I request Dr. Pradeep to take over for the vote of thanks.
Good evening, everyone. No duty is more urgent than that of returning a heartfelt thanks. The success story of this international virtual conference are our esteemed speakers who enlightened us on both the days, taking their time from their busy schedules. I sincerely thank all and each one of them, Dr. George Paul, Dr. Jiju George Baby, Dr. Jose Paul, Dr. Vivek Hegde, Dr. Mohan Bhuvaneshwar, Dr. Aparna Pandya, Dr. Manu Jones, Dr. S. Karthikeyan, and our own Dr. Joby Peter. We are greatly indebted to the management of Anno Dental College and Hospital for rendering us all the support and encouragement. And a special thanks to our Administrative Chairman, Advocate T.S. Rashid sir, and our CEO and Director, Mr. T.S. Binyamin. We wholeheartedly thank all the delegates for their overwhelming response, logging in on time, making this conference a grand and meaningful one. On behalf of the faculty and management of Anno Dental College, I extend sincere gratitude to the one-stop destination for dental education requirements, online dentistry. Last but not the least, I salute the spirit of Team Anur. Wholeheartedly thank all the members of teaching and non-teaching faculty, students of Team Anur. Yes, we proved we can. Thank you all. With this, we are concluding the sessions, wishing you all a safe and healthy times ahead. Thank you.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Participants, please note, all your certificates of participation will be sent to you to your respective mail IDs within 7 working days. Check both your inbox folder as well as the spam folder. If not, it can be addressed in the WhatsApp group. Thank you. Thank you all.